Check. Check.
Just a second, one picture, please. ऐसे क्या? Thank you so much.
Your internet connection is not stable.
उधर जा उसको जब पूरा
इसका आवाज बंद हो गया वापस। एक मिनट
सांगायचं की आवाज येतोय का नाही फक्त बोल बाकी काय नको बोलू
Hello, hello.
हाँ वेस्ट नहीं लीलावती हॉस्पिटल के पीछे है ये
Good morning, friends. Hello. Check, check. Ganpati Bappa Moria. Hello. Okay. Well, good morning, friends, to the second day of Super Specialty Lens Symposium. Yesterday, we spent a lot of time in discussion, and of course, that helped, but we got short of time. So the one lecture that was left, we'll take it in the evening, but let us start with the Scleral Sunday today. So all about scleral lens and interesting topics. So our keynote address speaker is Melissa Barnett from US. She has written so many books. She and Tom conducts ICSC, that is the only scleral lens conference, 2-day conference, happens every year in Hotel West in Miami, Fort Lauderdale actually. That is the best conference. If you really are interested in becoming specialist in scleral lenses, you must attend that. Another best conference for all specialty contact lenses, GSLS. That happens every 1 year in January in Las Vegas, every year. And that is the best ultimate in anything, that all the latest technologies in contact lenses, you will get to learn there. So save your money and attend these 2 conferences. Even if you attend once, then you will feel like attending every year, because even if you attend every year, you learn something new and different. That's how even I got my knowledge and understanding. It's amazing. Of course, you learn and then you practice. Unless you practice, it is not going to help you. Okay. Yeah. So, Melissa has sent me the presentation on a pre-recorded video that will run now.
Hello, I'm Melissa Barnett, and I'm thrilled to present this lecture on keratoconus titled Caution, Steep Hill Ahead, Keratoconus in Clinical Practice. According to the 2015 Global Consensus on Keratoconus and Ectatic Disease, certain findings are needed in order to diagnose keratoconus. Those are abnormal posterior ectasia, abnormal corneal thickness distribution, so global pachymetry, and clinically non-inflammatory corneal thinning. In keratoconus, we commonly see askew deviation, corneal curvatures that are steeper than average, even more than 46 diopters or 48 diopters, a steepening in one meridian compared to another, abnormal posterior shape on OCT or corneal tomography like the pentacam, abnormal corneal thickness, and that non-inflammatory thinning. So keratoconus is much more prevalent than we previously thought, and fortunately is getting more attention in recent years. So whereas before, many years ago, patients would need a corneal transplant, now we have corneal collagen cross-linking, so we can halt progression earlier and sooner than ever before. I love this picture here at the bottom middle. For all of his career, his life even, Steph Curry has had issues with his eyes, and he has a condition called keratoconus. So that's in the popular press. Lots of people are seeing this. Now, there are many different studies that are out there. So as previously thought, 1 in 2,000 had keratoconus. But if you really look at all the different studies in different populations, mind you, and also different methods of gathering data, the prevalence of keratoconus can really be much closer to 1 in 375 people, 1 in 84. There's currently a study going on in children in the US for keratoconus, and I'm really excited to see what the prevalence is going to be in that study, but I think it's going to be really very highly prevalent. So when we look for keratoconus, we definitely see it, and we can see and find and detect keratoconus even prior to corneal findings such as these. So you can see the normal cornea, the form frus kind of irregularity there on the second image, the nipple cone, the oval cone, the globus cone. So there are many different forms of keratoconus. We also know that there are many comorbidities with keratoconus, so things like allergies and asthma, eye rubbing, sleep apnea, collagen vascular disease, Down syndrome, diabetes, mitral valve prolapse. So we can ask our patients if they have any of these conditions, especially the allergy component and ocular allergy, to diagnose keratoconus even earlier than before. I kind of like this study on eye rubbing and keratoconus. So we know that chronic abnormal eye rubbing, and this is not just the gentle eye rubbing, this is the really vigorous eye rubbing that we see. And that knuckle grinding rubbing is associated with the progression of keratoconus. This was a study done by Rabinowitz, a case control study of more than 200 patients with keratoconus, 183 healthy age-matched controls, and found that eye rubbing is present in 83% of those with keratoconus compared to normal controls. Now, some of the comorbidities that I mentioned, including Down syndrome, Marfan syndrome. So here you can see an image of Abraham Lincoln, who is classic for Marfan's with a wingspan greater than the height, long and slender fingers and toes, hyperflexibility of joints, and a long, narrow face. And these are also things to ask patients for when diagnosing. There are many studies on pregnancy and keratoconus. Just one here. This was a study that looked at women who became pregnant, and 100% of eyes in the pregnancy group experienced significant progression of keratoconus. None of the control eyes had any sorts of disease progression, and there was no reversal after pregnancy. So this is important to stabilize the cornea. We should be stabilizing the cornea with corneal collagen cross-linking prior to pregnancy if possible, but asking our patients about these conditions. Now, we can use various tools to measure the cornea. We do have the capability, fortunately, to also measure the posterior cornea. So corneal topography is a great tool to measure the anterior corneal shape. Corneal tomography is just impressive and magical to measure changes in both the anterior and the posterior cornea for changes and irregular astigmatism. And we have really helpful software which can help us make the diagnosis of keratoconus earlier than before. We can also check epithelial thickness on anterior segment OCT measurements and epithelial mapping with some devices. The epithelial distribution in eyes with keratoconus follows a specific pattern, so it can help identify patients earlier than before. And why is that early diagnosis important? It's so much better to prevent than cure. So when we can diagnose early, we can manage early. We can use corneal collagen cross-linking to strengthen that cornea to really help prevent progression. Avoid a corneal transplant, which is very important. And also think about the economic burden of keratoconus. There are many studies that are out there that show in the thousands of dollars per year, just supplies and things like that that are needed. Say a patient who has keratoconus wears contact lenses. It is an economic burden, but also just look at the psychological burden of the disease. And there are studies that indicate that if in more advanced disease, there's more of a burden than in less advanced disease. So I'd say diagnosis early is really important. So the old mantra was to diagnose patients, kind of monitor or watch them for many years, fit with spectacles or contact lenses, and then need a corneal transplant, and in some cases, a full thickness corneal transplant. Now, fortunately, the new mantra for keratoconus is to diagnose early, to stop and prevent progression, to rehabilitate vision with a number of different ways, and avoid a corneal transplant, especially full thickness. So let's talk about what's new in keratoconus, and this is so exciting, and that's genetic testing. So genetic testing just in general out there in the general population is becoming more and more popular. If you ask just a group of people if they've had genetic testing, half or maybe even a majority will say yes. So in the US, the numbers are just going through the roof on how much money is spent. Again, this is just genetic testing in general. And by 2027, it's expected to reach a US dollar of 231, 43, 42 million, which is absolutely just mind-blowing to me, with a compound annual growth rate of 11.5% over that forecast period. So genetic testing, huge interest in general in genetic testing. And the CDC gives certain reasons for why we might do genetic testing. Again, this is just in general. So genetic testing can be used to determine if a genetic condition runs in the family prior to symptoms. So think about cardiovascular disease, for example. You can have a person who's quite healthy, they eat right, they exercise, and they have a family history of cardiovascular disease. So they do these modifiable factors and have a healthy lifestyle in order to prevent disease, versus a patient who has, say, a family history of cardiovascular disease and eats poorly, does not exercise at all. They're much more at risk for that cardiovascular disease. Also, reasons for genetic testing is just to learn about the chance of current or future pregnancy that might have a genetic condition. So that can be used for family planning, to diagnose a genetic condition if a child has any symptoms, so used diagnostically, and also to understand and guide cancer prevention and to develop treatments. So that's really just impressive in the cancer world, to develop specific treatments for the cancer based on genetic testing. So here you can see, you don't have to memorize this at all, but all the different conditions out there used in pregnancy, family planning, and also just used in children and for conditions that can be diagnosed. So for those of you who haven't reviewed genetics in a while, the genome is just the whole entire sequence of the genes. The genotype is an individual's complete DNA makeup. Genes have specific DNA nucleotide sequences, and a phenotype is an individual's physical manifestation of those genes. So a mutation in a gene can cause disease. So monogenic, you can just think one only. So one single gene mutation can cause disease. It's either positive or negative. So an example here is cystic fibrosis. You have it or you do not. Versus polygenic, where multiple gene mutations or variants are correlated with disease. So a risk analysis, so that cardiovascular example could be one of these. Obesity, diabetes, heart diseases, these are all polygenic conditions. And now, what about in eye care? There's so much going on, not only in the front of the eye, but also in the back of the eye, specifically retina and glaucoma. So in retina, there are many different conditions where the genes are now being determined and developed. There are studies that are using this genetic testing for future treatments. And in glaucoma, just recently, this last year, many new genes were discovered for glaucoma. So this is a really interesting and evolving field in eye care, which is quite exciting. But I think it's most exciting for the front of the eye. So we now have genetic testing for keratoconus and also for corneal dystrophies. And in the US, this came out just recently, and it's called the Avogen test. So this is a test that can actually help you manage patients to detect keratoconus and cornealtasia even earlier than any of those previous ways and methods that I mentioned earlier in this lecture. So we can identify the risk of keratoconus and the prevalence of corneal dystrophies. We can use this data and this information along with environmental factors and genetic information to detect patients, even those who are asymptomatic, early, and we can confidently make decisions about patient management and treatment. Now, let me just tell you how I'm using this in my practice, because I have so many people who have keratoconus. And so I'm talking to them about genetic testing, that we have this option. And it's important, as we know, for all family members of those with keratoconus to have eye exams. But I'm talking to my patients and talking about their kids and their cousins and their relatives, that we have this option for genetic testing, and they are so incredibly excited. So it has been helpful to pick up keratoconus, or even pick up the risk factors associated with keratoconus, in addition to everything else, to manage earlier than ever before. So we know that assessing keratoconus is multifactorial. So it's not just this one test at all. We want to ask our patients if they have allergies, if they have a history of eye rubbing, if they have any sort of abnormal measurements in topography or tomography, or even retinoscopy, so checking retinoscopy to see if there's a scissors reflex. If there's a change in prescription and refractive error, so an increase in myopia and astigmatism and or astigmatism, if there's an abnormal OCT, and of course, if there are corneal findings on the cornea, then we can diagnose keratoconus or corneal ectasia. But this test can identify 75 genes, more than 2,000 variants, and it's just one more tool in our toolbox to diagnose patients earlier than ever before and manage them earlier as well. So let's talk a little bit about this test and how it works. So looking at all the literature, this is a really helpful slide here on primary literature references and documentation of known keratoconus genes and variants. So there are multiple genes that are out there and available. And this is also an evolving field where more genes are being detected and determined now, currently, actually just right now, as we're talking about it. So this specific test, as I mentioned, has the 75 keratoconus related genes, more than 2,000 keratoconus related gene variants. The TGFBI gene is a monogenic, so yes or no for corneal dystrophy, and 70 of those TGFBI gene variants. So it gives a yes/no for the corneal dystrophy and gives a keratoconus risk analysis for keratoconus. So you might say, well, how do you actually perform this test? And the beauty of it is that it can be done on anyone. It could be done on a child. It could be done on a teenager. It doesn't hurt. There's no blood, no pain, or anything like that. So it's a swab that is taken, and the swab is in a suspension. It's a sterile swab, so it's important to rinse the mouth, not to eat 30 minutes prior to the test, and actually to take the swab and just rub it on the inner cheek of the mouth, 20 to 30 seconds, just move it around, and then take the swab, put it in the vial, twist it, shake the tip in solution, and to do that 4 times for one person for one test. Then the test is mailed off. The results come back within a few weeks. And the beauty also is that genetic counseling is available. So I personally have done this test and it doesn't hurt. It was quite easy. I got my results back within a few weeks. Fortunately, I do not have keratoconus nor corneal dystrophy. So what does the test tell us? So first of all, it gives a summary of the risk for keratoconus and the diagnosis of corneal dystrophy. It also gives a risk score on a green of good, there's no disease, to a red of high risk. So the keratoconus risk assessment, explanation of the polygenic risk score, and interpretation of that. So it gives information about the specific genes for the keratoconus polygenic test details. Here you can see on the right-hand side, and then the corneal dystrophy, again, the monogenic is a yes, no, and gives information there as well. So here you can see the test a little bit easier. This is a patient who did the test and has a high genetic risk. The risk score is 95, so that is very high, and that's a polygenic risk score. And then for the TGFBI, it's also positive in this patient, and it gives details of the variant. So this is what the genetic test looks like. This is what goes to the patient. So here you can see on the risk assessment, 95 out of 100, extremely high, and gives all the genes that are associated for this patient as well, and gives the following corneal dystrophies, the TGFBI corneal dystrophies that are associated with keratoconus. Now, the beauty of this is genetic counseling, because we're not geneticists, we're not trained specifically in genetics, but we can take this information and us as doctors we can talk to a genetic counselor. And I've talked to the counselor, they're very, very helpful. And they can help with the information. So they're giving us additional information about the specific genes for the polygenic risk score. And this can be used as needed. Now, for patients who have more questions, because they might have a lot of questions, the genetic counseling is also available for patients. And no private information is given. The genetic counselor is not recommending a specific treatment or anything like that for the patient, but they're giving them specific genetic information from a trained geneticist about what the test means. So I find that to be very, very helpful. So when do you even think about ordering the test? Now, it can be for a variety of things. One, family history, definitely. Anyone in the family, or if a partner is interested in having the test who does not have no personal history of keratoconus nor corneal dystrophy, but say they're interested in having children, this could be an option. Any sort of red flag, so concerns on the cornea, the topography may look a little bit funny or not so regular. There could be some against the rule astigmatism, maybe a little bit of irregular astigmatism or a change in astigmatism, but also have caution if there's an increase in myopia and astigmatism. You want to rule out if this is just simple myopia or if it is some sort of keratoconus. Thin corneal thickness, checking with pachymetry or global readings with corneal tomography. Any sort of unstable refractive error or reduced best corrected vision, especially if you saw the patient a few years ago, their vision was quite good, and then they come back, their vision's reduced. A steep corneal curvature, so over 46 diopters, would also be for concern. Now, for those who do corneal surgery, some of you in the audience, any sort of pre-existing refractive surgery, LASIK, PRK, whatever it might be, if a person is young with a prescription that is changing, any sort of family history of any sort of corneal dystrophy, or when deciding between LASIK and PRK, this can also be a very helpful tool. So when we're looking specifically for keratoconus, we can use genetic testing as part of the whole entire picture. We want to ask our patients about ocular allergies, any sort of eye rubbing, and also to manage the ocular allergies and counsel to avoid eye rubbing, flip the lids to look for floppy lids. Ask about atopy, any atopy or atopic dermatitis on the skin, any history of asthma, sleep apnea. Definitely a family history is very important, and any sort of genetic disorders or a family history of genetic disorders. These are all really important things to ask about. So genetic testing and this data can help us pick the appropriate management strategy for our patients. It can help prevent progression, really to improve our patients' quality of life, not only for themselves, but also for their families too. So it's an exciting time in keratoconus. We're able to help people much more than before and counsel them and to provide the best treatments and management strategies out there. So I do want to thank you for your time and your attention. Please feel free to visit my website. I look forward to seeing you one day in person. Thank you again.
We're not able to hear you. Okay. I think that was a very interesting talk, right? Genetics has been a real interest for everyone, I think. The first thing when I did, when I was in the US, first thing I did is I did my own genetical testing, 23andMe. There are so many other genetical things, but 23andMe is one of the best. Same thing, you just have to take your swab and send it to the lab. They'll give you everything from where you came, where were your forefathers, whether you have a balding, you have, you know, the nose, the cut here, your features, it's really amazing. And now this particular test, what she was talking about, is specially for keratoconus, because okay, you may think it is very popular among the LASIK surgeons. See, post LASIK, there are so many chances that okay, after LASIK the keratoconus may show up, right? There are so many cases. So this is the best way. And US is a litigative country, you know, like if anything happens, they are going to sue. So this is the best way to rule out that he is not a keratoconus candidate, so it's good to do any other procedure. And if he's a keratoconus, of course, avoid eye rubbing. You can't do much if it is in, but you know, manifestation can be managed a little bit. So that was quite interesting. India is very expensive. It is there. See, the best part of India is you get anything, whatever is available in the world. Medically, India is at par with the world. In fact, Indian doctors are very famous in the US. If you go to American Academy of Ophthalmology, you know, the Indian doctors rock the whole show. Of course, there are so many other doctors also, but they are really genius. So there is nothing when it comes to operation theater, it's same. So all testing, everything, money wise, it's little, you know, difference. 72 you into $72. So that's quite interesting. Let us go. Today we are not going to talk much, and then we'll talk in the evening too much. Okay. So let us not repeat the mistake we did yesterday. Let's go into our next talk, that is Karen. See, now it's 12:30 in the night, so they could not join me. Shalu Pal is from Canada. She's still awake because she'll be giving her lecture in person. So she's still waiting. So let us go quickly through this, and then she will join us. So Karen is going to talk. I requested her to speak on Boston fittings, Boston side scleral lenses, how to fit and other thing. Because whatever speakers are there in India talks about Boston side, they don't talk about how to fit. They'll just talk how good it is. So I requested her specially to give a practical tips and all. So let us hear from the horse's mouth. Uh-oh. Share Ernest, please. Presentation. तो वीडियो अच्छा था
Greetings, everyone. My name is Dr. Karen Carrasquillo. I'm the VP of Clinical and Professional Affairs at
चालू है सर अच्छा नहीं वीडियो
Greetings, everyone. My name is Dr. Karen.
प्रेझेंटेशन व्हिडिओ व्हिडिओ ना तो व्हिडिओ दाखवतो ना तुला तो तू ओपनच नाही करत त्याच्यामध्ये प्री रेकॉर्ड हे भाई ओपन कर
Greetings, everyone. My name is Dr. Karen Carrasquillo.
Okay, so by the time they fix this issue, you have any questions on the previous talk?
Greetings, everyone. My name is Dr. Karen Carrasquillo. I'm the VP of Clinical and Professional Affairs at Boston Site, and I would like to thank the Super Specialty Lens Symposium for the invitation to speak to you all about fitting Boston Site scleral lenses. So just as a mode of introduction and to start, talking to you a little bit more about Boston Site scleral and this lens design. Boston Site scleral was the first lens design that leveraged fitting data from thousands of patients to produce the first data-driven lens design in the market for a more efficient and more predictable fit. It has a wide range of smart features we're going to be speaking about today, and the diameters range from 16 to 19 millimeters. Aside from this wide range that are actually available in two individual fit kits. One fit kit contains the 16, 16.5, and 17 millimeter designs, and another fit kit contains the 18, 18.5, and 19 millimeter designs. We also have a free-form feature called Smart 360. So truly the power of data and science and leveraging these two when designing a scleral lens is that we are able to navigate and identify patterns of scleral shape and patterns of corneal scleral shape and build those in to these trial lenses so that when you have built-in squadron-specific haptics and built-in oval optic zones in this way, you're really able to achieve improved centration and better fitting endpoints to obtain a faster fitting as well. Amongst the data-driven features and the smart features we're going to be speaking about today, aside from the built-in oval optic zones, we're going to be talking about smart site technology, smart channel technology, and our free-form feature, Smart 360. And when it comes to Smart 360, this free-form image-guided approach to fitting is for all of you who like to leverage technology and have access to technology. Currently, in this case in particular for Smart 360, if you have an Euclid Eye ESP or an Oculus Pentacam and you have the CSP software. The importance and benefit of this is that truly independent of the instrument that you're using to obtain your scleral shape data, it could be the Euclid-I ESP or the Pentacam CSP, you can use this image-guided approach and obtain this data from these devices, push this directly through Boston Site scleral design platform, which is FitConnect, and from there directly to the Boston Site manufacturing lab for manufacturing. And you're able to obtain fitting endpoints like this from the get-go. This is an example from the first lens output from an 18.5 millimeter Smart 360 freeform design. And it's more to call out that this is available in all diameters in 0.5 millimeter steps, all the way from 16 all the way to 19. But truly the power of leveraging data and science for Boston Site really goes beyond the fit. And something that Boston Site has been leveraging since the early 90s is smart site technology, and is the ability to change the front surface eccentricity in the optic portion of the lenses for aberration control, so that we not only are able to improve quantitative aspects of vision, but also, and very importantly for our regular cornea patients, our qualitative aspects. But beyond aberration control, which is actually very powerful to have aberration control because it's available at your fingertips in these different fit kits, and you don't really need to use special instruments and equipment or invest in these. We do also provide custom HOA correction with our SmartSight HOA technology platform. It's important to call out, we're going to be talking about how to do this in a second, but based on our data, Boston Sight's data, and continuing to analyze the data, over 90% of patients actually achieve optimal vision for both quantitative and qualitative aspects of vision with the built-in value FSCE1. But we're going to be talking about, you have other two options that you can use. Amongst the smart features we mentioned was smart channel technology. And smart channels, you can use them to vault anatomical obstacles. I'm sure this is an application that most of you are familiar with, but there's a different application, and is a very powerful application, use of smart channel technologies. We're patent holders of this technology, and is that we can design these channels in a very unique way to reduce suction and promote tear exchange without necessarily increasing tear debris to the reservoir to improve physiological endpoints, especially for your ocular surface disease and compromised corneal surfaces. So now that we've gone over a general overview about the lens, let's just get started with the fitting. The first thing that you're going to do when fitting a Boston Sight scleral lens is decide, what diameter am I going to choose? You have all the way from 16 to 19 millimeters. Following this slide, I'm going to discuss a few parameters that you should follow when determining what diameter you're going to choose, but ultimately you know your patients best. So you first determine what diameter you would like your patient to be fitted in, and from there, you're gonna then study this simple fitting algorithm. As a data-driven design, when Boston Sight sought to design this lens, the notion was to also come up with a simplified fitting algorithm, one that did not require special calculations or numeric inputs, but just a very simplified approach. Our data-driven analysis identified three basic or general scleral shape patterns. The standard scleral shape pattern, over 70% of patients are able to be fit with this standard scleral shape. And so we recommend that regardless of the patient's condition, regardless of the diameter that you're working with, that you start in the center of your fit kit in the teal lens, which is your standard scleral shape. And very simply, if your standard scleral shape is too loose, then you move to the right of the fit kit and you apply the lens with the steep scleral shape that has more toricity added to each of the individual quadrants in a quadrant specific manner. And if the standard scleral shape is too tight, if you see impingement all throughout, then you move to the left of your fit kit and you choose the lens with the flat scleral shape. It's a scleral shape that has less toricity added in each of the meridians in a quadrant specific manner. As a way of determining in which fit kit I'm going to live in or reside, we recommend that the 16 to 17 millimeter fit kit is a great choice for patients with smaller HVIDs, smaller apertures, tighter lids, pediatric patients for sure, patients that have difficulty with handling the lenses, or regular cornea patients. For the 18 to 19 millimeter fit kit, we recommend to use those for highly ectatic corneas so that you can distribute the weight. These are very tall lenses, and that way you can distribute the weight of those lenses over a larger surface area. Your patients are going to thank you for that. For patients that have large HVIDs, compromised or fragile grafts, compromised ocular surfaces, cases of chronic exposure, where you not only want to protect the cornea, but definitely protect the conj, because we know that desiccates as well and is part of the ocular surface, and for severe dry eye patients. As a data-driven lens, it is actually the first lens to have right eye lenses, so anatomical shapes for the right eye, but also anatomical shapes for the left eye. So when you open your fit kits, either the 18 to 19 or the 16 to 17, you're going to see right eye fitting lenses and left eye fitting lenses. And all lenses are laser engraved for an easy identification. The first letter is the lens set series. You're going to then followed by the eye, so R or L for right or left eye, followed by the diameter, 80 for 18.0, 60 for 16.0, and so forth, followed by the lens number, either 1 to 12, and the E value, E1, E2, or E0. And you're going to be able to see that engraved in this manner. So this is an example of the 16 to 17 millimeter fit kit. These are lenses shown for the right eye. As you can see, lenses are numbered, so it's chronologically. This is 1 through 9. These are the main fitting lenses. We're going to see the 10 to 12 lenses in a minute and how they come into play. But as I said earlier, the first thing that you're going to do is choose your diameter. Depending on the diameter, you'll know in which row of the fit kit you're going to live. If you wanted to fit someone in the 17 millimeter lens, you're going to live in the top row. Or you're going to start in the center in the teal. And if your standard scleral shape works well, you're going to use this as your fitting starting point, and you can go to Fit Connect and tweak the lens design as needed. If this is too tight overall, we recommend that you move to the left of the set for the flat scleral shape, as I mentioned earlier. And if this is too loose, you have too much edge lift, there's bubbles coming in, the lens is decentering, then you move to the right of the set and you put the steep scleral shape. All of these lenses have a built-in initial sag value based at a 12 millimeter cord, 2.6, 2.8, or 3.0. In Fit Connect, you can then decrease this sag as needed for each of the diameters. But if when you start with any of these lenses, you see touch, each fit kit for each eye provides for each diameter, one additional lens. This is where the 10, 11, and 12 come in. These are additional lenses with a higher sag value, over 400 more microns that are added so that you can start your fitting endpoint. So these lenses you're going to use only if you need to. Otherwise, you're going to reside in the main fitting lenses, which is 1 through 9. As mentioned, all of the lenses have a built-in E value of E1, and over 90% of patients do well with this built-in value. But if your patient is one of those that is an outlier and the E1 doesn't reduce ghosting or creates ghosting or reduces glare or doesn't reduce glare, as a rule of thumb, you have two lenses that are not meant for fitting, but rather just for over refraction. So in Fit Connect, you can choose either E0 or E2 if these are better, and then provide the over refraction obtained from one of these two lenses and then carry out the fit that way. as a general rule of thumb, if you're working with an irregular cornea patient, if the E1 is not working, we recommend that you start with the E2 with a higher eccentricity and then over-refract before you try the E0. And if you're working with a regular cornea patient and the E1 doesn't work, we recommend that you start with the E0 first and over-refract before you attempt the E2. So the only thing that you would need to do is notate which lens you're going to use to start the fit, 1 through 9, and then in Fit Connect, from the drop-down menu that you'll find, you choose which eccentricity you're going to use, either E0 or E2, and then enter the corresponding over refraction. It's worth mentioning that our lenses are dotted for identification purposes. 1 dot is right eye, 2 dots is left eye, and that each of the meridians are easily identified with an engraving system of 1, 2, 3, 4 that are numbered chronologically for easy identification. So if you needed to tweak one individual meridian in Fit Connect, then you can either flatten or steepen as needed, and just by looking at the meridian number. So now that we've gone through this overview on how to fit Boston size scleral and generally speaking about the SMART features, let's now go over clinical cases and see how these data-driven features and SMART features really come together and help our complex corneal disease patients obtain better physiological endpoints and better fitting endpoints over the sclera and vaulting the cornea. So let's just start with smart channel technology. As I said, one of the first applications that you're going to use smart channel technology is to vault anatomical obstacles. And when you put the scleral lens, if you find that that is like a red spot, a hot spot where the lens is compressing too harshly over that elevation, one way to do this in Fit Connect is that when you go to the graphical representation screens, you click where it says Smart Channel. This window is going to pop up, and there's a great picture that is used for reference. Regardless of where the dot is, you just need to enter where the dot is in degrees, and we will be able to place the channels wherever you want, regardless of the dot location. In this case, I want the dot to be between 170 degrees and 190 degrees, approximately 20 degrees in width. So, and I'm going to use this reticle that is provided here also as a guide to determine what's the starting point in degrees and the end point. So I'm going to design a channel that starts at 170 degrees and ends at 190 for a total of 20 degrees in width. And if I don't have a scleral profilometer to show me what the elevation is, if I have access to that, then that's exactly what I'm going to input there for a more customized fit. But if not, as a starting point, we recommend that you start with 0.4 millimeters or 400 microns, and then you save changes. It is worth noting that in Fit Connect, you can click here and say Smart Channel, and you can add up to 4 independent channels in any location that you need. It could be to vault a tube shunt that is placed superior nasally or superior temporally. And so you would dictate, the start and end point in degrees and add your channels in that oblique position. In this case, this is how your smart channel would look like, and you solve the issue with the fit. Cases like this, where you have more protuberant cysts, you're able to design channels that are more extensive and deep. And you can see with the fluorescein and in a cross section how we're vaulting nicely over those cysts. So that is for the anatomical obstacle approach, which you're very familiar, and Fit Connect will guide you on how to do this. But let's talk a little bit more about the application of reducing suction and promoting tear exchange, and how really can this technology help our patients obtain better physiological endpoints. This is a patient of mine. I published this case in Contact Lens Spectrum together with Dr. Burns. And so the article is there for reference. You can find a more detailed case. But this is a patient of mine that has a history of grafted cornea secondary to fuchs dystrophy and dry eye. When I started fitting this patient, There was increased neovascularization along the graft-host junction, and there was also edema. I had already started fitting her, maximizing the DK over T of the system. At the time, the highest permeable material that I had available was the Boston XO2. So we went with Boston XO2, but I minimized the thickness to 250 microns to maximize that DK over T, which we've known for some time, but now even more as more data comes out that is crucial to optimize and minimize microcystic edema. But in this case, I decided to proceed and add 2 channels of 20 degrees in the horizontal and in the horizontal meridian, nasally and temporally. But in this case, only with 200 microns of depth, because I'm not really vaulting an obstacle. My approach here is to prevent sela from that haptic. That's where I prevent the suction and I promote tear exchange. And you can see that just 6 months after, you can barely see, you can see the ghosted vessels more here, but you can barely notice that the amount of neovascularization that was present. This is an example of how this technology improves physiological endpoints. This case is just tremendous, in my opinion. This is a case of Stevens-Johnson's patient. You can see the symblephra here. This is not atypical, as we all know, to see in SJS, significant opacification and vessels and neovascularization throughout the cornea. One can think immediately that this is just perhaps conjunctivalization potentially, and that this is not reversible. We decided the clinician who added this is a clinician in our clinic who managed this patient, and she proceeded to add 4 channels, 4 smart channels for this patient. And in a matter of months as well, you can see a significant clearing of that opacification and regression of the neo. It's almost impossible to believe that this is the same eye, arguably. And if anybody would dare argue, I would say with due reason. But thankfully, we have that symblephron to note that, this is the same eye. And you can see the significant improvement in physiological endpoints. So keep this in mind when you're managing your ocular surface disease patient, and leverage this technology for that reason. So now we're going to move forward to talk about cases on how using a scleral lens design that is based on data and evidence, how does that come into play in your fitting endpoints? This is an example of a keratoconus patient that was chosen to be fitted in an 18.5 millimeter lens, and they chose to start, as we recommend, with the standard scleral shape trial lens. In this case, from the get-go, using the standard lens, the patient with an over-refraction has a built-in FSCE, obtains 20/20. But what's striking for this clinician is that from the get-go, just with the trial lens, there was a good alignment in the haptics, and the vault was around 230 microns in each eye. So for this particular patient, when they dispensed the first pair, they had 20/20 vision. And at 2 weeks follow-up, the patient's still doing well with both comfort and vision. And 1 month later, there has been no changes. And this was just with the first pair at dispense. So this is an example of how a data-driven design can get these endpoints for you without the need of special equipment like profilometry or a smart 360 in this case, or a freeform lens. This second case was that of a GVHD patient. And this clinician out of Houston chose to fit this patient with an 18.5. She wanted to cover more of the ocular surface and protect also the conj. She also used the standard scleral shape. 20/20 from the get-go, the patient was comfortable. But what's striking for this clinician out of Houston is that after the first pair, she had good alignments just from the data-driven standard scleral shape. So she had no need to change the left eye. Just one lens. In the right eye, after she dispensed it, and after the patient wore it for longer, she did notice a little bit of lower clearance in the upper corneal limbal area. And because it's GVHD, she wasn't too comfortable with this. And so she ordered a second lens for the right eye just by increasing the sag. And those were the only changes that she obtained. So you can see how wide and wide this lens, this eye is. So for her, she was able to finish and complete a GVHD fit with 2 lenses for the right eye, 1 lens for the left eye. At the 2-year follow-up, this clinician reports that the patient is still doing well with good vision and comfort. This third case is an example of a clinician that chose to fit a keratoconus patient with a 16.5 millimeter standard scleral shaped lens. And he was able, with this lens, this is a patient that had a history of failure with corneal lenses and hybrid lenses. And with the 16.5 millimeter standard lens, from the get-go, there was a great fit. He says that the patient had great comfort, and but the vault for him was a little high. It was 350 microns for that size of a lens. So the only modification that he decided to do was just to decrease the sag and add the over-refraction. And after adding over-refraction, the patient was able to obtain 20/20. As you can see, this is the endpoint of the lens. There was no change in sag, in haptics. The only thing that this clinician changed was to decrease the sag. In this case, this is a clinician from California who fit this keratoconus patient status post PKP. And this was a very ectatic graft. And she shared this picture with me of how protuberant this graft is. And we've seen these patients in clinic. And so for this patient, this clinician had to use a steep scleral shape because this patient needed more toricity added in the sclera, but just with the steep scleral shape, she was able to get a good fit from the get-go, and she chose the 19 millimeters because of how protuberant and how tall this lens would need it to be. So she wanted to distribute the weight of the lens over a larger surface area. And after the first lens, she was good with the haptics, 20/20, but she found that the sag in some areas was a little shallow. And so she chose to order a second lens, just increasing the sag. And she shares with us that just after 1 year, the patient is still doing well. And the very last patient or case or smart feature that we're going to be focusing on before wrapping it up is talking about SmartSight technology. How does having different eccentricity options help us? How does having a built-in eccentricity option help us improve the vision in our patients? This is a patient with keratoconus that was fitted previously with sclerals, and the vision was 20/70 in both eyes. This patient was refitted into Boston Sight scleral because also they were having issues with comfort from tight fitting scleral lenses. But just with the built-in FSCE value, this patient's vision was able to improve to 20/20 in the right eye and 20/40 in the left eye. You can see some examples of the OCTs from this first case. The second case is from a clinician in Mexico who fit this RK patient that was previously fit in scleral lenses, but with 20/30 vision in the right eye, 20/25 vision in the left eye, but the quality of this 20/30 and 20/25 was subpar. There was a lot of ghosting with these lenses. So Dr. Cesar Enoch fitted this particular RK patient in the 17 millimeter trial lens, also used a standard lens. And he reported that just immediately from tight fitting lenses, the patient was more comfortable compared to habitual scleral lenses. But the striking thing for this clinician in Mexico is that he was shocked that with the built-in FSCE value and the base curve value, this RK patient only required a -0.5 sphere over refraction, which led to 20/20 and no ghosting. And in the left eye, there was plain over refraction and 20/20. So for him, this was the ultimate test of the benefit of a data-driven design and having built-in FSCE. And the very last case we're going to share with you, this is from a clinician in New Jersey here in the United States, Dr. John Gellies. This is a patient of his with keratoconus status post intact who had a history of corneal, hybrid, and scleral lenses. And with the sclerals that he habitually was wearing, could only get to 20/30. That was the best corrected vision. He chose to fit this patient in an 18.5 millimeter, but just with the built-in FSCE value, the vision improved in both eyes to 20/23, and he could objectively also see a reduction in HOA, showing that indeed we are offering this aberration control that is so important and beneficial to our patients. So with this, I thank you all for your attention. I hope this is a great introduction into fitting Boston Sight scleral lenses and how these smart features and data-driven features come together to improve patient outcomes and physiological endpoints. If you have any questions, please feel free to reach out at kcarasquillo@bostonsight.org.
You wanted to take a picture of the email ID? So there are one or two suggestions. You become a member of a keratoconus group on Facebook. My big fat scleral lens. So again, Facebook. So these two will give you a lot of information from patient point of view. Because there are, keratoconus group, people from all over world keep on posting their complaints or their satisfaction or what is happening. Somebody is going for a CXL, somebody is doing a keratoplasty. So it's very interesting because the patient usually will not tell you everything, but in that group they are talking to each other. So that's very good learning point. And my big fat scleral lens as well. So, and there are a lot of practitioners also, like when you become a member, you are also, so you can also opine or, help or something like that. That's a good, way of learning also. Okay, so now going more detail now, that is a Boston scleral lens, which is available in India. So that's how I requested her to present on an actual fitting aspect, so that you can, get the basic tips and start practicing. I'm sure some of you have the fitting set already, but there are a lot of features that can be added by Fit Connect and, like the channels, smart channels and all. So let us go into another topic called iPrint Pro. So when there is a irregularity, highly regular sclera, this is the best way to do it. So Christine Shin from Ohio State University, she is the inventor of this technology, and the iPrint Pro or ATV in Delaware is the manufacturer. Yeah, she will. She sent me first video. There was no audio, so she recorded again. So I think this is good.
Thank you for having me at this specialty scleral lens symposium. Thank you for having me at the Super Lens Specialty Symposium. Thank you for having me at the Super Specialty Lens Symposium. My gratitude goes out to the organizers for inviting me to speak about iPrint prosthetics. So I believe that the driving forces in 2021 and beyond are going to be ocular shape, advanced optics, and our time. So when we look at ocular shape, the studies that have been published have put things into categories of like spherical or toric or asymmetrical or just very irregular eyes. And when I took the data from iPrint and I looked at all of these eyes, you know, hundreds and hundreds, 1,000 eyes, and I compared them, we found some very, very interesting things. One is that when we look at the limbus itself and then the area outside the limbus, and we compared the slopes over these hundreds and hundreds of eyes, we found that based on the limbus, outside of that, it's very regular actually, and has very little deviation nasally and inferior nasally across all of these eyes. Superior and temporal, that's where we really started to see more standard deviation in our patients. So really up to about 2.5 millimeters based on limbal shape. The elevation or slope beyond that is very similar across all patients. The farther away you get from the limbus, both superior and temporally, is where we start to have greater differences among all of our patient populations, which really means we need to start with the fit at the limbus, because the limbus is what pegs that fit, pegs that design. And everything beyond that is where things start to get more complicated. So when we just look at basic lens design, many of the lenses out there start with a round lens or a round limbal shape, or don't even really take the limbal shape into account. They just have standard, we think of standard sizes for the contact lens. And the standard size for the contact lens doesn't matter. It's the eye shape, the eye size that actually matters. So when we look again at all these hundreds and hundreds of eyes across the whole spectrum, we find that the average diameter horizontally is about 12.5 millimeters, which is a little bit larger than what we've always said. But this is the geometric diameter, geometric limbus. In the minor meridian, in the vertical meridian, it's almost about 11.5 millimeters. And that's across all of these eyes. So the most corneas are actually oval in shape, but beyond that, they're actually this hyperbolic paraboloid. So they aren't a planar, they have highs and lows amongst this limbal shape. The other factor that comes into fitting a scleral lens is the depth of the eye, or the vault of the cornea. So it's really not the base curve that matters, it's this vault of the lens. And that's a wild card. We don't always know what the vault is. So we have to take into account this geometric diameter, vertical diameter, the geometric shape of the limbus. We have to take into account this ever-changing geometric shape of the globe, and then of course the vault of the cornea. And that's a lot of things that we have to figure out all at once. And of course, patients expect us to do it quickly and accurately because they really don't want to spend that much time in our chair. And that's where iPrint comes in. So when you iPrint somebody, you are taking into account all of these changes on their ocular surface, and it fits the lens to the patient's actual eye. There's no guessing. We know what the shape of the eye is, and we fit the lens to that particular shape. And that's going to eliminate a lot of the problems that we see: limbal hyperemia, fogging, discomfort, pinching, towing, healing, blanching, these things that we encounter when we do trial and error fitting. Many of them are just eliminated through the eye printing process. I'd like you to meet the iPrint team. Keith Parker and I developed iPrint almost 10 years ago now. And shortly after that, David Slater joined us, and he is one of our engineers that is critical and key into developing the iPrint algorithms and the iPrint process. Megan Bauer, Naomi Anderson, and Eric McDonald are our engineers that are our design consultants, and they work with doctors directly on developing the eye print lenses for their patients. Dr. Swati Kumar is our staff optometrist. She travels, she will do training, she goes to people's practices and teaches them how to eye print. She also consults, and she will see patients as necessary at our location. And Gabi Van Roorden is our regulatory person and our international relations person, and she's the person to talk to if you're interested in having eye print come into your practice. Our products include the iPrint Pro and the iFit Pro, and both of these products are elevation specific, designed from an impression of the eye. The ScanFit Pro uses profilometry and our same technology to design 3D lenses. And then coming soon, we're going to have the iPrint gas permeable lens, which is going to be a small corneal diameter lens based on the same technology and our fitting algorithms for a corneal lens. What is different between the iPrint Pro and the iFit Pro is really the number of data points that it takes to generate the lens. So an iPrint Pro has millions and millions of data points, and that allows us to make very critical turns in the lens. It's a very slow process to generate these lenses because we have to decrease the time on the lathe. And so this is a more complex, higher price point lens. It's really for these very, very extreme eyes, maybe 1% to 2% of your population. iFit Pro really is everybody else. These would be your standard cones and grafts and people that you typically see wearing scleral or corneal GP lenses. The ScanFit Pro is the same technology, the same design as the iFit Pro, and it is based off of scanning technology using profilometer, both the Oculus Pentacam and the Eaglet ESP. What are the indications for iPrint product? Well, pretty much if you have an eye, you have an indication for an iPrint product. We really started with the optical correction, the keratoconus and the pellucids, the post-LASIK ectasia patients. But I would say in my practice, at least, this concept of ocular protection has really taken off. The neurotrophic eyes, the eyes with these persistent epithelial defects that we cannot correct without constant protection of the eye. Really, these eyes that need protection need a lens on them fast. You can't be worrying about whether you're overvaulting or undervaulting or whether you have a mismatch of the ocular alignment. We need to get something on them fast and accurately so that they can move forward with healing and the comfort of the eye itself. So what makes our iPrint process different is really the impression material. It's an FDA approved material that is safe and accurate for use on the ocular surface. The material itself is accurate within 1 to 2 microns. Our scanner is accurate within about 6 to 7 microns. So we really do have a very accurate and stable ocular surface, which we can then go and fit a contact lens on. The whole process takes maybe a minute or two. It's about 40 seconds in the tray and about 30 seconds, maybe up to a minute on the eye. That will depend a little bit on the temperature and the humidity in the exam room. The impression compound is a polyvinyl siloxane that has been specifically developed for impression use on the ocular surface. It uses a high-grade platinum to catalyze, so it is an addition technology, so there are no byproducts that are released onto the ocular surface during the process. It's very safe. It doesn't require any anesthetic, and actually some patients say that it is more comfortable when the compound is on their eye than when it is off the eye. The iPrint impression provides 360 degrees of simultaneous corneal and scleral data. So there's no stitching of images that will cause error. There's no turning of the eye that will cause error. You know, the slope here is very different than the slope here. So this is in primary gaze, 360 degrees of data up to 26 millimeters. We then scan that impression into our 3D scanner and into our proprietary software. So really at this point, you can spend your time talking to the patient, because the rest of this, their 3D eye happens downstream and you're done with the patient in your chair. So it really speeds up your chair time and the fitting process of your patient. You don't have to keep putting trial lenses on and off the eye. Our proprietary software then uses technology to create elevations, to create the vaults where you want it. All of this happens automatically, but it is all manipulatable. So you can go in and you can change the vaults, you can change the diameters, you can change where the lens lands on the eye, depending what your goals are. We can move the optics around on the lens, both the back and the front optics. So it's really quite a versatile program to design these contact lenses. And then we create a contact lens. It's actually the shape of the patient's eye, and it's unique for that exact specific patient. The software will detect the limbus. It creates that back surface vault, all of that automatically. You can enter either Ks and refractions or over refractions data. You can use multifocals on the lenses. You can create extra clearances over the bumps. You can move the optics back and forth. It's a very simple and easy program. And then it outputs a file that imports directly into the lathe to create the lens. So really what makes iPrint unique is it's extremely portable. I take this into the surgical suites. I take it into patients' hospital rooms. I've been known to do it at parties. It's a very portable device. You can go to the patient. There are doctors out there that have mobile scleral lens practices where they just take their impression kit and they go out to the patients, out to a remote location and gather the data, and then can bring it back and design all the lenses. It really makes complicated things very easy. It's fast and it's accurate. Okay. So what can you do with elevation data? What's different? What can you do now that you have all of this data? First of all, we design the lens based on the limbus. So the whole lens is going to be the shape of that patient's limbus. And when you have a round lens on an eye, you frequently get into these situations where you have an overvault or an undervault situation, and then you get this inferior limbal hyperemia. But by matching the shape of that limbus, that hyperbolic paraboloid on the patient's eye, you can eliminate this overvaulting situation and therefore eliminate this hyperemic situation for the inferior limbus. These lenses don't have to necessarily be round. So when you typically have an eye that is very oval in shape or very hyperbolic paraboloid in shape, you can end up with a very small landing zone at the 3 and 9 o'clock position. And that can create some impingement, some discomfort, sort of a pivot or a rocking point. With the iPrint lens, we can create these oval, non-round shaped lenses so that you can have equidistant landing, nasal and temporal, as well as superior and inferior. And with these oval landings, we can even make them ovate. You can cover more of the eye, have a larger area to land the lens, so you have less sinking, less impingement, and more comfort. Because of this unrestricted design, we can create actually these ovate lenses, or these, they're not even oval, they're egg-shaped or shaped however the eye area is that you need to cover. This is an example here of an infant that was born with a large eyelid coloboma. Typically in these cases, either the eye dries out or they have to do surgery right away in order to correct that coloboma. The prognosis for these children is very poor. In our case here, in this case of this little child, we fit him with this protective shell at about 5 days old. It's optically active. This child is now 17 months old. His eye is still in amazing condition. He has no scarring whatsoever, and he still sees well. We have now reconstructed part of the eyelid, and he will have another reconstruction in a couple of years, but it took the hurry off of having to do surgery for this child, and it preserved not only his ocular surface, but the vision in his eye. Here's a case of an ovate lens for a patient, a young lady who had surgery superior for SLK. She had an amniotic membrane transplant, and ended up with just constant pain in her eye. And we were able to create this lens with this vertical ovate shape so that it covered the area and splinted the area of pain so that she no longer had pain in this area. And that lens was quite stable because, again, we're anchoring it to the whole shape of the globe. It's not a weighted lens. It's anchored to the actual shape of the eyeball itself. And so this is very important to understand that the dynamic positioning of these lenses is incredibly accurate. It always goes back to the same shape. We don't have rotation on the lens. There's very little movement on these lenses as well. So in a series of subjects that we looked at stability of the lenses on the eye, we found that the average horizontal movement was a little over 11 microns. The average vertical movement was a little over 15 microns with about 0.18 degrees. So almost 0.2 of a degree of rotation, which is very, very a small amount. And it went back to its baseline, back to its original position in about 1/10 of a second. So it repositions very quickly on the eye. Now, this allows us to actually play with optics a little bit more so than we've been able to do in other lenses. So we can decenter optics. We can move them around. So this incredible stability means that we can move optics. We can move the back optics for fit, right? The back of the lens is actually for a fit factor. And so when you have pinching in certain areas, we can move those optics so that it can take the pressure off of the eye. This is very difficult to do in other lenses. Here's an example of a lens that was touching this patient's cornea, but by moving those optics inferior, over this area of pellucid, we're able to take that pressure off of the lens and off of the eye, and then create a much safer and more comfortable situation for the patient. Okay. But we can also decenter and decouple the front optics. So the optics are not tied together. We don't have to move them together. We can move them independently of each other. And so in this case here, we have a situation where the line of sight is not in the center of the lens, and we can actually move that optics over the line of sight. Now, moving the line of optics over the line of sight can actually create a less scatter and a less HOA situation, which I'm going to show you in a minute. We have some additional optics because of this stability. We can put optical prism in any direction, up, down, out, any direction you want. And because we can move both the back and the front optics, we can actually put the optical center over the line of sight, which means we can increase the ability of a multifocal to be effective, because you do need to have the center of the multifocal over the line of sight. And by recentering these optics, we can actually eliminate some of these higher order aberrations. So typically in a scleral lens, you can have this coma like we see here on the left. By putting a scleral lens on the eye, very frequently will we reverse the coma, and you'll get coma going in the other direction, which they find very bothersome. And by just simply putting the line of sight over the optical center, we can eliminate that extra coma. Now, patients who have complain of blur or coma on their in their visual system, we have to look for other things such as tear film, optical centration, diffuse scatter, for example, corneal scars, dysfunctional lens syndrome, cataract, or decenter IOLs. But once you've counted for all of that, and you're surely aware of these HOAs in the patient's eye, that is when you want to put higher order aberration corrected on a contact lens. And because of that stability, we do have the ability to do that with the iPrint products, family of products. Here's an example of a patient who had worn corneal GP lenses for quite some time. She had this moderate keratoconus and this corneal scar over her apex. And she had this habitual rose K lens, which she did fine with for many years. She always thought her vision just couldn't be corrected and had accepted that. Her habitual correction was about 2100. Over time, though, through age and dryness, she started complaining of decreased wearing time. We tried to piggyback her. She felt like it degraded her vision. She did not like it, and she really felt that it wasn't worth the hassle. So we went ahead and did an eye print lens on her, and we optimized her optical centers on the lens. And her best corrected vision at that time was 20/40. And you can see she had a significant amount of coma, residual coma and trefoil on this eye. So we created a higher order aberration lens. You see these dots here. We have to dot the lens so that we know where the optics are, and we can center the HOAs appropriately on the contact lens as reference points. And by creating that HOA lens, we actually improved her vision to 20/20. She has now been wearing this lens for about a year, and her vision has actually improved a little bit more past that, because there is some when you wear an HOA lens, you do have to adapt. You do have to get used to wearing that HOA lens, and the vision will improve a little bit over time. So what are people expecting in 2021? I truly believe they expect things to be fast. They expect it to be accurate. You know, when somebody has cataract surgery, they expect it to be accurate. When they have LASIK surgery, they expect it to be accurate and fast. And really, when it comes to contact lenses now, people are expecting the same thing. And that's where iPrint comes in. We give you fast, we give you accurate, even on the most complex of eyes. And you can find us on Facebook. You can email us at team@iprintpro.com. You can find us on our website at iprintpro.com. You're always welcome to send me a message via WhatsApp or via Facebook Messenger. I'm always happy to respond. So thank you very much for your time today. And I look forward to meeting you. And I hope I meet some of you in person in the near future. Thank you.
Okay, I think you got a little more this thing, and we are going to do impressions also, so you will know a little more about it. It's very easy. You take an impression, send it to the lab. iPrint Pro, you can go online and find their email ID and everything. You can take the impression, send it to them. They can send you the lens. Actually they don't give their products to anyone. You have to go to them, pay $10,000, get certified, and then only you can practice that lenses. I've done that, though I was part of their team, but still I had to become, pay them and get certified, everything. But now I'm certified for India, so I can help you with my certification as well. But if you want to do, you can do directly also. Let us go into the next thing, that is troubleshooting. Now you know how to fit scleral lenses, right? But the idea is like when you put the lens on, then the problem comes, and then how to solve and what to look for, and midday fogging and other things. So I think everybody knows Tom Arnold. He's the world famous optometrist and very passionate. And Melissa and Tom conducts this ICLE every year. So let us hear from Tom.
Well, hello, and thank you very much for having me. It's a pleasure to be here, and thank you to Chandra and all the organizers of this conference for having me. And I hope everybody is learning a lot and enjoying themselves. So I've been asked to talk a little today about scleral lens troubleshooting. After we fit scleral lenses for a while, they bring us a lot of joy and pleasure and success, but sometimes there's some challenges. So I hope to share a few cases with you today to go over some of the things you can do when you meet these challenges and hopefully overcome them. So there's a folk song, "Don't Go Looking for Trouble, because Trouble Will Find You," by Steve Goodman. And a good friend of mine, Dr. John Potter from Pennsylvania, said, yeah, fitting sclerals is easy until it's hard. And I love this quote from Stephen Hawking that says, the greatest enemy of knowledge is not the ignorance, but it's the illusion of knowledge. And for that, for me, that means to keep an open mind to be open to new observations and ideas. The minute you think you've got everything sorted out and you know everything, that's when you might be surprised. So keep an open mind and always be willing to learn something new. And that was our famous Stephen Hawking. I have some disclosures of some companies that I've had the pleasure to work with. And another disclosure, my favorite band, of course, is the Beatles. All right, lesson number 1 in scleral lens troubleshooting is bubbles. And bubbles come from 2 different scenarios. There can be insertion bubbles, and also bubbles can occur with the wearing of the lens. So with insertion bubbles, often the causes are either not enough saline in the bowl, it's not aligned properly where the person's putting it on, at some angle to the eye, not 90 degrees to the eye, or just jamming it into the eye, applying too much force in forcing air into the tear reservoir, fluid reservoir. So what are the remedies? Well, make sure they overfill the bowl so you have a positive saline meniscus. Insert gently, using a stand helps, especially if people have handling issues. Many practitioners will recommend using 3 or 4 drops of viscous solution first, something with carboxymethylcellulose or a good amount of hyaluronic acid to make a more viscous solutions will sometimes help with bubbles. And then, of course, we sometimes see bubbles during wear, as in this picture. As this person was blinking, air was being forced under the haptic into the fluid reservoir. So this often happens when your haptics or your landing zones are not properly aligned, or you have too much central clearance. So every time they blink, you get a pumping action on the lens. So the remedies, and we'll be hearing this a lot today, is a toric haptic or toric landing zone. Studies done here in the United States and I'm sure in Europe have demonstrated that having a toricity in your sclera of 300 microns is common and even considered normal. And the other thing is decrease the bulb, as I said, if it's excessive. So another thing that we all kind of encounter from time to time, almost with every fit, is decentration, as you can see in this picture here. Well, why is that? Well, there's a couple of reasons. First of all, I'm sure everybody remembers their ocular anatomy and the spiral of Talot. And that's just the observation that the recti muscles insert at different distances from the limbus. Not only do they insert in different distances, but they also have different elevations. So this makes it very, very challenging to fit. And that also means that the limbus is not circular. It's a paraboloid, where you have often an oval configuration, and the 2 meridians are not the same height. So maybe some of you are familiar with a chip or a crisp called a Pringle, and that's a good example of a hyperbolic paraboloid. And so this is why we see this decentration oftentimes. We have excess clearance vertically, even though we may be landing fine horizontally. And the other thing that we have to keep in mind is that once we get off the cornea onto the sclera, the limbus is rather straight, or the sclera leading away from the limbus is rather straight. It's very what we call tangent. It's a straight angle, not a curve. And Randy Kojima and Pat Caroline at Pacific University identified this a number of years ago. So the angles are different. So what are we going to do about it? Well, toric haptics, we'll hear that a lot from the Greek haptikos, meaning to grasp or to touch or to bind. So we steepen the haptic in the vertical meridian in the case we just saw. But keep in mind that this may be the flatter meridian when we have instances of against the rule toricity, where the horizontal meridian is steeper than the vertical meridian. And this is quite common. Also, a wider, flatter, straighter landing zone haptic may help. So don't be discouraged if you encounter the challenging patient in your day. Sometimes they are challenging, a little, and maybe a little bit stubborn. Impingement. Okay, impingement is defined as when the edge of the lens digs into the conjunctiva. It's also known as toeing, like standing on your tippy toes. It's not always obvious, and it may not even be uncomfortable. Tight lenses tend to feel good for patients, but look for pillowing of the conjunctiva over the lens edge. That's where the conjunctiva actually wraps over the edge. The patient may be fine during wear, but will complain of seeing a ring on the eye after removal, an impression ring. So we should always, on our follow-up visits for patients, we should always remove the lens ourselves and see how difficult they are to remove. Stain the area with sodium fluorescein because the ring may be visible with fluorescein and not under white light. So here's an example of impingement where you see that pillowing of the conjunctiva on the edge. And so OCT, you can't hide the fact that we're digging in there. So again, it all goes back to the landing zone, because after all, these are scleral lenses. We're landing them on the sclera, aren't we? So increase the toricity if you don't already have a toric haptic. And many lenses now come in quadrant specific haptics where we have 4 meridians that are adjustable. And freeform lenses where there's a continuous curve around the whole landing zone are becoming more common as well. So kind of the opposite of impingement is compression. And that's what happens when the haptic lands too close to the limbus or it heals on the limbus, like standing back on your heels. Oftentimes the lens diameter is too small, or the haptic is too flat and not angled properly. And so as the police say, don't stand too close to me. So this is an example of healing. And again, little healing there. So the remedies are increase the overall diameter of the OAD, maybe extend the mid-peripheral zone so that haptic gets pushed farther out, and steepen or increase the landing angle. And of course, that depends on the design of the lens you're using there. So you want a line like this, where you can visualize the edge of the lens, but there's absolutely no compression or impingement on either side of the edge of the lens. So this is kind of what you're shooting for right here. A nice white landing area, no compression. Midday fogging. Much has been written about midday fogging. It's in our literature frequently. In fact, our good friend Maria Walker at the University of Houston College of Optometry just obtained her PhD, and this was her thesis, was midday. So it's certainly not a party, certainly not a disco, right? So anyway, a lot of fogging. Talking heads say it's not a party, it's not a disco, it's not fooling around. So it's very common. Up to 50% of our patients need to remove the lenses and refill them daily, although this is not ideal, and we hope to prevent it if we can. And one thing you have to rule out is it truly fogging? You have to rule out, is it microcystic edema? Are they seeing rainbows around lights? Okay. You differentiate the location. Is it anterior surface deposits, or is it in the fluid reservoir, or the post-lens tear layer, as we used to call it? So these deposits are on the anterior surface. These are lipid deposits, as opposed to true midday fogging, where you see the deposits in the fluid reservoir. So what are possible causes? There are many, many possible causes. So our job is to rule out what it's not and try to cure what it is. So if the haptic, again, is not aligned, especially if it has excessive vault, we're going to pump tears and debris under the lens. Some people believe that rocking of the lens, in this case, stimulates mucin production from the goblet cells. Okay. And then, of course, the pumping action of blinking forces the debris into the fluid reservoir, the post-lens tear layer. Also, I have to rule out giant papillary conjunctivitis. When I started practicing in the 80s and we had non-disposable soft lenses, which were kept for a year or two, we would often see GPC. And now that we have daily wear and daily disposables, that's pretty much been eliminated. But scleral lenses fit way up under the palpebral conjunctiva, under the upper lid, and they are worn for extended periods of time. And so they can stimulate papillary conjunctivitis. Okay. On the other hand, the lens may be too tight. And so epithelial cells, which turn over rapidly, become entrapped underneath the lens. So in these cases, the fluid reservoir, the post-lens tear layer, becomes stagnant and turbid. And that's what we're seeing here. If you look just to the right of the beam there in the pupil, you can see the midday fogging there. So loosening the fit in these cases may help to flush the tears. So it's a real balance. If it's too tight, it'll have fogging. If it's too loose, it'll have fogging. So just like in the story about the three bears, Snow White and the three bears, you have to be just right. So other considerations, of course, make sure you have optimal clearance. In these cases, oblate designs or designs where the central base curve is flatter than the peripheral curves may be helpful. Always goes back to the landing. Sometimes in these cases, you want to reduce the overall diameter. Don't forget about your viscous tears, and strive for a uniform clearance in the mid-periphery. And to monitor that or fit that mid-periphery, you may be changing the base curve of the lens. Okay, and don't forget about dry eyes. A lot of these patients have dry eyes, comorbidities. And so treat meibomian gland dysfunction, which is so common. Now with this, you want to do lid scrubs, heat mask at home. Sometimes you have to debride the lid margins, especially if they have capped meibomian glands. And maybe use an eye wash or flush the eyes in the morning before lens insertion. Maybe not like this, but something similar. In terms of giant papillary conjunctivitis, the mast cell stabilizers may be helpful, especially during allergy season. Here in South Texas, where I live, it's very humid and very moist, and we have allergies pretty much year round. But sometimes it's just the chickens, and you just have to fight it. You don't let them get you down. All right, a few more things. Conjunctival prolapse, and this is where the conjunctiva drapes over the cornea, usually inferior temporally, and again, goes back to the fact that the limbus is asymmetrical, maybe steeper in that area, and with a shorter cord length. As we get older, the conjunctivas can get loose, especially in elderly patients or patients that are overweight. We'll see a very loose, very spongy conjunctiva. So it's more common when we have larger lenses with large amounts of limbal clearance, or if they're decentered quite a bit. And so here's an example in a little bit larger lens of some prolapse there. So is this a problem? Well, we really don't know, all right? Often that prolapse will resolve when the lens is removed. It'll just flop back to where it was before. And I've had experts who've done a lot more of this than I have tell me that it's common in about 20% of patients. I think it's only a problem if when you remove the lens, if that tissue remains adherent to the cornea. The concern there, of course, is that it'll impair the flow of oxygen there. The oxygen availability may lead to neovascularization, may stick there and have to be surgically removed. I personally haven't observed this, but there's always a possibility. So what are the remedies of this? Well, maybe reducing the diameter, certainly reducing the limbal clearance. Mentioned Dr. Walker before. She recommends aiming for a limbal clearance, less than 100 microns, somewhere between 50 and 100 microns. But that's going to depend on the overall diameter of the lens that you're using. But if your patient looks like this, don't panic. Okay, call Nick Rumney. He'll help you out. And there's Nick. We're having a good time in South Africa after one of our conferences. Higher order aberrations. This gets a lot of attention these days as we fit a lot of patients and we deal with all the fit issues. Patients still may complain that, well, I can read the letters, but there's significant ghosting or doubling or a 3D effect. Okay, and this is because, the interface of the air and the tears of the anterior corneal surface is the area of greatest refractive change. And in eyes that are very, very ectatic, optical errors are induced by this highly aberrated cornea. In keratoconus, particularly that protrusion, elevation of the cornea leads to irregular astigmatism, vertical coma, and other third and higher order aberrations. In post-RK patients where these incisions go all the way down to the endothelium and cause an irregularity there, that's an irregular effracting surface as the light ray leaves that posterior cornea, and that's not correctable with conventional scleral lenses. Okay. A lot of studies have been done around the world. Here's a study out of Houston using wavefront guided lenses. And so with higher order aberrations, coma increases with age in everybody. Irregular astigmatism, scarring. Scarring is not truly higher order aberrations, but it causes scattering, which the patient may complain about. Pupil size will cause a variation in the amount of higher order aberrations and where they're located, as will accommodation. We use something called Zernike polynomials, and that describes the wavefront surface and can be converted into microns of elevation that can then be incorporated into the lens designs in order to reduce some of this. But the whole eye is difficult because it changes dynamically. Pupil size, photopic, scotopic light conditions, many things affect higher order aberration. So it's not a static measurement. So here is an example of the Zernike polynomials. We're used to dealing with lower order aberrations, sphere and cylinder, maybe prism. And then you have the vertical and horizontal coma and trefoil in the higher order aberrations, and even quadrifoil, and they get very, very complicated. But a lot of labs are doing a good job now addressing this and incorporating wavefront optics. So it's a very, very active case. And here's an example that the person did have a lot of higher order aberrations. We designed a lens. We like to dilate the person so we get the maximum amount of data from the patient, because we have to account for that in light, scotopic conditions where the light is dim, that pupil will dilate. So we take some measurements and fit the lens, and these patients can do quite well. And so here's our aberrometry results over the lens now, and you can see that we've reduced those higher order aberrations quite a bit. So it is possible. It takes some work, takes some patience on the part of the patient. And so here's a wavefront variation. You can see that you do have some regularity that's been corrected here. Post-RK, I think, is particularly challenging because of the scarring and the scattering. You can fit the lens really, really well, but those scars will continue to give you some trouble. Although we fit this lady very, very well. She still complained of suboptimal vision. I think she saw about 6'8" or 6'10" or 20/30. And that was due, as we talked about earlier, to this posterior corneal irregularity caused by the RK scars going so deep. So sometimes these can be challenging. So the best thing that can be done to that is just center the optical zone, as well as you can, in front of the line of sight. Sometimes changing the eccentricity or the rate of flattening of the lens will reduce these aberrations. And that's something certainly to try first. And as we talked about, there are several labs that are working with their designs to incorporate correction for higher order aberrations. So, in summary, these are challenging cases, but that's what makes this field of scleral lenses and specialty contacts so rewarding. So, keep calm. Just remember to clear the cornea, and good luck to you in your fitting. And again, thank you very much for having me today, and I hope you enjoy the rest of the conference. And thank you for listening. I'd love to hear from you.
These are his
And with that, I'm going to say bye-bye.
Okay, so any questions? I think this was quite interesting. He covered almost all complications. So we have a few questions here. Let's see. So is this iPrint technology available in India? Yes, available through me, but best is to get in touch with them and get yourself certified and start practicing. How does iPrint lenses correct corneal astigmatism when they actually take up shape of the cornea? So we are talking about scleral lens. So there is nothing about cornea here. The impression you are taking of the sclera. And you are vaulting over the cornea. So corneal irregularity has nothing to do with this technology. The technology is for the irregular sclera to get an exact fitting. Correct. You can move it, you can put a prism, you can do higher order aberrations. Yeah, of course, you can use for regular this thing, but the cost difference is so much that why should you use that technology for this? So there are so many other technologies where you can use the high order aberration. Like for example, you can use a Boston scleral lens, and that is much cheaper. So like I'll give you a costing if you want. The Boston scleral lens, I'm going to give costing of the US, $250 per lens. And iPrint Pro is $1,800 per lens. Would you use that? No. 4 times. So, since you have, one technology, see now you have so much. So you select what you want to do. When you have a simple case, you just want a simple 16 mm lens. But if you have a high ectatic cornea, you want 19 mm because that whole weight of the lens has to get distributed. So since you have only 16 mm lens, you are going to fit everyone in that. Doesn't work that way. And if you have a say, any surgical sclera like glaucoma surgery or anything, then your regular lens is going to have little difficulty. But you can use a smart channels. If you have eye profiler, then you can play around with that also. So precorneal reservoir in scleral lens negates effect of almost all topography. Of course, that's the whole idea. So the water that you put into the scleral lens becomes that, it goes into all the irregularities and gives you a nice optical clear surface. And the front surface of the scleral lens actually acts as a cornea. That's why you see better. Okay, so I think Shalupal is still awake and waiting for us. Shalu, are you there?
I'm here. Can you hear me?
Yes, thank you. Can we see Shalu? Can you see her? Can you put on your video, ma'am?
It's on. Can you not see me? Let's see.
Yes, we can see.
There we go. Okay. I'm going to share my screen now. All right. Are we good to go? Perfect. Thank you so much, first of all, for inviting me and having me as part of your conference. I wanted to stay awake so I could be in person with you as much as I possibly could. Hopefully next year, I will be able to be there with you in person. Today, I'm going to be talking about multifocal scleral lenses. My name is Shalu Pal, and I practice in Toronto, Canada. And I just want to say good morning to everyone and thank you again for having me here. Let's dive right in and have a conversation about presbyopes. What do we know right now? We know that 2.1 billion presbyopes worldwide are currently present. And 1 out of every 3 presbyopes want to try multifocal lenses, but there's only been a small percentage of people that have actually been told about multifocal contact lenses. We also know that 91% of those people that are in that age of presbyopia want to stay in their contact lenses as they continue to age. We also know in that same age group that people are dropping out of contact lenses so quickly because of dryness and discomfort. And this is where multifocal sclerals come into play and are very, very good. Dropout because of dryness and because of discomfort, we solve that with multifocal sclerals because of that tear reservoir that gives us that fluid over the surface of the eye, which makes it very, very comfortable. We also know that those irregular corneas, those keratoconics, and all the people that we use scleral lenses for, they're eventually going to become presbyopic. So we need a solution for them as well. We also know that those that have high amounts of astigmatism, we may not have a soft toric multifocal that works for them or is comfortable for them, as we were just discussing how that fluid underneath the scleral lens with the eye print lenses, this is what makes sclerals magical, is that we can correct all of those. We also know that scleral lenses, once they are fit, they're stable. They don't rotate, they don't translate up and down. So that means that the multifocal designs that we're used to with our soft lenses, the simultaneous design, the aspheric designs, they work so well with multifocals because of that stability of these lenses. One of the things that I truly believe that help our multifocal fits, whether we're talking about sclerals or whether we're talking about soft lenses, is communication. And communication is what really helps our patient understand what's happening and what's going on and helps us be more successful. In my practice, when I was just out early 20s and now talking to patients, and I'm talking about presbyopia to them, and I'm starting to talk to them about age, they hated the conversation. And I knew that I needed to change the conversation because I couldn't keep talking about them getting older. They didn't like hearing that from me. So I started talking about the accommodative system, and I started talking about it at a much earlier age than before, than talking about it at, a later age in 40s. I started talking about it with my teenagers and my young teens, because I was talking about the accommodative system as having a reservoir of energy that we slowly lose over time. Think about what a full presbyope is. They have a plus 250 diopter ad. If we break that up into quarter diopter steps, we technically have 10 steps of change that someone is going to go through, that we're all going to go through over the course of maybe 10, 20, 30 years. Okay, so let me explain how we can use this to really help our patients understand. So if you have a presbyopic ad power, okay, in this system, they are technically at level 4. That means they've lost 4 natural ability or 4 natural units of energy. They have 6 units remaining. I need to give them 4 units to get them back up to their full potential. And I'm going to give them 4 units of magnification. This is very helpful for them to understand where are they in this process? How many more steps of change do they have ahead of them? How many more potential glasses changes do they need? A lot of their fears and misunderstandings of what's going on, what's happening, how long is this going to happen? When is this going to stop? They can now track this properly with us. It also helps me to get them to start early with multifocal contact lenses and early with presbyopic glasses. So that way, I don't have to be waiting until they're a +2 before they finally come in. Get it. I'm giving them a small amount of reading support to get them back up to their full potential. Why is that easier for us? Starting early helps us. It also helps our patients. Think about whether we're talking about a progressive pair of glasses or a multifocal contact lens. The higher the ad power that you have, the more prescription that is in both of these devices. You have more going on, and it makes adaptation harder. We all understand what simultaneous vision is. And if you have a plus 250 ad versus a plus 1 ad, the simultaneous vision is going to be harder to adapt to for the first time with a plus 250 ad versus a plus 1. So starting early is really, really beneficial to everybody. You'll also have a greater likelihood of reaching your 20/20 vision in distance and up close. I really like this diagram, and this is technically multifocal soft lenses, but it's a really nice depiction of what a low ad power lens looks like, where there's not as many rings inside the lens, versus a high ad power where there's so many more rings happening inside the lens. This lens with a high ad or more amount of reading prescription in there is going to be harder to get used to than this low ad. These same principles apply to whether we're talking about soft lenses or scleral multifocals. But let's dive in a little bit deeper into the lens designs that are available. When we talk about scleral multifocals, let's simplify it and talk about center near or center distance. The center of the lens either has the near prescription or the center of the lens has the distance prescription. The majority of the lenses that are designed have center near designs. Let's go deeper, okay? With that design, you can have an aspheric design. So talking about center near, distance is on the edge and it changes progressively towards the center near prescription. You can have concentric ring designs, 2 rings or 3 rings. 2 rings, you have near and a distance ring. 3 rings, you have near, intermediate, and a distance ring. Let's make it more complicated. Each one of those rings can either be spherical, or they can be aspheric, or they could be a combination. You start to see there's multiple layers. Let's add more. Now that prescription can either be fit on the front of the lens, it could be fit on the back of the lens, or you could split these optics so some is on the front and some is on the back. The number of combinations that could possibly make with multifocal lenses is really, really intense. And we're going to talk about the labs and the different designs and how to really understand all of this. But just understanding the complexity of what each multifocal scleral lens could potentially be is really important. Here's another variable, optic zone. Some companies, typically the standard is 2 millimeters for that optic zone. Some companies will allow you to change that optic zone in 0.5 millimeter increments, all the way up to 6 millimeters in size. So how do you know if you have the ability to change the optic zone? How do you know what do you change it to? Is it based on the pupil size, bright light or dim light? It may be based on whether you start with a center near design or a center distance. It may be dependent on what's the goal of the patients. Your lab may say, you can't change anything. Just tell me what the pupil size is, and I'm going to do a set ratio. Let's say 2/3 of whatever your pupil is, that's going to be the optic zone. So you really have to think about what is it your lab, what are they capable of doing, and how do they want to help you fit this lens, and have conversations about optic zone, because playing around with the optic zone can definitely make a difference or more distance. What about the ad power, the total amount of ad? Well, what's capable? What's your lab capable of giving you? Some will give you up to 5 diopters of ad. But if you want more distance with your patients, maybe you want 2 center distance designs. If you want more near, maybe you want 2 center near design. Intermediate, maybe you're not going to give them all. The intermediate zone is a little bit bigger. What if you have those patients that I want it all, I want everything? Well, maybe you might do a modified monovision where you have a distance lens for the dominant eye and a near lens or for the non-dominant eye. There's so many different combinations that you just have to start being creative here. I stole this slide from Melissa Barnett, and she put together a list of all of the different types of multifocal scleral lenses that are currently available. And this list now, I can, Alden Optical has a lens on here. Blanchard has a new lens. This list keeps changing because so many more lenses keep becoming developed, and we have so many options. But the key is you got to pick a lab that you want to work with, and you have to dive in deep with the lens that they're working with. You have to find out, are we dealing with a design that's center near, distance, or both? Do we have spherical optics, aspherics? Are we doing concentric designs? Are we doing combinations? Is it a 2-ring design or a 3-ring design? Are the optics on the front surface, the back surface, or is it split? Can I change the optic zone? How do you want me to change it? How can I change it? And what are my possibilities of ranges, of power? You need to know all of this because that's going to help you decide, how do I modify my lens in order to adjust for what the patient is looking for? You also want to find out from them is, do they have a fitting set for multifocals? Do they have an actual set of multifocal lenses that you can play with and put on your patient? Do they have fitting guides? When we're fitting soft multifocals, the fitting guides are our, guides to how to work with these. You have the same option when it comes to multifocal lenses. So make sure you ask your labs and really understand what's going on. And one of the key things is, how do you get help? Who do you talk to? Is it by phone or email? And what's the cost and the warranty? How does this work? When you have a spherical lens and you want to upgrade to a multifocal, do you return the spherical lens and then upgrade? Or is it all part of the same warranty? Are there more number of redos? How much time do you have? Because this is not a quick, fast process. So you need to understand exactly how that works so you can plan your time. And so you can also be thinking about, how do I charge my patients for all of this? I threw the slide up just so you can see some of the fitting guides that are available. But let's talk about, how do we actually design a multifocal? Okay, so the most common way that people do this is they start with fitting their distance lens, scleral lens. They fit it perfectly. They sort out the comfort. They figure out the centration. They get a stable scleral lens, and then they empirically order their multifocal values on top of this. It's similar when you're ordering a front toric, right? I figure out what my scleral lens is for my distance, the spherical part first. I get it so it doesn't rotate anymore. I'm happy with the fit. And then the last piece, I'm going to add the front toric on it. The other way you can do this is you could order it all from the beginning and say, I've put my diagnostic lens on the eye, and now let me just design everything. I'm going to put the toricity in there. I'm going to make the fit changes. I'm going to put the ad in there. I'm just going to design it all from the get-go. This works, but if you're starting with your diagnostic lens and you have to make a lot of changes to the fit, I'm going to tell you maybe to wait, because if it doesn't work, where do you go back to make the changes, right? If that lens isn't stable after your first lens, things are not going to be stable. So you want to be cautious. There are other ways. You can use multifocal fitting sets. You can use computer software. You can use profilometry using those scleral topographers. You can use online tools, lots and lots of different ways. But I want to focus on the one that most people are doing. You've got your scleral lens set. You're happy with the long distance vision. And now you want to add reading on top. Before you jump into the reading, I'm going to encourage you to do a spherocell over refraction. Use your phoropter, figure out, is there any residual astigmatism that I need to deal with? But I'm also going to tell you that whatever you find in the phoropter, trial frame it, because you may find that you want cylinder behind the phoropter, but in reality, the patient is very happy with the spherical equivalent. And you'd be surprised, I have more people choosing spherical equivalent than actually the astigmatism. But now let's say that they do want the astigmatism correction. You got to know from your lab, will they give you a front toric and a multifocal? You may have to choose. So you want to make sure you check keratometry over top of lenses to see if there's any flexure, because if there's flexure, maybe you can fix that little bit of astigmatism by just getting a little bit of, have to choose, you can go with the astigmatism and the multifocal design. Then you want to determine your ad. And the ad determination is not based on the maximum amount of ad to let you to read. You want to figure out what does the patient want to do. I want to use scleral lenses and sit at a computer all day long. Then you don't need this plus 250 ad to be able to read, right? You want to set that ad to what they're actually asking. The least amount of ad, so you have the least amount of rings and change happening in that lens, is really important. Next, you want to figure out eye dominance. And the general consensus is when we're dealing with multifocal contact lenses, sensory dominance. Remember, when you're choosing sensory dominance, you're looking in the distance, you have your patient looking in the distance, and you grab a plus 150 or a plus 2 trial lens, hold it over one eye. then hold it over the other and tell them both of these are going to look blurry. Tell me which one looks worse. And you let them see and you let them choose, and they'll tell you which eye is the dominant eye because that will be the blurry eye. You're going to pick pupil size based on dim lights and bright lights, lots of different ways you can measure pupil size. And then you're going to send all of this information to the lab, and they are going to design the lens for you based on that spherical lens that you started with. And they're going to add these optics on top and give you a lens. Once you have the lens in office, you're going to dispense it. And I want to make sure you remember that some of these patients are now dealing with simultaneous vision for the first time. So give yourself time to adapt. Give them at least 2 weeks so they really can get used to it. But reassure them. Again, this is where the communication comes back in. Reassure them that things are going to change and make sure they understand how important the follow-up is, because small changes can make a big difference here. So you want them to come back, and you want to stress how important it is for them to come back. When you're checking vision, I check binocular vision. I also check monocular vision. I also remember, what is it that they wanted? Did they want to just be able to see their phone? Well, let me pull out their phone and look at their phone and look at those real world tasks to make sure, have we solved what they've been asking for? There's no need to put up a chart and not tell them what to look at. I'll always aim them at 2040 to set realistic expectations. If they're a 250 ad, they may not be able to get to 2020, but if I don't point them to 2040, they're going to automatically look at the bottom of the chart and say, I want to be the best. I want to get to the bottom. And if they can't get there, they're going to be disappointed. So definitely want to set those goals and remember to use those real world tasks. What if things aren't working? What if they can't see well? What if they're not happy with the long distance or the up close? I will use my loose lenses to try and over refract with each individual eye and with both eyes open to see, can I make small changes to adjust these lenses to give them better vision? I'm going to check to make sure there's no residual astigmatism or flexure coming through, but I'm also going to look at those fitting guides and say, look, I have a reading problem. What do I do? I have a distance problem. What do I do? I'm going to get on the phone with the consultant and chat with them and say, here's the situation. Guide me with your lens. How do I make the changes that I need to? Some things that they will consider and they'll offer to you is changing the design of the lens or changing the optic zone. If you start with 2 center near lenses, but your distance isn't very good, you might change one of those center near to a center distance. Or if you start with 2 center distance lenses and you want more reading, you might change one of those to a center near lens. You may start to do some of this modified monovision where you have a center distance on one eye, center near on the other, but you're going to give a little bit more distance to one eye, a little bit more reading to the other eye by modifying those optic zones. So many different combinations. And the reason why I want you to talk to your consultant and really understand the lens is because you don't have endless redos. You don't have endless time to keep trying and guessing. What if I do this? What if I do this? So think about a plan, but run it by the consultant to say, hey, does this make sense? Yes, let's go ahead and let's do a redo. So you don't keep spinning your wheels and wasting those redos. We can't have a conversation about multifocal sclerals unless we talk about misaligned optics. And what is misaligned optics? Well, think about how complex this optical design is that we've just talked about in a multifocal. If that is not lined up with the visual axis, things are misaligned. And you can have natural misalignment where you see this on topography. When you do topography on a patient and you have them look at the center of the topographer and you look at the placido disc and you're like, okay, these are not lined up on the cornea. I need you to move up or look to the right or look to the left or look up or look down. You are readjusting the alignment. So that initially tells you there's a natural misalignment with the center of the cornea and the visual axis. And typically that misalignment is superior and nasal to the geometric center. And that's what we're showing right here in this diagram. There's a second misalignment, and that has to do with the lens. The scleral lens, the optical center of the lens, may not line up with the optical center of your eye. If we look here at this diagram here, this is the center of the lens, which is the red light. And if we look at the cornea, the optical center of the eye is the green. These 2 dots are not lining up. So that's a scleral lens that's decentered. Why do scleral lenses decenter? Well, scleral lenses follow the anatomy of the eye. And typically that position of that lens wants to be inferior and temporal. weight of the lens, if you have a high prescription lens, or if you have a large diameter lens, or if you have a very deep tear reservoir, that lens is going to drop on you. When you have lenses that are dropping, this is where you want to use your toric peripheral curves or your toric haptics to realign this lens. So take a look and see at the top, this space here versus the bottom. There's a lot more at the bottom. This lens is sitting low, and we can use the toric haptics to straighten and lift this up. This is the reason why people like to empirically order their lenses, multifocal lenses, after they've done all of these adjustments, so they can fix the centration of the lens and then say, okay, now let me add the add power because I've gotten that centration a little bit better. So what's the big deal if things are decentered? We've heard a lot of talk just recently about higher order aberrations. Higher order aberrations can be created by this decentration of these optics. The more decentered the lenses are, the more problems are going to rise. Low contrast VAs, high contrast VAs can be affected. The patient will complain about, I see this ghosting or these 3D effects or these halos or these overlapping images. All of this should be thinking about decentered optics, but I want you to be be thinking that, hey, I've got solutions to these, because iPrint, for example, that we just talked about, can fix this. They will move the optics of that design to line up with the optical system of the eye. You have other companies, AccuLens and Blanchard, and I'm sure there's many, many more that will decenter optics for you. But how do we measure these misalignments? So how do you tell the lab, okay, I'm decentered, now I need you to fix it? There's a couple of different ways. Right over top lens, you can project these Placido discs, as you see right here, and you can see where the misalignment is, and you can give this information to the lab. You can also do topography over top of the lenses and see, okay, where are my optic zones? Where are those add powers? And in this example right here, you can see that the lens is sitting inferior temporal, just like we would expect most lenses to be, but this is a topographical relationship. The labs that are fitting lenses that allow you to decenter the optics may have these trial lenses where you can see all of these hash marks. And then you can put this on the eye and say, hey, I'm decentered 3 hash too low and 2 hash marks to the left or right. And that will give you the calculations to be able to tell the lab, hey, this is how I need you to fix the optics of the lens to correct them. There's others, there's online calculators. So this is an example where Blanchard, and I just sort of put these drawings in here so you can see this black ring is the pupil and the white ring is that marking that is on the lens. And this online calculator, what it does is they want you to replicate what you're seeing on the eye with the calculator online. So you can see those hash marks are lined up with these hash marks, and this image has been decentered, and this will do the calculations for you, and then your lens will be designed that way. There's MATLAB software that can be used to calculate and do the calculations for you. You can use the reticle on your slit lamp to make these calculations. However you decide to measure these, again, it all depends on your lab and if they will offer this technology to decenter the optics. The key is that we have options to be able to troubleshoot. Why is my patient not seeing well? I've done everything. What else? I want you to be thinking about, let me think of potentially decentering these optics. Maybe that's the issue. And you can figure this out right from your initial topography of your patient. I will look at these initial topographies, and if I don't have the ability to decenter optics, I'm going to say, you know what, this is going to be challenging because we are so far apart between the optical center and the visual axis that maybe multifocals won't work. But these are clues for you to be thinking about. Let's review. There's so much to talk about with multifocal sclerals, but they are complex, but we have the tools that we can make this work. When you're problem solving, remember to do K's over top, to think about flexure, to see if we can thicken that lens a little bit to get rid of some of that residual astigmatism. Think about doing those over refractions. Think about pupil size. And if your lab allows for you to adjust for pupil size, think about decentered optics and whether we need to adjust things. Can we adjust things? Monocular VAs to double check. And when you're designing these lenses, think about what the patient is asking you for and think about what their goals are and be creative because there's so many different options. And lastly, make sure you look at the fitting guides and you talk to your lab partners because they are key in helping you understand their specific lens and getting you the best results for your patients. Thank you so much for inviting me and having me here. I really appreciate it. Here's my email address. If you have any questions, I'm happy to answer anything. But to keep you on track, Chandra, I'm going to hand it back over to you.
Thank you, Shalu. It was so nice of you. It's 2:30 in the night, and she's still here for us. I really appreciate, and we thank you. All the delegates wants to say thanks to you, Shalu. And next year in person, definitely, yes. Any questions for Shalu?
Absolutely.
She's expert in myopia control. She's expert in scleral lens, multifocal, anything. You can ask any questions. Yes, Ajit. Yeah, it is really, she made it really nice and simple. Yeah.
Madam Shalu, it was so nice of you. You made difficult subjects so simple to understand that we thought that we already knew this. But it's your patience that you have made things so simple to understand. Thank you so much.
See, the importance of this talk is this decentration can be applied to anything, since whatever you have done. See, now you learn how to put a scleral lens, but all the scleral lens are going to decenter. Okay, it's very difficult to get exact centration. So now what? If your lens is decentered, the vision quality is going to be little compromised, right? But if you can use this technology and move your optics accordingly, then you get that maximum benefit. And of course, all the lenses has that capacity, but not many will offer you to decenter. So this Maxim, Max 3D is the latest launch. Shalu has shown the laser marking and everything. It's very easy. You actually see how much decentration you have to do, and every time it's perfect. So not only for bifocal or multifocal lenses, for regular optics also you can use this technology, so that you get a more sharper and clear vision. So you can use high order aberration, eccentricity, and the decentered optics. Many times we get satisfied with whatever, like, from finger counting or 660 to 6.9 or 6.12 vision. But why not do 6.5 vision, right? So all these things you can incorporate and make the patient happy. Any more questions for Shalu? I think, Shalu, you did a great job. And
thank you
very much. Thank you very much for.
Thank you so much, Chandra.
Thank you.
Thank you. Thank you.
Next talk now. So, okay, we have done scleral lenses, right? Now it's time to dispense, and how to go about that. So Arlene is from Atlanta, and she has a very busy practice. She works with 8 ophthalmologists, and she's the only optometrist, and very, very busy. So let us, I requested her to, give a presentation for us. Same thing, it's middle of the night, so they preferred to give me the presentation. That's why special thanks to Shalu to be awake for us at middle of.
Good evening. I'm Dr. Arlene Gotay, and we're here in my office at the Contact Lens Department of Eye Consultants of Atlanta. Today, we're going to be talking about the dispensing of scleral contact lenses in particular. And this is where the magic happens. Our goal is to make sure our patients are comfortable and confident, and that the process goes smoothly so that they are successful. For that reason, we make sure the process of the dispensing starts the first day that patient walks through this hallway.
First, identify special dispensing needs ahead of dispensing day. One of the ways is the way we do it, that we go over the dispensing process, over the insertion and removal the day of the fitting appointment. That way we can address if the patient needs extra help, needs a family member or a friend to come and aid the patient on the insertion and the removal, or if the patient needs an extra help like one of those ring inserters or the stand. Number 2, inspect, clean, and condition the lens ahead of the appointment. Very rarely a lens arrives that it's far from perfect. Every once in a while, a lens might have a little nick or a little damage. It's important that we inspect that lens when the lens arrives prior to contacting the patient for the appointment, and also that we clean the lens well and let it soak for conditioning. That way it limits the problem with fogging when the person first puts the lens on. 3, prepare the area for dispensing. That will also let the patient know things they can do at home to prevent other problems. I like to recommend the patient to use a cotton towel in the area they're going to be working at. That way, if the lens falls, the lens doesn't crack or has limited possibilities of breaking if it falls over a cotton towel soft area. Then we process to go to the insertion and the removal training officially. Of course, the first step is good hand washing. We like recommending a soap that's an acne type soap because it cuts all the oils off the hands. And also, we like to take a big benefit of audiovisual or written material. I'm a believer that the more information the patient has, the more compliant they are. We present a video that shows the insertion and removal to the patient, and we also give all the information in writing, including how many hours a day they should be using the lenses and everything they are supposed to be doing. Next, we proceed to teach the disinfection and the care of the lens. It's important that the patient knows what we're recommending. When the patients don't know what we are recommending and are not clear about it, the patients are bound to make mistakes, or they are bound to go online and get the advice of what the internet has to tell them. It's important that we cover what solutions we recommend. There's definitely several different solutions. We recommend in our practice for most of our patients a hydrogen peroxide-based solution because of the efficiency of the solution. But it's not necessarily accessible in all the markets, or it may not necessarily work well for all the patients. There are also some multi-purpose solutions that are perfectly acceptable. Find out what's accessible in your area or in the area where the patient lives so that it's easy for them to find a solution.
When the patient comes in for that first appointment, he is brought to this room where measuring and explanation of what's going to happen happens. But that day is the day that dispensing process starts. Part of our fitting process includes teaching the patient what's going to happen the day they come for the final pickup of their lens. That helps us know, is the patient capable of doing the insertion of the scleral lens by him or herself, Or is this patient gonna need extra help from a family member or someone that lives nearby that can take care of the process? It will also help us find out if the patient is gonna need any extra accessories. There are different accessories out there that help patients be able to put their lenses with ease. Let's say the patient has a little difficulty holding the plunger. Well, there's a little ring the patient can put in their finger and put the lens on. And we'll look at demonstrations in a little bit. So the patient is here, ready to put the lens on. Remember, this patient has already put the lens on by himself, and we know he is capable of doing so. So we take the large plunger, the contact lens that we have cleaned and moisturized for the patient, preservative-free sterile saline solution to fill the bowl completely, and a strip of fluorescein so that we can assess the fit after at least half an hour of the patient wearing the lens. Notice we have prepared the area for the patient with a flat mirror. And there goes the lens on the eye. And open the eye, and we're gonna make sure there are no bubbles, which there are not. The patient will now wait for us to assess the lens in about half an hour. For removal, we're going to use a small plunger. There's different types of a small plunger. One of them is slant and one of them is flat. That's more of a personal preference. We wet it a little bit. And locate the plunger closer to the edge, a little off center of the lens, and there it comes. Easy removal. Once the lens is removed, the lens process to teach the patient on how to clean the lens. If our patient is one of those that need extra help or assistance on the insertion and removal of the contact lens, we make sure that person that's going to be helping that patient on a regular basis understands what are the supplies that are being provided and also understands the information that we're giving in writing. And then now you remember that we talked about the extra gadgets that some patients might need to insert the lens. There are also stands available in the market to ease the insertion of lenses. This one is totally hands-free. There's a light attached to the plunger. And you place the lens, you fill it up, and you bring your head and your eye, of course, towards it. This is a gadget that's very easily reproduced at a minimal cost. You could use a plastic cup, you could use a flower base and a straw. There are different options, different methods that you could make your own. Earlier, we talked about learning to make your own hands-free stand. A very simple and inexpensive solution for patients that might need extra help putting their lens, but they don't need an extra person. We start with a piece of foam. Simple piece of foam. We make a hole in the center of the foam the size of a straw. A regular plastic straw for that matter. We take a plunger, one of the large plungers, and we cut the back end of the plunger. Now we insert the plunger on the straw. We put that straw in the hole, and voila, we have a stand. Now, how are we going to solve the problem of the light with that stand? Simple. If the person has a cell phone, all we need to do is get that light, put our straw and stand right there, and we get the light through.
Now that our patient knows how to insert and remove the lenses very well, then it's time to discuss the care of the contact lenses. It is important that the patient leaves the office with a supply and with information so that they are not having guesswork on how to care for their lenses. That's when the patients end up getting a solution that's not the right one or could hurt themselves. In our case, we prefer to recommend a hydrogen peroxide-based solution because it cleans deeply, disinfects the lenses, and also it's very easy to use. The important part of a hydrogen peroxide-based solution is that the lenses need to stay on that case for at least 6 hours so that the solution neutralizes. Otherwise, the patient needs to rinse those lenses very, very well with saline solution to get rid of the hydrogen peroxide and avoid irritation and burning.
Now that we've trained the patient on how to properly insert and remove the lens, and we have trained the patient on the care of the contact lens, what are we sending the patient home with? We're sending the patient with a supply of the solution to disinfect the lens. It's enough for a week, and a detailed instruction on how to use it. The patient is going home with some preservative-free artificial tears. That way the patient has enough for at least the next day or so, or maybe longer. Patient will take a 30-day supply of the preservative-free saline solution. Some instructions on how to take care of the plungers. A small and a large plunger. We also provide the patient with a travel case. That way the patient can have these in their bag or even their car, that they don't find themselves not being able to insert or remove their lens in a case of emergency. We're also going over detailed written instructions with the patient. We're believers that if the patient has the information in writing, the patient has more chances of being successful and compliant. At this point, the patient has the tools and information needed to embark in their new life with scleral contact lenses. Any questions the patient may have been answered. The follow-up appointment has been scheduled, usually between 1 and 2 weeks. At that point, the patient must come wearing the lenses, and we prefer the patient has the lenses on for at least 1 or 2 hours or longer if possible. We have covered the importance of the patient having the knowledge and the confidence on handling and caring for the lenses. But what do we need as practitioners in order to help our patients succeed? As practitioners, we need patience. Keep in mind, most of these patients are struggling emotionally and physically. So us having patience transmits that calmness to them. We need efficient and highly sympathetic staff. It's important that we have 1 or 2 or 3 people trained in insertion and removal and caring of the patient. These are the people that are going to be spending the time training the patient, showing the patient how things are done properly. And also they're going to be training the families in the case the patient cannot handle the lenses themselves. We also need as many written and or audiovisual materials as we can provide. All the patients learn in different manners. Some are very visual, so a video may be helpful, and some like to read, and some will remember what we told them. But there's so much information that the more we can provide to them, the more they can go back and look at when questions arise. We also need to know what products are accessible for these patients. What products the patient can either find at the store, what products the patient can order maybe online, or if we need to have the products in the office so that the patient can come to the office and get their products. And when we're talking products, we're talking disinfecting products, we're talking the saline solution, plungers, and so on. Another thing we need to be creative. Like I said, every patient is different, and we need to adjust to each person's needs. So the fact that one patient can put the lens sitting down doesn't mean that everybody else can. Some need to be standing up, some need to be bending over. Tons of different things, tons of different methods. But we need to find what works for each patient. And that applies not only for us, but it applies for our staff as well. And last but not least, we need a very positive attitude. Ultimately, we are these patients' biggest cheerleader.
I know there was a lot of background music, so you may not have got, but you understood what it was, right? I think this was the best presentation. She took a lot of efforts to make this video specially for us. So thank you, Arlene, if you are listening. I'm sure she's not listening, but when I'm going to post this on the YouTube and other stuff in future, she will appreciate that. We thank her. So before we go into Seema, I think Seema will be there online, but I requested Arnaud from Europe to talk about the eye profiler. That is the latest equipment. It's very famous. Even Karen spoke about it. And that instrument is connected to all the major laboratories. You take the image. So that works for scleral lens as well as orthokeratology. That's the best thing one can have. So let's see. Can you add?
Good. Yeah.
We can't see you. No. Can you put your video?
My video is on.
Oh, okay, great. Yeah. Stop share. Yes, we can see you now.
Wonderful. Hello. Nice to be here. Nice to be part of your conference. Thank you so much, Dr. Chawan. I will share my screen, and it's an absolute pleasure to be a part of this comments, and it's also a pleasure to give you a quick introduction into the eye surface profiler. Let me just get that started. Okay, it measures the full front surface of the eye. So we do 100% of cornea and then a large part of the sclera. Any part of the sclera that is exposed to the device. And so then create a 3D model of the front surface of the eye at a very high accuracy. So for the cornea, that's 2 micron, and for the sclera, it's 10 micron. And so what we try to do here is to take the guesswork out of specialty lens fitting, whether it is a scleral fitting or ortho-K or RGP for that matter. And we also have some soft lenses integrated already. And that is the goal that we do. So let me bring you into. So what we have is a system where we project vertical line patterns from 2 sides, and we have a digital camera in the center. And essential here is that you instill fluorescein, because it's the fluorescein that also gives you the image of the sclera. And those are the 2 images that we take, and these are then constructed into a 3D model of the eye. And this is the basis of all the fitting that we do. And it's a very fast single shot process that takes just a few, a second in total, but each shot is a millisecond. So there is very little issue with movement of the eye. And also in your practice, you can be able to process this quickly. And we have full topography software that you would expect from any other device. The measurement process is fairly straightforward. It's in a couple of steps, and you lubricate the eye, you pre-align the device, instill fluorescein, as I mentioned. It has to be done in a light-controlled room, and also said that you need to open up the eyelids in order to also get very good vertical coverage, and then shoot. That's in essence what the whole measurement process is, and with a very short ramp up time, you can be fitting like a pro. So this is the patient's perspective, and also what the doctor sees. So you see, you align up the device, you hold open the eyelids, you hit the fire button, and you're done. And once you then process the data, it is then presented in a set of comprehensive maps and parameters. But what we've done on top is we collaborate. We're an open platform collaborating with any lens manufacturer willing to work with us. And up to now, there's more than 20 of them, and more than 40 lenses have been integrated, have been connected to. And so we are capable of creating intelligent fitting algorithms that match the front surface of the eye with the back surface of the lens. And so they will suggest the best fitting lens right away. Excuse me. So you choose your own lab that you prefer to work with, of course. You're always in control. This device will never tell you who to work with. That's up to you. And of course, it will also, from region to region, there will be some regional differences. So, and once you've selected your lab, you then go down to the lens type, because many of these labs, they have various lens designs. And don't worry, we have a big team of professional affairs specialists helping to train you up and to make those decisions, to help you make those decisions. You choose the lens diameter, you click on calculate, and this is the outcome of the smart algorithms that will match the front surface of the eye with the back surface of the lens. And except for the over refraction, you basically now have a lens that you can order. And of course, it's always important that you, when you receive the lens, that you fit, right? That you put the lens on the eye and you verify that everything is okay. We're dealing with the regular surfaces here, so this will never end up in a supermarket somewhere with a 3D printer. You are the specialist. The purpose of this device is to empower you with the 3D data and the algorithms. But this is always going to be you that is in control. And we have a direct connect feature that will allow you to push all of these parameters out to the lab and have them process the order. And so we keep on adding more labs and more lenses to our program. And we're very excited to have first device in India right now with LV Prasad. And unfortunately, COVID delayed the process there, as you can understand. But we are well on the way there to get some studies done. And they are, of course, very interested in integrating this into their specialty lens practice. And we look forward to making more steps in the coming year into providing ESP services into India and into the other parts of the world. And that concludes my very quick introduction. We are on Facebook, we're on Instagram, we have our website, eagleteye.com, and contact me on info@eagleteye.com. Always interested, and we love to hear from you. Thank you so much for this opportunity.
Thank you, Arnold. It was so wonderful. Arnold is very nice, kind person. He's friends with me since many years, and this instrument is amazing. Because it combines both.
Thank you.
Apart from your scleral lenses, you can do orthokeratology, you can do so many things. It will help you understand. And the best part is your guesswork is out of thing, because right now, whatever lens you have, you're putting it, you are seeing whether there is a compression, this, that. Even in my case, we have been fitting spherical haptic scleral lenses. Since last 2 years, almost 50 to 60% of my scleral lenses are toric haptic lenses, because you need that. See, the sclera is not spherical, it's toric. And with this instrument, there is so many ups and downs and everything that is captured. 5 lakh data points are captured. And the whole thing is fed to the CNC machine in whatever lab you select. It's a perfect fitting lens. You can decide exactly how much clearance you want, 250 microns, 350 microns, whatever you decide, the lens is going to, the manufacturer is going to produce exactly same. So fitting is done on the first, as the power depends. If you calculate the correct power, your first lens is final lens. Thank you, Arnold, for being supportive and sponsor for this meeting. And hope to see you next year in person here.
Yes, I'm very much looking forward to that.
Thank you. Machine cost. Arnold, you're there?
Yes.
So Dr. Ajit is asking what is the cost of the instrument in India?
I'm sorry, I'm not sure about the cost in Indian rupees. Euros, and it would be $26,000 US dollars, which is about 22,000 euros.
So about 20 lakhs.
That in rupees.
Yes, about 20 lakhs rupees. Plus shipping or whatever is your thing. But
yeah, usually we take care of the shipping costs, and of course for each region, for each country, there's certification required, and so we're working towards that for India as well. Yeah.
We welcome you to India. Please bring your instruments to Indian optometrists, ophthalmologists. There are a lot of centers, and I'm sure you're going to do great in India. Thank you.
Wonderful. Thank you so much.
Thanks. Any questions for him? Thank you, Amod. Okay, so let us move on to the next presentation. Next. Here. She's from Sangli, Nandati Bai Hospital. She was supposed to come, but she had a lot of cases, so she's recording from OT.
Good morning, everyone. I am Dr. Seema Mani Kundwilkar from Nandadip Eye Hospital and PG Teaching Institute, Sangli, Maharashtra, India. Today's my talk is about scleral contact lenses in Stevens-Johnson syndrome patients. First, let me talk about Stevens-Johnson syndrome, which is a type 4, very rare hypersensitivity reaction secondary to the drugs like sulfonamide, nimesulide, fluoroquinolones, or any other drugs which is patient allergic to. Also, some viral infection like mycoplasma pneumoniae can lead to this syndrome. This can be a serious life-threatening, almost 30% of death rates. There is an involvement of mucosa and skin, particularly the target lesions, and this can be a very severe kind of reaction. The mucosal involvement can be of eyes, nasal mucosa, oral mucosa, ear, genitourinary mucosa. So regarding the mucosal involvement, it is only the ocular sequelae which remain in the chronic SJS patient. Almost all other mucosa gets healed. This is one of my patients whom I diagnosed during her acute SJS condition. This patient was wandering here and there with the acute conjunctivitis. When I saw the patient had the severe excoriation of the lid margin. I removed her mask to see the oral mucosal involvement, and also when asked in depth, history reveals some skin lesions also. So why these things are important in scleral contact lenses, as these lid margin excoriation in chronic SJS will lead to the healing of this lid margin. The skin over the lid will encroach on the conjunctiva in the eye that will cause the lid margin disturbances like trichiasis, entropion, keratinization, and these will cause problems in scleral lens fitting. So what happened in chronic SJS? This is an irreversible cicatricial disease. If not handled properly, the subconjunctival fibrosis may lead to the symblepharon, total symblepharon, almost closure of the eyes in these patients. Subconjunctival fibrosis lead to the loss of goblet cell, meibomian duct fibrosis, lacrimal gland duct fibrosis, and this in turn leads to the severe dry eyes. And here where the scleral contact lenses play a major role in these patients, as this is an irreversible condition. So with the medication, it is not possible to treat this condition. So they need some substitute for the dryness, where the scleral contact lens plays the major role. Also in chronic SJS, there can be recurrent chronic inflammation, which has to be taken care before patient goes for scleral contact lens fitting. Even during the use of scleral contact lens, patient may have the recurrence of these inflammation, which has to be taken care properly. The subconjunctival fibrosis, fornical shortening, these fibrotic bands may cause problem while scleral contact lens fitting, which has to be taken care in this patient prior to the scleral contact lens fitting. So scleral contact lens fitting in this patient is not straightforward. You have to take care many other conditions before you go for the scleral contact lens in this patient. Lid margin, as I have told, these chronic changes in lid margin causes the keratinization. This is one of my patients whom I operated for mucous membrane grafting. That patient had lid margin keratinization, and this keratinization, the lid margin effect on the cornea causes the corneal changes like punctate epithelial changes, ulcers, or epithelial defect, vascularization as they continuously rub. So this has to be taken care before you go for the scleral contact lens fitting. So usually in such patient, what I do, if patient's puncta is open, then I go for the punctal cautery, as this is a irreversible cicatricial disease. So punctal cautery take care of part of lubrication, as whatever lubricating drop they put in the eye, that stay for a longer time. Along with that, lid margin changes like keratinization. I operate patient with mucous membrane grafting, where mucous membrane from oral mucosa is used to get implant here. And then once this is done and patient surface gets little bit better, then scleral contact lens fitting is done, as these lid changes also can hamper or change the fitting of these lenses in these patients. Other changes like trichiasis or entropion also has to be taken care prior. In cornea, vascularization like superficial vascularization has been shown to be reversed with the continuous use of scleral contact lenses. Opacity causing the diminution of vision can be improved. The vision can be improved with the scleral contact lens fitting. Also central thinning, secondary to constant epithelial rubbing, persistent epithelial defect or ulcers over the period of time, there can be thinning, which also can have some changes while you are fitting these lenses, patients with the scleral contact lenses. And also few patients which has the persistent epithelial defect, they may improve with the scleral contact lens uses also, as scleral contact lens act as a bandage. So acute SJS in India, it is not a routine practice to use scleral contact lenses in acute SJS, but like in this patient, scleral contact lens can act as a bandage, which will help patient to improve their healing, and this will cause there won't be any symblepharon bands, at least in this patient. This patient I managed with the total amniotic membrane graft almost twice or thrice. Patient underwent the surgery. Now patient is doing well. But scleral contact lenses can be used in acute SJS patient. In chronic SJS patient, scleral contact lens acts as a bandage, as I have told. The precorneal fluid layer in the scleral contact lens take care of the severe dryness in this patient. The vision improvement is obviously there, as it gives a better optical surface for this patient. Cosmesis gets improved, as severe dryness and constant redness in the eyes causes bad cosmesis in this patient. Also the freedom from the drops, as their maximum lubrication is taken care by these lenses, the patients are much more happy. So what these lenses do, this is one of our patient, ASOCT of this patient, that this is a lens, this is a precorneal fluid layer, and this is a cornea. So there is an adequate sealing on the scleral zone by these lenses, and virtually any topography can be fitted in these patients, and there is no prerequisite for the close alignment between the corneal surface and the lens. These lenses are stable on the eye irrespective of optical power, and there is no localized exposure due to disrupted blinking, as these lenses take care of the cornea. Maintenance is usually straightforward. But in some patients with severe dry eyes, the lacrimal fluid quality is poor. So there is a chances of dehydration and degradation. So this can be taken care with the lubricating drop over the lenses. The lenses can be subjected to the deposition, which can be easily cleaned and polished as necessary. And these lenses, as they act as a bandage surface, so they take care, they give complete protection from the lid margin disease. And this tear reservoir provide optical neutralization of corneal surface irregularities. So what are the few obstacles that the few patients experiences that few of my patients were complaining of drying of scleral lens surface and in fact increased frequency of lubricants. As what happened in this SJS patient, it is a severe dry eye. So even if you put a new surface, that surface is going to get dry. So patient has to put some lubricating over the lenses, and the lens is a little bit elevated over your normal surface. So there may be increased frequency of this lubricating. So what if punctal cautery is done in this patient beforehand? So whatever lubricants they are putting, they will stay longer in this patient, and the overall frequency also decreases in these patients, which I have observed. Because of the large size of lenses, which is not much problem right now because there are many miniscleral lenses are coming, but staring look can be a problem for the patient. The turbid precorneal fluid, as the severe dry eye patient has the mucoid discharge in their tears, this will patient has to change the lenses frequently, but the frequency is not that much as they were used to put drop frequently. So for them, twice or thrice in a day, and plus overall use of their scleral lenses is for 12 to 14 hours, which will give them more beneficial effect with the lenses. The patients which are more demanding, like those who are surgeons or IT people, for them this turbid precorneal layer will cause colored halos or decrease contrast while working. So they have to just remove the lenses, change the precorneal layer, change the saline in it, and then they can take the maximum benefit through these lenses. If those who are working for a longer period and they forget to put lubricating, the lenses may get stuck. One of my patients also had lenses stuck in the eyes in the night. It was a real bad nightmare for the patient, but we have to counsel the patient. Increasing lubrication and just putting more drop of saline can help patient to remove these lenses. If it is not possible by the patient can come next day and it can be removed in the OPD also with the help of the syringe and the saline. So there are different people have different experiences. From India, LVPI, they have used BOSP for therapeutic purpose in SJS patient, and all the patients had relief from symptoms of pain and photophobia. There is paper on the for the pediatric patients and they have shown over 2/3 of their pediatric patient improved significantly with the PROS treatment, and there was significant improvement in the vision, and lens was durable over a period of many years. And for the pediatric patient also, the initially parents are trained and later on the children pick up so fast about the fitting of these lenses. And there is one more paper about tear exchangeable limbed rigid contact lens, which has shown that patient day-to-day activities also improved except the driving ability. But I have seen many patients which are driving normally with these scleral contact lenses, and there were no adverse reaction. These were different kind of limbal rigid contact lenses for the SJS patient. Our Nandadi patients, there is a 21-year-old female who had the SJS during her childhood when she was around 4 years of age, which was not managed properly. Now she has total keratinized surface and multiple symblepharon. We could able to fit her lenses. Post lenses, she had her vision improved to 3 feet in both the eyes, but she was more happy with the lenses as it took care of her pain and photophobia and dryness. She could at least open her eyes and do her day-to-day activities. One of her 47-year-old patient and 36-year-old patient, both of them right eye improved to 20/80, and the left eye they had severe keratinized surface, but where they had the improvement in photophobia but not the vision, but they are happily using. And this is my patient which I diagnosed her in acute SJS and managed well. So now her vision is improved to 20/80 in right eye and 20/20 in left eye. And in her right eye, to mention about, she had some epithelial defects, some infiltrate which were managed properly, and she was while wearing her scleral, when her trial of scleral lenses was going on, she did had some epithelial defect, but during the trial, in fact, the epithelial defect improved and it heals. It has left some opacity. Because of that, her vision is now 20/80, but she's happily using both her eyes, and it is giving her much cosmetically better life, and also the productivity of her life is increased. So thank you everyone for listening me carefully, and I hope my knowledge about scleral contact lenses in SJS patient has helped you to upgrade your knowledge. Thank you and take care.
Dr. Seema, are you there?
Yes, sir. Can you hear me?
Yes. Can you put on your video?
Yes, yes.
That we can see. We really missed you.
Yeah.
But thank you very much for being there now. Dr. Seema, I know her since many years. She herself is a Stevens-Johnson syndrome patient. When she was in medical college, I think she came to me, and that time she was scared with what to do, because she's now medico and don't know what to do, but she selected ophthalmology as a specialty. She did fellowship, and now she's doing fantastic. She started, actually I started one the Stevens-Johnson syndrome group. We started that, but now I'm not much active. So she has started and taken over the lead, and she's helping so many Stevens-Johnson syndrome patients. Being herself experienced and gone through all that trouble, she knows exactly everything, and she's doing really fantastic work. Of course, we saw her in presentation. Dr. Seema, you want to give any comments or anything, please, floor is open. Anybody wants to ask any questions, please.
Hello, Seema. Seema, this is Dr. Quresh from Sydney.
Yes, how are you, sir? I'm fine.
Yeah, missed you today. Seema, we had this Maskati Chawan training for Stevens-Johnson syndrome, in which we found that those who have got complete keratinization were really not much help with the scleral lenses. So we used to not give them the scleral lenses in the series which I will be presenting later today. But you have shown that even in these completely keratinized patients, they did have a little bit of the improvement in photophobia, and therefore it's still worth giving a trial. I actually have stopped giving trials to those who are completely keratinized. Are you still willing to put the lens in?
Yes, sir. This patient actually, the first patient which I spoken, she was she first, when we gave her a scleral contact lens trial, actually when she wore the lenses, she was much happy with the lenses. Problem with this total keratinized surface patient, that because of their keratinization, kind of constant rubbing or some kind of epithelial defects may be there, so they are having a lot of photophobia or pain. So these lenses, they almost took care of pain and photophobia, and little bit 2 feet improvement in vision could help her do her day-to-day activities. So in other two patients, there were left eye was totally keratinized. So it was kind of comparing the right eye with the left eye. So they did not take for the left eye, but right eye they took it. So those patients for bilateral, they may have some improvement. For them, the day-to-day life at least get changed with these lenses.
But I think that means it is not fully keratinized. Means if they are still feeling something, that means there is still chance of, that means there is some stem cell still left. But that was our cutoff point. If it's a keratinized cornea, then it is a case for Boston Capro or actually Pintucci keratoprosthesis. Dr. Maskati has operated many such patients with Pintucci keratoprosthesis with very good result. Even that one lady got 6/9 vision, without any additional correction. So, that was our cutoff point. But yes, later in day, Dr. Maskati will be talking about grading system, which we developed. And I think in India, we have the largest series of Stephen Johnson syndrome patient after LV Prasad, Shankar, Dr. Sangwan. But they didn't did much of a system or something. They fit lenses. Of course, he has presented few papers also. But this is the last resort for Stephen Johnson syndrome patient. It's amazing. It's a dramatic improvement in their quality of life. When they enter in, I don't know whether you have seen any Stephen Johnson syndrome patient. So when they walk in, their closed eyes, head down, really in pain. Every blink is a pain. And when you put the lenses in, slowly their head goes up and the photophobia is gone and vision improves. So it's really amazing. So Dr. Seema, can you?
Sir, I wanted to share that experience.
That is what I was about to say.
The first time when I saw Dr. Chandrashekhar Chawan, and he put me on lenses, I think I was 6/60 without this and with my head down and with almost my all confidence lost, because I got the good, but I was not knowing what field to choose, and I wanted some surgical. And when he fitted these lenses on me, my vision completely improved 6/5. So I was like, okay, now. And Quresh Maskati sir, he told me that your cornea is crystal clear, that you can take ophthalmology as your branch. So it's kind of a life-changing experience, at least for me. And I know, as I'm seeing so many Stephen Johnson patients, so it is actually a life-changing experience for them, because considering the lubricating drops available in the market, there are almost none drop which can give a long-lasting effect. And plus, there are no regenerating factors we have as of now in the medicines. So for them, this helps a lot. It is almost life-changing for each and every Stephen Johnson patient.
Thank you, Dr. Seema. We really missed you actually, but maybe next time.
Yes, sir, sure, next time.
Hats off to you, Quresh, Maskati sir, and Chandrashekhar. This is what we, dramatization or filthy style experience that we are having, that both patients is now another super specialty.
Yes.
Ophthalmologist, and what kind of confidence he must be generating in her own patients.
Right.
After that traumatic experience and losing all that confidence, intelligence is what she had, and vision is what you gave. So, on every Stephen Johnson patient, we have to thank both of you for doing that human work for the last 20 years.
See, the actual story goes like this. When I was doing fellowship with Dr. Perry Rosenthal, we used to get at least 5 to 6 patients per month traveling from India to Boston for Stephen Johnson syndrome treatment. And this being a non-profit organization, they used to take care of their, hotel, food, everything. So they said, instead of, getting them in US, why don't we start this facility in India? And that's how we invited Dr. Jitendra to Boston, and then he saw himself that this is working, and being a cornea specialist, he immediately said, yes, we'll start in LV Prasad, and that's how we got this technology in India. So the main driving force was Stephen Johnson syndrome and not keratoconus. Thank you, Dr. Seema, again, and let's move forward with the next.
Thank you, sir.
It's 1 o'clock. Do you want to break for lunch, or shall we finish this in quick? After because yesterday we lost a lot of time in discussion. Huh? Ek talk karu na? Huh? Subhash, people are feeling little cold, so thoda sa AC. Okay, so this is kind of a history which I was talking about. So let us go into a little more detail. So Don Ezekiel from Australia, he's an optometrist. He was from UK, but he's moved to Australia, and he's called as a father of scleral lenses because he's the one who he started with the fenestrated scleral lenses, because that time there were not high decay materials available. Plastic was the only choice. And if you know the history of contact lenses, it started with a scleral lens, and then it became smaller. Actually, it was a glass lens, and the mention of scleral lens goes back to Da Vinci. In his drawings is mentioned about that. But the reality, somebody actually got into practice, is Don Ezekiel, and I was fortunate to learn from him. In fact, yesterday I was sharing the same story. Dr. M.S. Sridhar at LV Prasad is no more, but he was cornea head, and I was invited to set up a prosthetic lab in LV Prasad. So they gave me an air ticket from US. I stayed in LV Prasad for a month and trained Kuldeep and Deepa, if you know Kuldeep. So they were my students, and then after finishing my training with them, then I was free because I used to stay there. So one day I met Dr. Sridhar, and I used to carry Dr. Maskati's Pintucci keratoprosthesis in my pocket all the time, because that opens door to anybody. So I went to Dr. Sridhar and showed, hey, this is the Pintucci keratoprosthesis, and this is, yeah, I know everything, this is, but I'm not interested in keratoprosthesis, because not all corneal surgeon will dare to enter into that thing. But he said, I'm interested in scleral lenses, because he has recently visited, he came from Moorfields Eye Hospital, and he has seen Kane Pullam, who practices scleral lenses. Of course, he's thick lens, another thing, but he was impressed. He said, if you can get something like this, it will be really wonderful for cornea patients. And that's how my journey started. And Don Ezekiel shared all his presentation papers, everything, thanks to Ashok Pradhan of Flexilens, who was also in UK. That's how he knew. And then I designed the lenses, fenestrated lenses. Actually, I cut my own lenses. I bought a small lathe from him. Dr. Perry Rosenthal and Polymer Technology refused to give me buttons. You need large diameter buttons. They said, we make only for Perry Rosenthal, not for selling. Because that time not many people used to make scleral lenses. So I had to catch hold of my friend, Dr. Anil Chawan, who was doing polymer technology, the PhD in polymer technology, UD So he helped me to learn polymer technology. I learned myself. I prepared my own oxygen permeable material, which still I use for my prosthetic scleral lens and all. And I cut the lenses. I made about a 24 lens fitting set. And then Dr. Srinivas Rao at Shankar Netralaya invited me to give a talk, and he arranged few patients, and that was life-changing. Keratoconus patient, you put a scleral lens and the vision improves dramatically, and that gave confidence to everyone. Then Usha, Dr. Gyanchan, Rekha, yes, Dr. Rekha Gyanchan, Bangalore, thanks to Maskati sir again. So she said, okay, you come and I'll arrange some patients. So in Lion Eye Hospital, she arranged almost 30 patients one day. It's like a eye camp. I just put the lenses. Wow, everybody was like, wow. And that of course gave me also confidence. And then I think almost I treated that time over 55 patients successfully with fenestrated designs. But then some corneal surgeon do not like that air bubble on the cornea. The moment you have a hole, there will be an air bubble, and that's how you're supposed to fit it, because it doesn't cause any suction effect. You don't have to put any saline. It's very easy. You just insert it and it works. In fact, we are now again launching it in the US for pediatric population and penetrating keratoplasty population, which is going to take care of all the suction and other things. So coming back to India, so it was really nice. And then we used Bob from Denver gave us an Tyro 97, which was 90 DK fluorosilicon material. Now that company has been taken over by Minicon, I think. So Flexilin started manufacturing with my designs, and we started giving it to so many. Dr. Maskati and myself did almost 50 patients, and we published this in article in BOA journal. And of course, then during the conferences when I used to talk about it, and if there is an international speaker, international ophthalmologist, they used to say, you must meet Perry Rosenthal. And incidentally, one of the patient who from Oman, he met me. He wanted to go to US, but he could not get visa. So that's how he came to me, and he told me again. So I heard Perry Rosenthal from so many people. And I said, okay, let me see if I can go. And one day it happened that it was not planned, but I had few days of extra time. So I went him, and then all the rest is history. I just stayed with him, and it was really wonderful. So we started scleral lens, starting with the fenestrated, then of course the fenestrated lenses, and then we call it a fluid ventilated lens. Now nobody calls fluid ventilated. Like when you say contact lenses, it was corneal RGP. Now you have to mention corneal RGP to differentiate between scleral lens. So like that. Now the scleral lens is scleral lens, unless you mention a fenestrated scleral lens. So we are launching this in the US now with the brand name of Chandra Windows scleral lens. Windows means holes. So this is good for PKP and pediatric population, and of course it will work in keratoconus patients as well. So I was the first fellow of Boston Foundation for Sight, and that's how I told you the story. We bought the technology. In India, I used to travel to Shroff Eye Hospital, Delhi, Narayan Netralaya, Rajan Eye Hospital, Shankar Netralaya, LV Prasad, of course, and it was very busy. And then now, of course, almost most of the optometrists and ophthalmologists are convinced that this is a modality for treating keratoconus patients, and it is working fantastic. I trained Samir Ganu, I sent him to Boston. Then Prasad Chawan also, I sent him to Boston. And I trained few other optometrists and even ophthalmologists. I stopped going to LV Prasad, and then Dr. Vasharati, we sent her to Boston for a fellowship, and then we again started scleral lens department there. And then from Shankar Netralaya, Rajeshwari, she's no more now, but she went to Boston and did fellowship. So far only 5 of us are fellow, but I encourage any of you who's interested, write to them. Karen has given her number, write to them. You can go there, do the fellowship, learn firsthand, and bring the technology here. Of course, the technology already here. You can always go to LV Prasad and learn the same thing, but it's a interesting thing if you can go there. Then I requested Blanchard, Jean Blanchard, and got this MSD lenses, that is mini scleral device. And don't mistake this mini scleral lenses with the mini scleral what we have in India. So the Indian mini scleral is not a scleral lens; it's a corneoscleral lens. That's why you will find some issues with that. The scleral lens has to land on sclera and do not touch cornea or limbus. So that fulfills the MSD lens, and that became popular in the US. Today they are the leaders in scleral lenses, and of course now there are a lot of other people came in, but they have a lot of like 1 feet lenses, and MSD, a lot of different brand names for different application. Rose K is still there because that is the cheapest thing, but I don't like any contact lens on that compromised cornea. Keratoconus is a compromised cornea. So you are putting that lens which blinks like 12 times, goes up and down, and is going to rub on the cornea. If you have already fitted such patients, you know every 3 years to 5 years, patient will come with a severe intolerance. What is happening is cornea is giving up. It don't want that lens. And you say, okay, you discontinue lenses for a month or week or so, the cornea heals back. Second episode happens and patient gets permanent opacity. Most of the cones are in a visual axis, and if you have a permanent dense opacity, the patient has to go for penetrating keratoplasty. And again, that's a different story. So instead of that, if you switch over to a scleral lens, that will be, you're doing a benefit or help to them. Of course, we still have a mini scleral lens from Silverline Lab, and you can still try your hands with this. It works fantastic anyways. Rose K became, because now nobody is using much about Rose K lenses. So he came up with Excel Design. So Excel Design, again, because he was a still cornea guy, Paul Rose. So he thought, why not make a large diameter? And it was a corneoscleral lens. So same problem with Silverline. It doesn't work. It's not that comfortable. And since it is touching on the limbus, long-term complications will be there. This is the best lens that we have available in India at par with the US. And, this is the best thing that you can have. Of course, they have 16 mm to 19 mm, depending on what kind of condition it's. If it is a simple, less ectatic cornea, you can go with 16 mm. If it is very too much of a ectasia, then you have to consider large diameter. Aculens is also present in India. I think there are some distributors. So that lens is fantastic. I bought some fitting set from them, Maxim 3D, which you saw in Shalupal's presentation about the laser marking, and you can decenter the optics and everything fantastic. So that's a very, very good lens that is available in India again. But the lenses come from US, so the cost is little more. And in 2022, we'll be launching the fenestrated lenses also. So you can go on their website. There are, a lot of educational materials, and you can get yourself certified also. See, in America, you have to get certified with every lab. It's a good thing, and it's a free. You can just log on to them, get certified. You have a one certificate, and you know how their system works. iPrint Pro, of course, we had lecture by Christine herself. iPrint Pro, iFit Pro. So iFit Pro, that's where you need the eye surface profiler, and that will be connected, and then you'll get a exact fitting lenses without impression. We are going to do some impression today in a practical session, but if you have this Eaglet topographer, you are done with it. It's very simple and easy and works fine. And as I said, it will cost about 20 lakh rupees or so. Of course, you need to take care of the lenses. So Yashwant has yesterday presented about practical thing. Boston Simplest solution is the standard as of now, but hydrogen peroxide system is actually standard. Unfortunately, the company closed everything. I tried to introduce hydrogen peroxide, then I tried to introduce hypochlorite solution, but now since COVID, everything is shut down, and I'm in US now, spending more time. So, but maybe the company come back. Some other companies may come back with hydrogen peroxide. If that comes, of course, there are from Amazon. You can still buy Clear Care solution, that is hydrogen peroxide. Little expensive, but that is the real care system for scleral lenses. It's of course the best device for vision and comfort. It acts as a liquid bandage lens, mitigates pain, photophobia. If you become a specialist and fitting this, you stand out of the crowd. It's a very satisfactory field. Your patient thanks you. Of course, it will generate more revenue also. If you're working with ophthalmologists, both of them will be happy. And I strongly recommend, of course, since you are here, that means you are interested. And hopefully with this knowledge, you will at least venture into the scleral lens and orthokeratology and myopia. Thank you very much. You have any questions? Huh? Your turn. So Savita has come all the way from Chennai. So she's fitting Boston scleral lens also and Aquilens. Okay, I think we'll break for lunch and then, yeah, go ahead. Subhash, lunch ready?
Yes. We are talking about so many trial sets and everything. But what's your take on if somebody is okay with same company's trial set? So do we need to modify? Do we need to have how many trial sets to have a good?
Very good question. So to start with, you start with any company trial set and a normal, fluorescein and a slit lamp. You will be able to start fitting lenses. No problem. But once you start the lenses and venture into that and land up with complication, then you will need to modify the lenses, modify the design. If your company is willing to work with you, that's fantastic. There are people who have been successful with staying with only one company. No problem. But as you advance, see, today I have 5 fitting sets. You have to invest in your knowledge, and then, whatever is available, like every company has something different, right? That's why they are there. Okay. Now let us take AccuLens, right? It's the best lens. I've been talking good about it and all, but they don't have eccentricity, right? So Boston site has eccentricity, right? So you can choose, but not all lenses you want of Boston. Reverse geometry lens. Correct. So Boston site don't have multifocal lenses, reverse geometry. So there they have, everybody has their own little bit of limitations, and that's how you, once you come across that kind of patient, then you want that extra lens. Okay. Of course, you need one equipment at least, right? Then you start, and then you eventually you yourself will keep on buying. If you don't want to invest into fitting set, invest into the iris profile, eagle eye, because then you just need one fitting, any company fitting set just for to get the refraction, and then it is like best thing. But see, when you are investing so much into you better have some fitting set with you, right? Anyways, we need a fitting set to do all the refraction. Right. See, the profit margins are also more, so it is like you have to give that back to the society also, right? So don't try to compromise on your equipments. If you don't have good equipments, how can you give the best to the patient, right? Then you are compromising. When we started RGP fitting lenses, I think ask Yashwant also, 5-6 fitting set he may have sitting at, now he may not be using it, but it is there. 8 mm diameter, 9 mm diameter, 9.4, right? You still have those. Yes. Repeat again. Yeah, chalu hai.
I said my father is talking at this, and over a period of last 40 years, we have accumulated 1100 trials.
See, so that's how it works, and he may not need it now, but one particular patient will come and you'll say, oh, okay, I have this, let me try, right? And it works. I think yesterday you told about one patient and you had some lenses that was in stock and you just gave him the lenses and patient is happy, you are happy.
In fact, in earlier days, we used to do this only. First order of PML lens, and once that fits, we experiment with PML lenses, and once that fits, then we can turn into RGP. Even today, I do it for people. And I think that is the best way of learning RGP also. I used to tell don't attend theory classes, that's not important. But
practical.
Order one patient, order one proper fitting RGP lens, then order 1 step C4, 2 step C4, 1 step factor, 2 step factor, 1.5 millimeter larger, 0.2 millimeter larger, 0.2 millimeter smaller. So all possible combinations. So just by looking at the fluorescein pattern, you should know, okay, I need to go 2 steps back. So you should be thorough. So order these lenses, then own learning. See, he experiments so much and spends lakhs of rupees. And I was just telling somebody yesterday, somebody asked me, how's your orthopedic practice? And I said, my orthopedic practice right now is minus 3 lakh rupees. So I've not made any profit and I've made a loss of 3 lakh rupees. Because for one person, I'm ordering 3 pairs of orthopedic lenses, one from this company, one from that company, just trying to see, which matches, like my designing and that lab's production, which matches. So all these experiments you have to do in the initial phase of your practice.
See, unless you invest in yourself, you cannot become master. Right now, in fact, he's invested $500. I brought some books. Even I don't need those, but he's invested because even I was asking why you are, but that is his future. That with that $500 books, he will help so many patients and he may make 50 lakh rupees. So it is your own, you are investing in yourself. Even these conferences, you are investing in yourself. This will help you to learn. Even I learn every time I listen to Christine or, all the speakers, or Tom or Melissa. You always get something, different and it helps you. So education and, invest in yourself, right? So one more point, now don't invest in RGP trial sets. Frankly, I'm telling you, it will be absolute. Try to give scleral lenses because that is the best. You are going out of the cornea and you are going to take care of a lot of complications that will not happen because of the RGP. Plus, you will make more profits also. Another thing, there is a story like in our oculoplasty and even cornea, we used to say, oh, you get a lot of alkali burns, that tuna, right? And we always blame why they make that, right? Because that tuna ka thing, you press it and accidentally it goes in the eye. So it should be banned, right? So somebody has to stop giving it, then only like plastic bags, right? They should not manufacture itself less than 50 micron, then there won't be anything available. So same thing, when I took over Pradhan's lab from FlexiLens, first thing I did is I stopped PMMA lens giving trial sets. Okay, because like what you did is correct, but that was a cost-cutting thing. But again, if you try with PMMA and order high oxygen decay material, it won't fit the same way. So ultimately, you're landing with the same. So better you try the fit. My fitting sets only was Boston X. I knew what is good, so I changed. I could change. So now you are entering into that. So why to give the old technology? See, I have nothing against with rose scale, but it's an old absolute technology. It was good 30 years back. That was the best technology for keratoconus patients. But today, you don't need that. You need something better. And the price and the cost and affordability, it's all in your mind and the patient's mind. I'll give an example, the cataract surgery, right? You can get it done for 5,000 rupees also, and free also, CAMS also, and 2 lakh rupees also. Same, right? But it depends on who's operating and what, facilities they have, what they're offering. There's so many things. So it's up to you. You offer them the best of the best, decentered optics, 120 DK material, this, that. See, patient doesn't know. He came to you with, okay, I have a problem, you solve it. Now it's up to you how you want to solve the problem.
Can I just ask, how much approximately are you charging for RGP patients? 5,000, 3,000, 5,000. Now just imagine this patient comes to you, you click a picture, you show that picture on the monitor, saying that there is excess of forces there, the lens is touching there. Then you take another photography. When you virtually design that lens in front of the patient is sitting next to you, and you explain everything. Oh, now I need to reduce the clearance here, I need to reduce the layering here. How much do you think the patient will pay? More than double, exactly. So when you use technology, the patient knows that he's getting a better lens, he's getting a safer lens, the vision is going to be comfort and vision are going to be better. So why not use technology to upgrade the practice? So what earlier I was doing using PMMA lenses, now I do using the practice. I very recently read a case,
See, I can add one more. So 5,000 was your maximum range for corneal RGP. Same patient, you fit with a scleral lens, you can add one more 0, right? So profit margin is same, but it is into, suppose if you are charging 2 times or 5 times or 3 times, whether you charge 100 rupees and charge your cost is 100 rupees and charge 300 to the patient, or 10,000 rupees and 30,000. So that is also, of course, we'll keep one.
I will attempt to upgrade from 3,000 to 15,000 and then you are
Sure, yeah. Yeah, I can give them a cosmetic scleral lens. See, this is what the idea is. You fit them with the scleral lens first. Okay, now the vision problem is solved. They're comfortable, everything fine. But they have a life, right? You have improved their quality of life, but people want something more. So that is what I'm offering in the US. Like, okay, then you add a cosmetic in the scleral lens, add one more 0, and the patient is happy, you are happy, right? Everybody's happy. If they can't afford, if they don't need, then of course no problem. But there is always, you provide them that this facility is there, and you will find takers. Yes. Yeah, people are going out of space. Is there a need? No. But yeah, if you can do it, why not do it? Okay, let us break for the lunch and come back quickly. We'll take only 30 minutes, not like yesterday's 1 hour. Okay, 30 minutes. You can bring the plate here, and then we'll start the next presentation. That will be nice. Okay. You like the lunch? Food is good. Yeah. 5:30. See, you're close from here, so you book online everything. So 5:30 from here, you take a taxi. 6 o'clock you'll be at the airport. 2 hours before. Speaker online. काय म्हणतो? Speaker online आहेत का? मग त्याला पोस्ट कर. केलंय का? ठीक आहे ना, लंच करून पुन्हा आपण So you designed the complex. So ask them to put a channel. They may not be able to do it, but please look. Because now everybody has that capability. अगर नहीं है तो मेरा पूरा दिखना नहीं है. I'm an ocularist also, so I have all the equipment, I have lab also. So I'll order the lens from Boston Foundation with the extra lens, and I will take them my drill and I'll cut it off and polish it. You can still do it, but you should have the polishing. Activity is for a decent job. This is actually company activity. या माझ्या लॅपटॉप दादा यांचं सरांचं लॅपटॉप हे आधी लोड कर. सरांचं प्रेझेंटेशन लोड कर.
Buenos días, desde Colombia les habla César Augusto Rodríguez en Bogotá. Primero que todo quiero agradecer al doctor Chawan por la invitación y por participar de este excelentísimo panel de expertos en lentes esclerales. Un saludo desde Latinoamérica para el mundo. Para iniciar, quisiera comentarles que la población mundial estamos llegando casi a 8.000 millones de personas, de los cuales más o menos el 9% somos los latinos. El incremento de la población del mundo aproximadamente supera en la región latina a Estados Unidos y a Europa, ya que crecemos más o menos a un 1% anual. El promedio de los pacientes de consulta para lentes esclerales está entre los 15 y los 64 años, lo que equivale al 65% de la población mundial. Tiene un 40% aproximado de aumento en las adaptaciones de lentes esclerales en el mundo. Y en todos los segmentos de lentes de contacto se muestra un incremento estimado al año 2026. En este momento el 89% de todos los lentes de contacto son lentes blandos y el 11% son lentes de contacto rígidos. Dentro de los lentes de contacto rígidos el 13% muestra un incremento en la adaptación de lentes esclerales únicamente superado por los lentes de Orthokeratology. Eso nos dice la importancia que le estamos dando los profesionales en contactología a la adaptación de lentes esclerales. En el mundo, el 62% de lentes de contacto son adoptados en América. El 43% de esos lentes son correctivos y el 55% de esos lentes son esféricos. Las multinacionales se dirigen en sus mayores ventas, en sus mayores inversiones a los países que más posibilidades tienen para comprar. Y el ingreso per cápita de las personas en Estados Unidos supera 8 veces los ingresos per cápita que tienen las personas en Latinoamérica. Los gastos en salud también están asociados directamente a la inversión que pueden hacer las personas por su ingreso per cápita. Y se ve en este mapa que el ingreso o la inversión por salud se da en lugares o en regiones de gran impulso económico, Norteamérica y Europa, y en zonas como Asia Meridional y África, en donde las limitaciones hacen que los gastos en salud sean reducidos. Las inversiones entonces de las multinacionales están asociadas directamente a la renovación de los lentes de contacto. Y ese mercado en Estados Unidos, por ejemplo, tiene asegurada una reventa del 34%, mientras que en Latinoamérica solamente del 16%. El mercado de lentes de contacto esclerales a nivel mundial ocupan más o menos entre 70 y 80 mil pares de lentes al año, y en Latinoamérica el número se viene incrementando progresivamente, llegando a ser más o menos un 7% del mercado mundial. ¿Cuáles son entonces las dificultades que nosotros los contactólogos en América Latina realmente tenemos para incrementar nuestro número? Lo primero, pues que los laboratorios externos, o sea, los laboratorios productores de lentes, no tienen casas matrices en Latinoamérica, lo que hace que ellos realmente vean a nuestros países como de poco impulso y de baja rentabilidad. Los laboratorios propios no adquieren tecnología y obviamente eso se debe a que haciendo ellos diseños propios, a pesar de que sepan que no llegan a ser tan perfectos en la adaptación, solucionan en parte los grandes casos clínicos que podemos tener. Y realmente no se encuentra en perspectiva ningún tipo de inversión adicional que se haga por parte de los multinacionales. Uno de los grandes actores de nuestro trabajo a nivel de Latinoamérica están en las inversiones de representantes comerciales. ¿Qué hacen? Pues obviamente una inversión que aumenta los costos de los lentes de contacto por la inducción de ellos en el mercado. Ellos tienen también entonces representantes directos propios dentro de la zona y que su trabajo también incrementa los costos de los lentes de contacto. Si el profesional quiere de todas maneras hacer su inversión o hacer su importación directa, los registros sanitarios que se necesitan en cada país llenan de documentación a las personas, dilatan el tiempo de entrega y adicionalmente hacen más costosos todavía nuestras soluciones visuales. Uno de los gastos importantes adicionales son los valores de transporte, que incrementan por ser en dólares la inversión de nosotros en los lentes de contacto. El valor de las aduanas, el valor de los impuestos y el mayor incremento de problemas está asociado al tiempo de entrega de las soluciones visuales. Un lente fabricado en Estados Unidos llega a mano nuestra más o menos entre 30 y 45 días y las garantías tan necesarias en lentes esclerales pueden hacer que la solución visual para un paciente de manera global llegue hasta unos 2 o 3 meses posteriores. Uno de los grandes inconvenientes también es que la tecnología en equipos médicos no se consigue fácilmente, se consigue por compra anticipada, ya que los importadores no tienen obviamente productos dentro de su stock o dentro de sus almacenes, lo que hace que se retarde un poco más la consecución de esas posibilidades. Dentro del equipo básico que el consultorio tiene en cualquier profesional, pues está el queratómetro, el fluorograma y la lámpara del vidrio. Y la poca inversión que se hace en equipos nuevos está asociada directamente a que el profesional no puede hacerlo, no tiene cómo hacerlo o definitivamente no quiere hacerlo, porque de pronto piensa que su educación y su enseñanza le da para adaptar cualquier tipo de lentes y se adecua y se acostumbra a manejar ese tipo de limitaciones. Otra opción adicional que incrementa los costos son los cambios en las cajas de diseño que los importadores y las casas comerciales representantes hacen, logrando pues que esas inversiones sean permanentes y consecuentes con las necesidades que uno tiene. Los otros insumos que utilizamos en los lentes de contacto para los pacientes también a veces son importados y eso hace que se haya como un desaliento de las personas que utilizan los lentes, ya que se incrementan mensualmente sus gastos, pero sin embargo eso hace que haya una disminución en nuestra rentabilidad y que se incrementen todos los costos que tenemos nosotros aquí en América Latina. Sin embargo, nosotros, los contactólogos en América Latina, estamos preparados para todos esos retos porque tenemos el interés de mejorar la salud visual de todos nuestros pacientes. Por eso hacemos inversiones importantes, por eso sabemos que nuestras necesidades clínicas son mucho más importantes por nuestros pacientes y porque nos damos cuenta también que ese tipo de trabajo especializado nos da algo de diferenciación y eso los pacientes lo sienten. Sin embargo, toda esa inversión es de carácter privado. Nosotros somos en determinado momento los que movemos un poquito la industria de las nuevas adaptaciones, ya que todas esas opciones las tenemos solamente si nosotros hacemos la inversión por ellas. Otros oftalmólogos tienen ya centros especializados clínicos de gran volumen, en donde los optómetras especializados en contactología terminan siendo asesores de los oftalmólogos. El gobierno no tiene una necesidad obligatoria de tener estos dispositivos médicos especializados, ya que la mayoría de países en nuestra región la salud pública es un ente privado y les obligan solamente a conseguir entonces soluciones y no las mejores soluciones. Nosotros, los que trabajamos con lentes esclerales, estamos asistiendo de manera permanente a congresos teniendo interés por los últimos avances en contactología, y hace que de todas maneras seamos voceros también incluso de las universidades, donde ellos cambian de manera permanente en contactología sus pensos, sus materias, sus créditos, y eso hace que todos en términos generales estemos actualizados. También se debe agradecer de manera muy permanente a las casas comerciales que representan los lentes de contacto en el nivel mundial, ya que ellos durante toda esta pandemia y durante todo este tiempo han hecho esfuerzos inmensos en darnos a nosotros la actualización con webinars, con charlas de tipo comercial y charlas incluso de tipo virtual, que nos han ayudado a no quedarnos un poco atrás de lo que la tecnología mundial nos está ayudando a sacar. Sin embargo, uno de los problemas más importantes son las estadísticas y los estudios comparativos. Recordemos que nuestra raza latina es un poco diferente a las demás razas y que podemos encontrar entonces diferencias dentro de la configuración anatómica de los ojos, tanto en la forma, en el tamaño, en la presión, en todo lo que el comportamiento de los dispositivos médicos visuales. Sin embargo, no tenemos cómo compararlos. Eso nos darían patrones diferenciales de comportamiento y hace que de pronto sea difícil la recopilación de estos datos clínicos. Por eso también se encuentra dentro de nuestra región un poco de interés por la investigación. Desde hace más o menos unos 6 meses hemos conformado junto con otros 60 colegas, CLIO, por sus siglas en español, Consejo Interamericano de Investigación en Optometría, donde nos hemos reunido 60 investigadores de más de 23 países y 32 universidades, apoyadas obviamente por grandes asociaciones a nivel mundial de tipo optométrico. Y nuestra misión específicamente es generar un perfil epidemiológico en Latinoamérica de la salud visual, investigación que se hará directamente por nosotros, los optómetros latinoamericanos. En relación con equipos médicos, pues realmente tenemos gran variedad de topógrafos, tomógrafos y OCT, lo que nos da un gran cubrimiento. También tenemos, obviamente, las posibilidades de conocer los profilómetros de tan alta importancia, aun cuando por ahora la inversión se ha hecho lenta en ese campo, también por causa de que las casas comerciales que venden este tipo de instrumentos especializados no ven a la América Latina como un punto importante para sus ventas. Los laboratorios de lentes esclerales tienen representantes a través de las comercializadoras, y ellos no solamente venden los productos, sino que también venden los sets de prueba. Ya en nuestra zona podemos contar con Blanchard, con Valley Contact, con Excel, con ICD y con Medifacus como laboratorios que ya venden nuestros productos en el mercado. Pronto, creería que el año entrante, podemos tener también marcas de gran reconocimiento mundial como Boston Sight, Aculens y Custom Craft. Dentro de los laboratorios de fabricación en América Latina de marcas especiales tenemos en México, Costa Rica y Brasil. Y los laboratorios propios pueden tener opción de hacer sus diseños propios con algunas limitaciones en Chile, Argentina, Colombia y Ecuador. Afortunadamente no tenemos problemas con materiales porque son los mismos que estamos utilizando a nivel mundial todos los adaptadores de lentes de contacto. Pero realmente el principal foco de adaptación de lentes está en el consultorio privado, donde tenemos el Pentacam como una herramienta importante, el Benmon como topógrafo ideal para superficie ocular y en algunos casos el OCT. No solamente estamos valorando el tipo de adaptaciones de lentes de contacto, sino también estamos valorando la calidad y la cantidad de lágrima. El profilómetro, el eaglet, nos puede llegar a dar la opción de generar la posibilidad de conocer de manera mucho más evidente la superficie de la esclera. Y así poder nosotros adaptar un lente diseñado para cada paciente de manera especial. Algunas personas podemos tener la posibilidad de adaptar lentes bajo el sistema iPrint, obviamente para escleras extremadamente irregulares. Y algunas personas tienen OCT, lo que nos permite hacer mediciones de ságitas perfectas, tanto en centro como en periferia y limbo, y adecuar los lentes en los aterrizajes de manera perfecta, tanto para aumentar o cerrar ángulos dentro de la adaptación de los aterrizajes de lentes esclerales. También estamos utilizando nuestra tecnología y nuestra sabiduría para poder superar problemas asociados a alteraciones producidas por adaptaciones en excesivos aplanamientos de lentes de contacto rígidos, teniendo como aliados a los contactólogos y a los oftalmólogos para lograr que con medicamentos podamos superar problemas de alteraciones corneales profundas, como la que ven en el cuadro. Ya está en nuestro poder la posibilidad de hacer adaptaciones empíricas basados obviamente en nuestros sistemas nuevos de adaptación empírica basados en topografía. Y también tenemos ya en nuestro poder la posibilidad de comenzar a hacer adaptaciones bajo sistemas especiales como el Space. Reconocemos entonces que cada ojo es único y que cada lente debe adaptarse para ese ojo. O sea, cada lente debe ser único para cada ojo. Tenemos desde Latinoamérica una gran cantidad de profesionales con muchísima preparación que se viene gestando de muchos años atrás. Nuestra persistencia por conocer nuevas tecnologías se hace por un esfuerzo meramente individual y porque durante muchísimos años hemos visto que las soluciones visuales que utilizamos deben propender a conseguir más y mejores resultados. Y ahora que lo estamos logrando, queremos que ese empeño no vaya a cesar y que llevemos a nuestros pacientes a tener la oportunidad de conocer esta nueva forma de ver la vida, ya que tendríamos un incremento en la calidad de vida de nosotros, traeremos un impulso a la región y tendremos un nuevo desarrollo de tipo económico, social y sobre todo familiar. Tenemos las ilusiones abiertas de seguir aprendiendo, de mantenernos dentro de esta opción de avanzar y de tener todas estas horizontes abiertos, amplios, y que estas oportunidades en estos simposios nos dan a conocer cómo nosotros realmente somos, profesionales valiosos que queremos hacer las cosas bien. Quiero entonces agradecer de nuevo la oportunidad por parte de los optómetras latinoamericanos de hacernos o darnos a conocer. Muchísimas gracias a todos y esperamos que se mantengan en contacto con nosotros.
Thank you, Cesar. Gracias. Thanks for sending me the video. I know you were there waiting till now. It is, almost early morning there in Colombia. But thanks for supporting me and sending your presentation. Let's go back to share the video. Next one.
Hi, I'd like to thank Dr. Shekhar and Dr. Maskati for this invite. And though I believe scleral
So our next speaker is Dr. Arun Gulani. He is very famous cornea surgeon in Jacksonville, and he handles all the world's complications of cornea, LASIK, keratoconus. He has very innovative techniques. He recently got a patent also for his corneoplastic surgical techniques in the US. And it's amazing. He's like a film star. If you see his Facebook or something, it's like his clinic also is like a CNN studio. So he made it purposely like that. And every week he gets people from all over the world, and he will make up pictures, photographs, testimonials. But it's really good work. Incidentally, he's also from KEM Hospital, so knows sir very well. Listen to him on surgical correction for keratoconus, because there are not much of a surgical options, safe options for keratoconus, except the keratoplasty. So let us hear him.
Hi, I'd like to thank Dr. Shekhar and Dr. Maskati for this invite. And though I believe scleral contacts are a tremendous advance in the field of keratoconus, may I encourage you to understand surgery as the first line of action for these patients to not only fix their vision, but permanently. So think outside the con. May I show you patients and their reactions when you liberate them from this vision imprisonment and the lack of belief that these patients can actually see. Here are patients immediately after surgery, and I want you to get addicted to how they react.
Here she is, the girl from Wisconsin.
It is very important to understand these concepts as I keep showing you patient reactions in every presentation of mine. Here's a patient actually I saw yesterday, and you can see her after her major keratoconus surgical complication she had with other places before she came here. She actually went down this very treacherous 11-mile drive in the mountains called the Tail of the Dragon, and she actually
fun things.
So in all my presentations, you always see me showing my patients. I believe that's the highest level of accountability, and very important that we understand how they feel visually imprisoned just because doctors don't understand that they have the capacity to see. Here I am teaching actually a full course of surgical aspects that can be applied to keratoconus, right from corneal techniques to lens-based techniques to combination techniques, like you see me doing intact rings here. You can see me doing lamellar corneal techniques here, associated hand lamellar or automated lamellar techniques for building the cornea in extreme cases. Mostly I use laser techniques on these patients. You can also see associated conditions in keratoconus that can be corrected. For example, patients with Fuchs dystrophy or pterygiums with keratoconus, they can all be very beautifully done. Don't think these patients are abnormal. That's pterygium cases, very advanced cataracts in these patients. Take them to 20/20. Do not believe that they cannot see. Actually believe that they can and take them there. It's possible. Here we are, ICL techniques, you name it. So keratoconus patients deserve all these techniques and concepts. Piggyback lenses, really no limits to how you can correct them. So I'm going to show you this, which is also important for me to make sure that you memorize this and don't forget these pictures. These are keratoconus patients. These are patients who are surgeons, attorneys, pilots. They are professional athletes. These are people in the real world, and they're back with their 20/20 vision. So not compromising their life and completely free with their visual freedom, that too permanently. So these are patients' keratoconus in a single day that we fixed, and they're all free to go back and be the best in their profession. I want you to see these reactions of these patients right under the laser. As
I just finished doing laser plastic on your keratoconus cornea with the very irregular stigmatism. Can you see anything at all?
I see this is an immediate difference. This is, oh my God, like I am tingling from the inside out. This is fantastic.
Any pain, Hector?
No pain whatsoever. None at all.
Super.
This is great.
Very proud of you. And I kept my promise, no pain, everything perfect.
No pain. No pain at all.
And for doctors who are watching, if you can see up on the screen, our reflex has become a perfect circle. Right? It looks great at the line, beautiful. And that basically translates to vision, right?
Absolutely.
Congratulations. Here we go.
Always translates to vision. These patients enjoy and they make me dance with them. Whatever, I do it for them. It's okay. It's fun. Here's another patient who came with cross-linking complications, and again, see their reaction.
Danny, we just finished doing laser plastic on your very advanced keratoconus. Can you tell me the difference?
I can't believe it. I'm shocked. I can see much clearly. This is unreal. Much more clearly than ever before.
The girl from Wisconsin.
Again, remember, demanding, skeptical, well-researched patients. Both of you crying, guys. Dancing, before they would believe.
Thank you, Dr. Gogate.
Patients with scars of keratoconus can also be corrected, as you can see here. In fact, this is an acanthamoeba scar. And all of these scars, as you know, my in-cornea, on-cornea techniques with corneoplasty.
Very nice.
Look at the
I just finished doing laser on your corneal scar, acanthamoeba scar. Can you tell any difference?
It is a lot more clear. Things are sharper.
Wow.
The image is sharp.
Fantastic. Any pain at all?
No pain.
Well, we're so proud of you. How many years have you suffered with this blindness?
14 years.
Very happy for you. Very happy for you. And for doctors who are watching, this is a acanthamoeba scar. You can see the reflex of the perfect circle. That tells you again.
Circle. Here's another patient. This patient is very complex keratoconus patient.
Finished laser plastic on your keratoconus. Can you tell me any difference?
Yes, the light is clearer.
Yes?
Yes.
Fantastic. Any pain at all?
No, none at all.
Super. For doctors.
Keratoconus patients from moderate, mild to extremely severe that I will show you, but their reactions are all the same, no matter where in the world they've traveled from. Look at this patient from South Africa with associated extreme astigmatism and nystagmus. And you can see that I designed especially extremely so it doesn't move while I'm doing the laser plastique technique. And you can see their reaction, their happiness, and she in fact flew to California for skydiving before going back to South Africa. Patients with extreme myopia and astigmatism with stable keratoconus can even have phakic implants done. So you can see these kind of cases. I use the Vision ICL that we've experienced with all the 6 different phakic implants in the world. And again, bring these patients to 2020. Patients with cataracts with keratoconus. Here's a patient from Abu Dhabi, and again you can hear.
Great, Jack. Everything's going fantastic. You okay?
Oh, yeah. The reaction of this patient while I'm in their eye, and they have no anesthesia. Most of my patients
Inside your eye, just behave like a patient now, Jack.
Even in such complex cases. And here he is, and that same night he hired this bike and encouraged me to sit on the back, and my confidence on sitting on the back of his bike, where he had surgery that morning with his complex keratoconus cataract, and he took me for a ride before going back to Abu Dhabi. Very important to see these concepts. Then new technologies that we use can also be used for keratoconus. For example, using the intracameral steroid that we use, that patients don't have to use eye drops anymore, right? That's the technology. Right here you can see me, the little ball, the sphere of white that you're seeing going inside the eye, they don't need drops anymore. Then the other concept of using steroid-based lacrimal plugs in these patients, called test extensor. You can see that being inserted in these patients. And of course the tissue or the glue, the Rissure sealant that I'm using in these cases for no stitches. One of the most complex cases I have done, not because of the extremeness of the keratoconus, I've done up to 38 diopter astigmatism, though this is 24.7 astigmatism, but the cornea was just close to 100 microns thickness in the center and in the area where I'm doing the surgery. And you can see the ring I have placed in one area and compressing sutures on the other, took them out to stabilize the cornea to perfect stability in this patient, avoiding a full transplant. Patients like these who came to me with This is not keratoconus, but surgical keratoconus, hexagonal keratotomy, that's severe ectasia, about 90 diopter keratometry, 23.5 diopter astigmatism. And we brought them to 1.4 diopters and then did a cataract
This is a
surgery for this patient
75-year-old
with
nurse who was
impulsivity of
referred to
5
me
months
following
fast.
hexagonal keratotomy.
You can see here that patient straight to 2020. And this is why I want us to look at every patient with keratoconus, no matter how severe, and actually give them this freedom that sets them free. So how do you define keratoconus? May I encourage you not to get scared by that word and decrease your desire and the patient expectation. In fact, break down keratoconus into a condition that is stable or unstable with relatively thin cornea, high keratometry, astigmatism with myopia or hyperopia. It's an exercise in futility to grade keratoconus, score it, label the patient as complex, and then do nothing. That doesn't help anybody. Similarly, cross-linking confusion. Don't cross-link keratoconus patients and leave them disabled. Cross-linking is a very important concept I'll share with you later, but stop this discussion of epi on, epi off, protocols, what do you use, how thin the cornea. Cross-linking cannot just cross-link a patient and leave them dependent and disabled. That's not the end goal, right? Raise the bar. Dependence on a contact lens or delaying a transplant should not be a goal. Delivering vision should be a goal. No harm in falling short of your goal and then needing scleral contacts to make them see. That is absolutely fine. So avoid distractions. Looking at topographies and doing courses and conferences means nothing. It doesn't matter how irregular the cornea is. Fix it. Same as I showed you here. And then what is important to me is how I go after these patients and believe in their vision and actually refract them despite all the technology in the world. This is the key point in keratoconus.
Love it, Mom. Love it.
That the patient can see. Then my 3T system, which defines technology, techniques, and target. Very important again. Do not be limited by this is all I do, a LASIK, a SMILE, a ICL, a cataract. No, I want all 40 techniques to be the realm of every eye surgeon. Take, for example, this case. Now I'll start showing you how I think. A patient who was sent to me having had premium cataract surgery through his keratoconus was ended with hyperopia, open capsule, presbyopia, central scarring, high keratometry. A horrible situation for a pilot. This patient was in a lawsuit. His surgeon had him travel over to me. Again, see what I did. I never like to think barbaric surgery. Always think logical. How do I make him 20/20? My first thing is to believe that the patient can see 20/20. Then I start walking backwards to understand the least interventional way to artistically give them vision. So let's pick all the pins in this case. Patient has a corneal scar, high keratometry, high astigmatism, hyperopia, and pseudophakia but open capsule. So you don't want to exchange the lens. Yes, surgically I can show all my skills, remove the lens, do the vitreous, but that doesn't get us to 20/20. So what did I do? So here my concept was, if I need one surgery to fix this patient's scar, high keratometry, central limitropia, or everything, it would be myopic laser surgery. But the patient's hyperopic. So I start defining how to create myopia. So what I call this is going to Paris, but through Iceland. The patient and you have to be confident to hang on to the journey. So I first put in a piggyback lens and made this patient actually myopic, which was my goal. And patient's vision obviously was bad, but his confidence in me and my confidence in where I'm headed. So, and then I went in and did piggyback. After getting myopia, I did a laser plastic surgery. Now I got all my errors: myopia, astigmatism, scar, keratometry, larger zone. In fact, this patient landed at 2015 vision without glasses and went back and got his PUTS license. So here's my thought process for keratoconus. If a patient's vision is better than 20/40, astigmatism with myopia, more than 400, stable, regular, no pathology, I'm doing laser plastic, as you saw me do, right? Here is how I do these cases. For example, this firefighter, you can see he's at 0 with laser plastic, vision of 2015, astigmatism straight to 0, even topographically. And these people are back into their lives. Then patients who come to me who've had multiple surgeries also, like this gentleman in Canada, California, all over the world, had multiple cross-linkings, but they had left his vision uncorrected. That's the point I'm trying to get to. Cannot just stabilize the cornea and send the patient home blind, right? So this patient we brought straight to 20/20. How I tackle in-cornea scars and on-cornea scars that I've taught y'all before, and that takes straight to 20/20 in these cases. Now, take patient cases who are 20/40, myopia more than astigmatism, more than 400, everything stable and regular. Now I'm going in the eye and doing an ICL or a phakic lens to make this myopia, which is a higher criteria, in a stable cone, straight to vision. As you can see here, we're experienced with all kinds of phakic implants in the world. My present preference, the Vision ICL. Even in cases like this that came to me, this is a baseball player who came with severe granuloma, with stem cell deficiency, with high myopia, with keratoconus, thin cornea. And I put in an ICL after a collaboration with my colleague. We did an amniotic surgery first, corrected the granuloma, and then went straight to vision. Take, for example, patient more than 20/40, but high astigmatism, hyperopia, stable, regular, and a cataract. You're going straight to cataract surgery, what I call lensoplastic surgery. Even though the cornea pre and post-op has the same astigmatism and irregularity, the patient is at 20/20 because we basically corrected optically the anatomical problem. Various lens technologies can be used in keratoconus, absolutely can be used. Even the new X-wave technology is great. My present choice for keratoconus patients with cataracts, patients with extreme situation like this, excuse me, high irregular astigmatism with keratoconus, and nystagmus, as you can see. Nystagmus, as you can see, in a patient with albinism. Patient had albinism, myopia, very high irregular astigmatism you can see here. But even these cases can be corrected and you can put them back in their lives. Then you can see in these patients when the vision is more than 20/40 but high astigmatism, cornea more than 300, less than 400, stable, regular, and no pathology. Here's where I'm doing cross-linking on these patients and stabilizing them to a better vision or to a vision out. My concept of cross-linking is called keratoscoliosis concept that I've defined over a decade ago, is not to cross-link. In these words, I'm showing a spine and it's bent. Don't put cement on the spine saying it won't bend anymore. That's correct. But then you haven't corrected the spine. So that's a disfavor to the keratoconus patient that you're keeping them disabled for life. So cross-linking, which is a very important part of treating keratoconus, must be done. But after you have fixed the keratoconus cornea, made the patient see to their best capacity, and then you can permanentize that shape with cross-linking. Of course, there are other indications which are early, young age patients where the keratoconus keeps changing, but most importantly, do not use the cement on the bent back until you fix the bent back and made it straight. All right, there you go. Complications of cross-linking, as I mentioned to you, we correct all the time, and they can easily be corrected like I showed you all in the video. Here's my thought process and how I go through at this level of the treatments for the visions less than 20/60, high astigmatism, less than 400 cornea, unstable, irregular with ectasia. This is where I go into intact surgery, which are directional rings that I put into the cornea, which not only stabilize the cornea and give it strength, but it's directional. So it also, as you can see, this is my technique. And what I do here is create channels with laser or manually, depending on the complexity of the case, and put in single rings, double rings, plan it along the axis. And this is again, no stitch, tissue or glue sealant that I'm using on the cornea. You can see these patient reactions that is so immediate. I don't want you to forget this. That's why I keep showing you patients how they react, how they cry, even with intact, which is now called the Golani T intact technique or the titratable technique. They start seeing the perfect circle right under the laser.
So Anthony, we just put a special ring to control your complications from the LASIK cells, and look to the right. Can you tell any difference?
I can tell her hair right there. I can see her head ring perfect.
Wow.
And I can see the square around that. I can see that square ring around that perfect no glare.
Wonderful. Wonderful. Excellent. Congratulations. Keep your eyes closed. You fixed it.
Very positive.
Anthony, come on. Give me a smile. Tough guy like you crying. I don't want it. Get up.
Going on to seeing how these intacts can correct all kinds of ectasia, even here from, as you can see, from 10 diopters going down to 0.1. Patients with LASIK ectasia, which is like a surgical keratoconus, 7 to 0.6, 23.5 to 1.4. So there is no limit to what you can correct, as you can see here, right? All kinds of ectasias can be corrected, even ALK ectasias. And it doesn't stop there. After you control the cornea and built it with the ring, you can still do laser plastic on top to correct the residual astigmatism or refractive error. Patients who came in to me, like this guy with a Ferrara ring from abroad in Europe with broken ring, they asked me to remove it. I said, no need for removing. The surgeon did a good job. The ring's doing its job of stability. We did laser plastic on top, straight to vision. This patient from Egypt had multiple surgeries, not only in Egypt, but London, Germany, all over the US, and corrected straight away to vision. Doesn't matter how many surgeries they've had. And you can see the impact there. Vision less than 2100, very irregular, very unstable, less than 200 cornea, Here is where I need corneal tissue to build the cornea. That's when I do lamellar keratoplasty. Remember, never penetrate. So you can see here in this technique video, again, for paucity of time, I'm so fast, you can do automated technique and lamellar techniques, and you're constantly making sure the cornea is stabilized and freshened up for future refractive surgery. That's the goal. It's not just the surgery. You're now building it up for future refractive surgery. That's hand lamellar technique. Again, all these videos are on my YouTube for you all to see, but it's just to give you a glimpse of where we are headed. And
this is a
all
case
these
of a
patients
very
can be
advanced
rehabilitated back to normal vision. And you can see what lamellar keratoplasty does. It doesn't correct the astigmatism, but decreases the keratometry, clears the cornea as tissue for future correction. This patient from Switzerland came in with extremely high myopia with astigmatism, posterior polar cataract, keratoconus with an intact ring, and then I went inside the eye and put a toric premium lens straight to 20/20. So you can see combinations are very, very, very impactful in these cases. This physician had 12 procedures before coming to me, completely blinded, 2200 vision, and had all these techniques before coming here. But it doesn't matter. He had PDK, PRK, cross-linking multiple times, ICL, and now he had a cataract with the intact rings and keratoconus. So we basically did a laser plus, made him measurable. Then I removed his cataract and his ICL, and then kept the bag open, as you can see here. And then a week later, on refracting the patient, went inside and placed a perfect, stable toric lens implant to 20/20 vision. That's the ICL coming up. That's the cataract part. And then I come back a week later and I put in a toric premium lens straight to 20/20. And of course, I keep showing you patient reactions because it's very important for you to be understanding that surgery can help these patients, even with previous multiple surgical failures, to bring them to 20/20. With that, I'd like to thank you all for your attention, and may I encourage you, please, to think outside the cone. Dr. Galani. Hi. I'd like to thank Dr. Shekhar and Dr. Maskati for this invite. And though I believe scleral contacts are a tremendous
So that was Dr. Gulani, and he's, definitely a different kind of surgeon, and he does whatever he does. It's the best in US, so we are proud of him. Now let us go ahead and go with the next presentation. Yes. Next, copy करून ठेवलं. So I invite Dr. Quresh Maskati to talk on scleral lens as a bandage.
Thank you, Chandrashekhar. So as he told you earlier, that we've been working on this since 2002, I think, and worked a lot hand in hand. He would do these scleral lens fitting for my patients, and we did quite a few patients. So some of this is just repetition, so we know what we mean by a scleral lens as opposed to the mini scleral lenses. This is a genuine full scleral lens which sits on the sclera itself and bathes the cornea continuously with a cushion of saline. And that's the reservoir that bathes the cornea with oxygen-rich artificial tears. It can be customized. So we've had some patients with symblepharon for whom Chandrashekhar has made a lens which is customized, which sits over the symblepharon without me having to do surgery, because in Stephen Johnson patients, many of them have got pre-existing symblepharon. So we can design these, and he has designed them for me many a time. We know the details of how the various parts of the scleral lens, and perhaps you've discussed this in the morning, Chawan, when I was here. These have been, so we won't go into the details of the various curvatures which are there. So the main thing in a severe corneal surface disease like in a Stevens-Johnson syndrome, what helps is a liquid bandage lens. They're not looking so much for vision. They get good vision, which is a bonus, but they're looking for that liquid bandage lens because they're putting drops sometimes every 15 minutes. I've had patients putting drops every 15 minutes of their waking hours in the eye. No matter how good the drops are, they're going to get some dermatitis at the end, some allergy, some skin excoriation, because every time they put the drop, then they dab it over here and things like that. So a scleral contact lens, whereas Seema pointed out, even if you have to reduce, it's not that you have to stop putting drops, but if you can reduce the number of times that the drops are put, it's a very win-win situation for the patient. So scleral lenses have multiple indications. Some of them are for K corners, but today I'll just be talking about the not the optical, but the protective or the therapeutic indications. These are the, again, a little bit of repetition. As Seema also pointed out in her small series, that the most important sort of relief for the patients is the difference it makes in the ability to stand light. Many of these patients with severe photophobia can open their eyes only because of this scleral lens. Nothing else helps them to open their eyes. Drops every 15 minutes does not help them to open their eyes, but a scleral lens which put in immediately makes them stand light much better. And if I have a patient with severe photophobia, I straight away know that this is going to be a happy patient when I put the lens in. Because if they've come to me for photophobia as the primary indication, I'm almost 100% sure I'll be able to get rid of that. So this is from some of Chawan's patients when he was with Perry Rosenthal. The before and after, the lights were purposely put down because this lady couldn't open her eyes at that time in any sort of light which was there. And this was a patient with Stevens-Johnson with K corners, a combination of them. And she would stay with closed lights in a corner of a room. And here she's opening her eyes brightly. So basically, any severe dry eye, the keratoconjunctivitis sicca, whether it's Sjogren's syndrome, non-Sjogren's syndrome, or Stevens-Johnson syndrome, the improvement is quite dramatic, as you can see in the before and after pictures. Even melting cornea, sometimes we are able to prevent further melting of the corneas, and you can see that the staining pattern improves tremendously. Persistent epithelial defects, where no matter what I did, even autologous serum drops, I do a lot of autologous serum drops where we bleed the patient, then centrifuge the blood and make about 20% dilution of autologous serum. Works very well in treating persistent epithelial defects. Much cheaper than the scleral contact lens. But if the patient is going to get this recurrent PED, it's difficult to continuously bleed the patient and centrifuge. You can do it once in 3 months to once in 6 months, you can do this. If the PED is occurring more often than that, then you have no choice but to go in for a scleral lens. So these are some of the indications. There's a syndrome called Riley-Day syndrome. Riley-Day syndrome is what is called familial dysautonomia. That means there is some problem with the autonomous nervous system. So they have congenitally anesthetic corneas. And we know that the corneal sensation is very important for proper tear production. So when they have Riley-Day syndrome, when they have anesthesia, you can't put any other contact lens on in the patient's eye. The chance of infection and other things are huge because the patient has no sensation. So a tear film bathed or a saline bathed scleral lens works really well in these patients in congenital anesthetic corneas. Any cornea with absent sensation or poor sensation. These are some of the patients. Some of the severest reactions of some of the severest dry eye patients you will see is Stevens-Johnson and graft versus host disease. And we've had fairly good amount of experience with both these type of patients, as well as rheumatoid arthritis and what we call the dysfunctional tear syndrome, where the tears there are tears in the eye, but those tears have got toxic cytokines in them. They're very, very sort of poisonous to the eye. Those tears do no good. They're not wetting. they're causing more problem. So when you replace that with the scleral lens with saline inside, the patients jump from the closed eyes to open eyes with these patients. It's now fairly well established. We've been using this since over 2 decades now in Mumbai, courtesy Chawan, who brought this technology from Perry Rosenthal, and I'm grateful to him. This is a study that we did of 98 consecutive patients. 13 of them had persistent epithelial defects, and all follow-ups for more than 6 months, and some of them are up to 15 years. So success rate in these patients, again, I'm talking only about dry eye patients now, I'm not talking about K-Conus patients. So almost 100 patients, success rate was about 73%. And if you take the non-PED patients, success rate jumps to a little about 85% of the patients. And so we had some keratitis sicca patients, some miscellaneous patients like acid burns and things like that in our list. So when we were doing these numbers, we came across, we devised our own grading system. We called it the Maskati Chawan grading system or the MC grading system. Humility is not our strong point. We learn a little bit from Arun Gulani, the master in non-humility. So, but this predates when Arun was a student in KM, we were doing this. So the Maskati Chawan, we had a little bit of an argument which lasted about 15 minutes about whether it should be the Chawan Maskati system or the Maskati Chawan system. And I guess being a little senior to that, it became the Maskati Chawan grading system. Unfortunately, we didn't make money on this. We didn't even publish it anywhere. So the purpose was to evaluate, sorry, I got the first prize, but the prize was a piece of paper costing about 7 rupees. So they evaluate, and I've never tried to sell that paper after that. So it's notional value. So to evaluate and grade the severity of chronic ocular idea was to see in which patients, because these are expensive lenses. So which patients of Stevens-Johnson it would work and in which patients it would not work. So using the MC grading system, if we could come out with this, then we wouldn't have to put the patient through unnecessary trials. And to compare the efficacy of scleral lens versus no scleral lens in Stevens-Johnson. So we said, let us see if we can use this. So this was a retrospective review of 72 patients, 144 eyes, all with Stevens-Johnson syndrome, in which we fitted these scleral lenses, at least a year's follow-up. This was done between September 2008 and March 2010. And all patients were chronic Stevens-Johnson, nothing acute. At least 1 year had passed after the episode of Stevens-Johnson. So detailed history and ocular examination was done, and we collected this data. Now, just as we have something called the tumor node metastasis when we are doing cancer grading, there is something called the TNM classification, which is tumor. How big is the tumor? Grade 1, grade 2, grade 3, grade 4, grade 5. Then are lymph nodes involved? How big is the lymph node? Is it single lymph node? If it's a breast cancer, axillary lymph node, peripheral lymph nodes. So tumor node and metastasis. Is there a metastasis? How much is it to the liver, kidney, spleen? Where is the metastasis? That's the TNM classification. So we use that to grade this, and we grade it using 5 parameters: photophobia, corneal transparency, the best corrected visual acuity, presence of superficial blood vessels, and presence of deep blood vessels. So these were the letters that we used: P, C, V, BS, and VD. And each parameter was graded on a scale of 0 to 5. So photophobia, what kind of photophobia does the patient have? 0 photophobia means no photophobia. Grade 5 photophobia, which is severe photophobia, and something in between. Corneal, so I'll just go through each of them with you. So for photophobia, we said there is no photophobia even to very bright light. If I shine we have a very bright light in my indirect ophthalmoscope which we use. So if we shine that bright light and there is no photophobia even to very bright light, is P0. Then P1 was photophobia only for bright light. Daylight and all is okay. But if I shine an indirect ophthalmoscope into his eye, then there is photophobia. Then P2, photophobia to moderate light. Like from the slit lamp. When I put him on the slit lamp, the patient goes away because he can't stand the slit lamp light. P3 is photophobia to dull light. from a non-powerful torch. We have two torches in our clinic, one powerful one which I use, one non-powerful which Hetal Mistry uses. So the non-powerful torch is the one which is used, and if that causes, then it's P3. And P4 is a patient who's wearing dark glasses even inside the house, and P5 is even with dark glasses, he finds that he's closing his eyes. So that's the way we graded this over several cups of tea, usually at Chawan's place. Then, so for example, this patient, this child is going backwards, cannot tolerate moderate light from a straight lamp, so you would be P2. If the patient is wearing glasses even indoors, you would be P4. If he cannot open his eyes even indoors, keeping his eyes closed, this would be P5. So it's a very simple, replicable sort of thing which everyone can use. Then for the other things, we divided the cornea into 3 zones. Zone 1, Zone 2, and Zone 3. The peripheral zone was Zone 1. The mid-periphery is Zone 2. For all contact lens practitioners, this becomes easy. And the central zone is Zone 3. So we said, where are the blood, so grading transparency, is the transparency lost in Zone 3, which is the vital central area? Is it lost only in Zone 1 where it makes no difference? Blood vessels, are they penetrating right to the center? Are they going only to the periphery? So if you just remember this Zone 1, Zone 2, and Zone 3, where Zone 3 is the innermost, then we'll do the other parameters. So corneal transparency was the letter C. So if the cornea is clear, it is C0. If there's scarring in the periphery, Zone 1, the peripheral zone, then C1. In mid-periphery, Zone 2 is C2. In Zone 3 is C3. If there's scarring in all the 3 zones, then we would say C4. And if there is complete keratinization such that no iris is visible, then it will be C5. Now see that picture over there. You can see iris. Iris is visible. So it is not C5. But there is scarring in all the 3 zones, not complete 360. But if you see the lower half, there is scarring in all the 3 zones from 1, 2, and 3. So this patient would fit into grade 4 or C4. For superficial and deep blood vessels, it was exactly the same, where BS0, that means blood vessels, superficial 0, there are no blood vessels entering the cornea. So there is 0. And if it is, again, entering Zone 1, Zone 2, Zone 3, all the zones, and superficial blood vessels in Zone 3, and more than 50% of the cornea involved would be BS5. So if you see this picture here, this would be a BS4 because there are superficial blood vessels going right up to the center, up to Zone 3, but less than 50% of the cornea is involved. You can see about 3 clock hours in the bottom are involved. So less than 50%. So it would fit into BS4. And for BS5, it was exactly the same way. BD, exactly the same as superficial, except that these are deep blood vessels. So again, you can see in that patient, it is BD4. There are deep blood vessels. They're not as shiny, so they're deeper. You can make it out on slit lamp. And it doesn't, the deep blood vessels are not more than 50% of the cornea, so it is BD4. And for visual acuity, that's the last parameter. We did VO, where visual acuity was 2020 to 2030, then it's VO. And if the V5, the visual acuity is less than visual 20,000 or up to perception of light only, that would be V5. And these were the in between. Again, this was very random. Sometimes we required coffee also to do this. So let's go to examples of Stephen Johnson. This patient presented with the following MC grading system. So this is the picture of the left eye. Patient was wearing dark glasses indoors. So it is P4. The visual acuity was between 2080 to 2200. So it is V3. There was scarring present. All the 3 zones were involved. So C4. There was superficial and deep blood vessels entering right up to the Zone 3 inside. So on grading, this is what we would do. We would write down P4, V3, C4, BS4, BD4. It was very impressive to the patient because they thought this was Greek and Latin. Now, we treated this patient for 15 months with scleral lenses and again did the classification. Now, grading, what we would do is we put the latest findings on top of the first visit. So the first visit you see was P4, V3, C4, BS4, BD4. Now, on the last visit, 15 months later, the P4, so wherever the numbers improve, so P4 has improved to P1. which is great. The photophobia is much less. The vision has improved a bit from V3 to V2. The corneal transparency has improved a little bit from C4 to C3. The blood vessels have regressed quite a bit to 2. So you know that this patient has done remarkably well. Patient, of course, tells you also that you've done remarkably well. But you know that such type of patients would do very well on this. Now, this is patient 2 presented with the following MC classification. This is the picture of the right eye. P2, not much of photophobia. Visual acuity fairly okay. Some amount of scarring, but only up to mid-peripheral zone, not central. Central area, you can see the pupil fairly clear. And just a little bit of blood vessels entering superficially at the temporal side. There are no deep blood vessels. So this was the grading. P2, V3, C2, BS1, BDO. And just in 1 month of treatment with scleral lenses, the photophobia vanished completely. So that is the biggest advantage. The photophobia improves. The milder the case, the faster the photophobia improves. So the vision improved to normal to V0, and the other parameters showed no change. But the patient's vision was better and the photophobia improved. This is another patient with the left eye is shown. Now, this is what I was discussing with Seema today, that you see that cornea completely keratinized. The cornea is completely keratinized. So the conclusion was that it was C5, completely keratinized cornea, iris structures we couldn't see. And we found that treating these patients with scleral lens was not going to help them much. So we stopped treating after the trial period. After that, we just, if there was somebody with a C5, I wouldn't bother about any of the other things. We just would stop. It was not fit for a scleral lens. So in almost all the cases, there was significant improvement in terms of photophobia and visual acuity. In some cases, there was relative improvement, and few cases, as I said, those with C5 were not suitable for scleral lens. So we would leave these alone. So in Stephen Johnson, 72 eyes of 144 patients, average vision on presentation 2050 to 2080. Average visual improvement after mean 1 year follow-up was 2025 or 2 logmar lines. And average 2 to 3 grades of improvement on MC grading system of the almost all the parameters was found. The conclusion was that the MC grading system was useful for decision making about whether to use or not to use the scleral lens, to give them prognosis. Certain things we would say you would improve in 1 month's time. Some we would say that it'll take a year or more for improvement of some of the parameters. As we grew more experience, the blood vessels take much longer to regress. The photophobia is much faster to regress. So those sort of things, because of this classification, we could come out with. So this new method for grading the extent and severity of the ocular involvement demonstrates that the severity of ocular involvement is correlated significantly with the final visual outcome. And we found that this was a fairly objective method, which could be, instead of comparing apples and oranges, somebody sitting in California and writing a paper on Stephen Johnson and using some different method or some different lens, and we writing a paper over here makes no sense because the parameters are not evaluated. So if everyone uses this classification, then you can easily come to a conclusion that your lens is better than my lens or vice versa. And we found that scleral lens is effective in mitigating the symptoms in these patients. So it can be used to evaluate any future treatment options. What something new might come, something better than the scleral lens might come. But we can use this classification to objectively find out whether it is better than the scleral lens, etc. It's fairly easy to use, can be replicated anywhere in the world. You don't require any expensive equipment. The indirect ophthalmoscope is what I use for the light, which is available. The slit lamp is available, so nothing else. It comes in handy to compare your results with XX company scleral lens with, say, YY company scleral lenses as well. There are limitations of this, that we only talked about corneal changes. I have not talked about symblefra. I have not talked about lid margin keratinization. I have not talked about conjunctival changes. This is because our treatment modality was the scleral lens, which only works on the cornea and does nothing to conjunctiva or anything else. Thank you so much.
Thank you very much, sir. That was really nice. The old days again. So
post किया उनको.
Dadi, are you there? So Dadi Fadil from Italy, she is one of the renowned, world-renowned scleral lens and orthokeratology practitioner, and she has written a lot of books. So of course she has sent me her presentation, and she's already there with us. So maybe we can interact with her after I finish her presentation. Dadi, are you there?
Hello, I'm here. Yeah, I'm here. Thank you.
Thank you, Dadi. So I will just run your presentation first, and then we'll have a questions. Is that okay?
Okay, wonderful. Thank you. And it's an honor and pleasure for me to be part of SSLS 2021 virtually this year, but hopefully we will all be able to meet in person next year. Today I will be talking about contact lens fitting in keratoconus. So let's see a little bit what is keratoconus. Keratoconus is the most common corneal irregularity and still the most mysterious one, despite several years of research. Imagine that in 1844, Pickford stated, "There is probably no disease to which the eye is subject, hitherto so rebellious to medicine, so intractable in its nature, and at the same time so fatal to vision as conical cornea. And not one, the pathology and treatment of which are so little understood. After more than 1.5 centuries, this disease is still enigmatic. In 2013, Pater reflected, keratoconus remains an enigmatic disease in terms of inheritance, prevention, associated risk factors, progression, treatment, and underlying pathophysiology. It's characterized by central stromal thinning, scarring, and protrusion. Typically, keratoconus starts to appear in adolescence, and it's progressive until the 3rd or 4th decade of life. There are different types of keratoconus depending on the stage and location. Different methods have been proposed for the classification. Here are 2 classifications based on corneal curvature and corneal thickness. Clinical signs of keratoconus are several and depend on the stage of the disease. Over a short period of time, the refractive correction may change rapidly, and importantly, the refractive error change in the amount of the cylinder and its axis. Reading material may be held at an abnormal close range because of the irregular myopic astigmatism. The topography is unstable, and fissuring, voxstria, or scissor reflex may be observed. In advanced keratoconus, scarring will be detected and the refraction will be difficult to perform. Other signs include significant difference in astigmatism between the 2 eyes and high order aberrations. And when we are assessing the cornea and keratoconus, it's very crucial to ask patients about their family history. There are different management strategies for keratoconus. Here we will see only those regarding contact lenses. There are several challenges when fitting keratoconic patients, and this includes the frequent change in refraction and isometropia due to the significant difference of refraction between eyes, the high astigmatism and the oblique axis, the impact of high order aberrations, and never forget patients' need, which can be very challenging. The objective when fitting contact lenses are to provide good vision and good comfort, maintaining a healthy cornea. So for this purpose, it's important to optimize the fitting for a better visual acuity and comfort, and to avoid mechanical stress on the cornea and promote oxygen transmissibility. Here is a very useful chart for the choice of the lens depending on the stage of the keratoconus, and we can see that different contact lens modalities may be fitted for the same stage, and this depends on the patient's need and the cost of the lenses as well. So let's start with soft contact lenses. They have some benefit in early stage of keratoconus, providing good comfort and centration. Important limits are the vision, since the soft material conform to the cornea and do not compensate the irregular astigmatism. Dehydration is also an issue, especially in patients presenting dry eyes. Many soft contact lenses are designed specifically to correct the keratoconic cornea. Customized soft contact lenses consist of having the central portion of the lens thicker, indeed to conform less with the irregular cornea and compensate the irregular cornea and the irregular astigmatism. They also have a spheric design to reduce high order aberrations. Here are images of the lens fitted on the eye, observed with an optic section. What we can see here is the central thickness of the lens, which is significant. The thicker optic zone is also seen in diffuse illumination. The main concern of these lenses was the oxygen permeability, which is not anymore an issue because these lenses are now made with high decay materials. Also, the thickness is limited to the optic zone, and lenticularization allows better oxygen supply to the cornea. Additionally, the lens moves on the eye, allowing a tear exchange. Corneal lenses are rigid contact lenses that do not conform to the corneal profile, so the tear layer formed between the lens and the cornea corrects up to 90% of the anterior corneal astigmatism and high order aberrations. Here in the photo on your right, so you can see a standard toric soft contact lens fitted on an advanced keratoconus with the edge lifting off due to the corneal protrusion. This definitely compromises vision. This is because the lens is thin and conforms to the corneal shape, while rigid lenses do not present this issue because the lens is rigid. Corneal lenses are the traditional correction for keratoconus. Their benefits are high level of oxygen permeability and great tear exchange, which maintain corneal metabolism. They have superior optics when compared to soft contact lenses and spectacles, and they are relatively easy for patients to handle and available in unlimited powers. However, corneal lenses may present several disadvantages, such as discomfort due to the important interaction between the eyelids and the rigid lens edge, and their poor stability. An important issue is the flat fitting of corneal lenses appear to cause apical scarring. There are three fitting philosophies: apical touch. Some practitioners still recommend this for advanced keratoconus because it allows better vision. 3-point touch is the one recommended because it allows a slight touch centrally and more important peripherally. And the last fitting philosophy is the apical clearance, which may be indicated in mild to moderate cases. Awareness on apical touch philosophies is very important to highlight. The CLEC study showed that 43% of flat fits had scars compared to 26% for the steep fitted eyes. Of the 878 patients with at least one unscarred cornea at baseline, the 5-year incidence of corneal scarring was 14% overall, 17% for contact lens wearing eyes, and 38% for contact lens wearing eyes with corneal curvature greater than 52 diopters. The topography is essential in corneal lens fitting. The actual map is up to 20 times more sensitive than tomography data concerning the front surface refractive changes, but for lens fitting, it's necessary to use the elevation map, which allows to determine the most appropriate contact lens modality. The red portion of the elevation maps represent areas of the cornea that are highest in elevation, and the blue portion represent the cornea that are lowest in elevation. The blue areas of the corneal elevation maps, as you can see here in this photo, indicate the fluorescent pattern. Here in these figures, we can see the optimal central fitting. We can see example of optimal fitting. Cases where the lens is fitted too flat, and also lenses where the fitting is too steep. Lens edge should also be assessed. It should be optimal, and we have different patterns of lens edge as well. If you want to learn more about corneal lens fitting in keratoconus, you may download this book for free, written by Professor Gina Sorbara. Intralimbal lenses are also indicated in keratoconus. When fitting intralimbal lenses, the back optic zone radius is flatter than expected, and it should be calculated 0.2 millimeters flatter than the average mild K. The lens diameter should be about 0.2 millimeters smaller than the corneal diameter and have small movement. These large corneal lenses allow to vault the cornea, avoiding mechanical stress on the apex, allowing to maintain the health of the cornea. Another value-add system is the piggy bag, which consists of fitting a soft lens and a rigid lens. So this option is a good one when the best fit of corneal lenses isn't 100% appropriate, and they may improve comfort. So the soft lens correct the cornea from the rigid lens, which is applied on the soft lens, reducing epithelial damage due to the touch of the rigid lens. And they improve lens centration as well. So the soft lens avoid the rigid lens to touch the cornea and avoid the damages caused by this touch. Most use plano for the soft lens. Negative soft contact lenses are fitted to steepen the corneal lenses, and positive soft contact lenses to flatten the corneal fit. Regarding the power of the lens, soft contact lens component will contribute about 20% to the system. Low power has negligible influence on the corneal fit or the net system power. It's suggested to use plus power to somewhat mask corneal irregularity and possibly improve the corneal centration. Generally, it's recommended to use lenses of approximately +6 diopters. Now we will see hybrid lenses. They are used for mild to moderate keratoconus. They allow to avoid corneal abrasion and resolve neovascularization from low decay and reduce time chair. They are called hybrid because the central part of the lens is made of rigid material, allowing better vision, and the periphery of the soft lens promote comfort. This is the design of the lens, showing the rigid part that does not conform to the cornea, allowing the creation of the tear layer, correcting the corneal irregularities, and the soft part allowing good centration and comfort. The rigid lens may be made with oblate design as well. It's made with high decay material, landing gently on the mid-peripheral cornea, and also the soft lens has a high decay, which is of 84. Here we can see the lens fitted on the eye, showing the corneal clearance under the rigid lens. The OCT image showing the edge of the rigid part and the landing of the soft part. It's important to determine the central vault, assess the intralimbal zone for the gentle touch, determine the correct skirt curve, and determine the correct power. They should be fitted 100 microns at the initial fit, 50 microns when it's an oblate design. Lens settles up to 60 microns with wear. The lens is about 200 micron thick, so the clearance should be of lens thickness at insertion. And after settling, the final lens is expected to vault the cornea by about 50-75 microns. Scleral lenses are large, rigid contact lenses that completely vault the cornea and limbus and lens exclusively on the conjunctiva. The particularity of these lenses is the combination of the large diameter and the rigid material. The large diameter offers great comfort thanks to less interaction between the lens edge and the eyelids. The lens does not touch the cornea and rests exclusively on the conjunctiva, which is less sensitive. The lens is very stable on the eye. It does not move when the patient blinks, and as a result, the vision is very stable, not fluctuating, as can happen in the case of corneal lenses or toric soft contact lenses fitted on irregular corneas. The rigid material does not conform to the cornea and allows for the creation of a large liquid reservoir, which acts as a lens collecting up to 90% of regular and irregular corneal astigmatism. This reservoir during all the wearing time allows to protect, lubricate, and moisten the ocular surface. And this is crucial when we have cases with dry eyes and ocular surface diseases. Scleral lenses, comparing to corneal lenses, are more stable on the eye, and this allows better visual acuity and quality and comfort. When to prefer scleral lenses instead of corneal lenses? So referring to this study, in eyes with 300 microns or less of corneal elevation difference along the greatest meridian of change have an 88% of chance of success with a corneal GP lens. When this difference is greater than 300 microns, it's better to fit scleral lenses. The scleral lens fitting process consists of 3 steps. The first step is the evaluation of the patient's condition. The second one is the selection of the lens design and diameter, and then the lens observation on the eye. First step is the selection of the diameter, which depends on different factors such as HVID, the palpebral aperture, like in this patient in the photo who will have problems opening enough the eyes to apply a large scleral lens. The diameter depends on the ocular surface diseases, since the lens must protect as much as possible the exposed ocular surface. So for this reason, larger scleral lenses are indicated in ocular surface diseases and in cases with dry eye. Sagittal height and toric or asymmetric sclera also influence lens diameter. The higher the sagittal height of the cornea, the larger the lens diameter should be to allow a softer landing without compression of the conjunctiva. So in advanced keratoconus, larger lenses are needed, because the higher the sagittal height of the lens, the more pressure and compression then will be on the conjunctival tissue. And a larger lens allows for a more balanced distribution of this pressure. How to choose the lens sagittal height? It depends on the corneal sagittal height, which can be estimated by looking at the corneal profile or be measured with topographers, OCT, or tomography. The clearance must be about 200-300 microns before lens settlement, about 50 to 300 microns after lens settlement. Lens settlement varies in subject and can reach about 200 microns. After half an hour, we have 50% of lens settlement, and 4 hours, we have 80% of lens settlement. And remember, in cases with keratoconus, we need to consider 100 microns more for those who have the pathology progressing. Peripheral corneal zone should be assessed, and remember to adjust the lens sagittal height in the event of modification of this area, since this zone is the one which has the greatest impact on lens sagittal height. Limbal zone should be assessed in different gaze direction, and it depends on lens diameter. The height of the limbal clearance depends on the lens diameter. Here in the left, we can see a lens that is hardly touching the limbus. In the middle, we can see that the lens is touching the limbus only in the horizontal meridian, and the last picture is showing an optimal clearance in the limbal area. Now, the scleral area assessment, be careful because not all blanching are the same. Different blanching require different solutions. When the blanching is in the outer area near the lens edge, like in this photo here, it means that the lens is too steep. When the blanching is in the inner area, the lens is too flat. We are also seeing the lens edge lifting off, which is indicating the same problem. The periphery is too flat, and here we are seeing an optimal fitting. The presence of indentation indicates that the lens is too steep in the area where it appears. Indentation will appear at lens remover as an arcuate staining. Here we can see an example of circumferential arcuate staining, indicate two steep lens. In the other picture, we are seeing a sectorial staining, only in one area, meaning that the lens is too steep in this zone, needing a toric or asymmetric lens. So we have different contact lens modalities for the management of keratoconus. The selection of the lens depends on the keratoconus stage and location. The selection of the contact lens depends on also patient needs, the cost, and the visual acuity, and the result obtained with a previous contact lens fitted on the eyes. So we need to consider all the options, starting from soft toric to scleral lenses, taking in consideration several factors. Thank you again for this opportunity to be part of SSLS, and I hope that next year we will be able to meet in person, and would love to meet everyone in person very soon. Thank you.
Thank you, Dadi. It was really wonderful. Can we have Dadi on the?
Hello.
Dadi, can you put on your camera? Can
you hear me?
Yeah, we can hear you.
Yes, of course. Hello, everyone. Yes, you can see me here now?
Yes. Thank you, Dadi. It was really wonderful. Anybody
Thank
has
you.
any
Thank you for
questions?
the invite. It's an honor for me to be part of this meeting.
Anybody wants to ask any questions to Dadi? They are mesmerized and they're stunned with your presentation. You covered wonderful. Doctor. Yeah.
I don't know whether you need the Salida.
Not really.
I'm the yeah.
Can you see me now, Daddy?
Yes, I can see you. I can hear you very well. Thank you.
Hi, how are you?
Hello, I'm fine. Thank you.
And I really wanted to thank you, Daddy, because sir, whenever I have any doubts, I generally message Daddy and I mail her, and she replies me immediately. Whenever she sees my mail, she'll reply me. So I take so much learning from her. I really wanted to thank her. Thanks, Daddy.
Oh, thank you. No worries. And please feel free to contact me anytime you want. No
Thanks,
problem.
Daddy.
It's a pleasure for me. Thank you.
Thanks.
Thank you. Can't hear.
Dadi, Dr. Quresh Maskati, ophthalmologist, he wants to ask you that what is your experience with Rose K, the new designs?
Well, I think that Rose K all has been a wonderful lens, and it's the most fitted lens in all over the world. So absolutely, yes, corneal lenses are still valuable. Lenses do not replace corneal lenses, but they are an option when corneal lenses cannot provide good comfort or good visual acuity. Rose K lenses are wonderful, definitely.
About the Excel, rose ke XL lens, which is
the corneoscleral lens. Well, yeah, the corneoscleral lens is not a scleral lens because it lands on the cornea and the sclera. It has totally different fitting approach and can be fitted for initial, for mild and moderate keratoconus, not for advanced keratoconus, unfortunately. And also when the keratoconus is more likely centered, because when it's decentered, since the lens, XL lens peripherally on the cornea, we may have a harsh landing on the apex cone. So for more centered cones and mild to moderate, XL may be differently fitted, also because it allows, differently from scleral lens, the XL lens allows a tear exchange, which is very important in some cases.
So will you prefer to go with XL lens or a mini scleral lens or a true scleral lens instead?
Well, you know, I cannot say I prefer one lens to another. It depends on the patient and the case I have. In some patients, I would prefer XL lens instead of scleral lenses. In others, I would prefer scleral lenses. So we cannot say this in absolutely, in absolute. We need to take every case by its own and consider different lenses.
Right. I know you design your own lenses and make customized lenses for every patient. But usually, what is your choice of diameter? From 16 mm to 19
well,
mm, what is your choice?
I customize all my scleral lenses, and finally I have the technology which allows me to reduce the time in designing these lenses, because it takes so much time. So I have my Pentacam CSP and I have my eagle eye finally, which allows me to understand the topography and to design these lenses. This technology allows me also to understand the diameter of the lens that I need, depending on the need of toric lenses. For toric lenses, I would prefer larger lenses, just to allow the lens to stabilize on the eye, to have a larger landing zone. A larger landing zone allows less pressure and more stabilization on the eye. I am fan of larger lenses. Generally, I start with the 16.4, 16.5, and depending on the case, I go larger or I stay small. In some cases, I fit also smaller lenses. It depends on the palpebral aperture, on the dimension of the eye, the cornea, so it depends. But generally, I'm fan of larger lenses. In my opinion, in my experience, large lenses create less problems, less issues than small lenses.
Definitely. What percentage of your lenses are HydraPeg?
HydraPeg. Well, fortunately we have HydraPeg in Italy. I suggest HydraPeg for some of my patients for dry eye. It allows better wettability, definitely, and for people who have problems with lens wettability and ocular surface diseases. So definitely, HydraPeg is a great option to go for.
Do you offer any other filling solutions apart from just saline? Do you have any other special solutions for filling the scleral lenses?
Well, we have electrolyte balance solution. In some cases, I do saline. It's saline. In the majority of my cases, I provide this kind of saline because it reduces. In my experience, it's not well demonstrated in scientific reports, but in my experience, clinical experience, I see that with this electrolyte balance saline, there is less midday fogging.
Definitely.
In some other patients, I also use a more viscous solution to limit the debris entry in the liquid reservoir, or also when air bubbles are still entering despite all the adjustment of the periphery. When I need some tear exchange, air bubbles may enter. So with this viscous saline, it may be a great option in these cases.
What kind of options do you use for high order aberrations correction, like aspheric designs or something like that?
So this is a huge question, very good question. Thank you for asking me this. So unfortunately, in Europe, we don't have the wavefront customized contact lenses. We can go for only changing the eccentricity in the front surface. So for now, I am doing different eccentricities in 03, 06, and 08, depending on the case. And I'm also collaborating with some practitioners to have. I have a special case now that he needs a wavefront customized contact lens, and we are trying to get this in Europe because this technology does not have the CE. The lenses that provide these lenses do not have the CE mark. We have iPrint Pro that provide high order aberration correction, but it still need to be finalized and perfected for these patients. So looking forward to this technology to come in Europe, because we definitely need it, and it changed lives, especially not a lot in keratoconus patient, but in post LASIK, post refractive surgery patients. They have 20/20 vision, but they are not satisfied, and they need this technology to improve their vision quality.
So we saw your video on Facebook about modification of the lenses with the hand drill and a very fantastic technology that you use. So you prefer to do everything in your lab, or better you ask your manufacturing lab to do the needful and send it?
Well, in Italy, I searched lab to make me notches, and no labs could do this for me. So I started to do that
yourself.
Actually, I am doing this in my lab, so I'm not updated if now some labs are started to do this modification of the lenses. Doing this in your lab has some benefits, because the lens, you don't need to send out the lens to the lab and leave the patient without lenses. So you go 10 minutes in your lab, you do the change that you need, and you give back the lens to the patient. This is very important because some patients cannot stay without their lenses. They definitely need them. And the time, you can also order another lens, but the order of the other lens will take time and will take more expenses for you. So having this possibility to do it in your lab allows you to save money and to save time, to save frustration also to the patient.
So do you prefer, or do your labs provide you with a micro channeling and other stuff, like a special channeling in the?
Yeah, we have micro channeling in Italy, and in some cases they are indicated for more tear exchange and to reduce lens suction. Definitely, yes, these are great options.
And what are your thoughts on fenestration? on the scleral lens?
Fenestration are great an opportunity to present for some patients for oxygen need for the cornea for debris reduction. It reduces the midday fogging because there is a frequent tear exchange through the holes, so the debris will go out and some fresh tear will come into the under the lens. Also to reduce lens suction, in some cases very indicated. And I'm talking about the fenestration in the limbal area. And now Boston site has presented a fenestration in the landing area, which is fantastic, I think, in some cases, because it doesn't allow a tear exchange or reducing the debris or improving oxygen permeability, oxygen supply to the cornea. But it has only one purpose, to reduce suction. But the hole may be sucked by the conjunctival tissue if the conjunctiva is soft. To avoid this issue, you have to fit the lens slightly flatter in that area. So the hole will reduce, the conjunctiva will not suck into the hole, and the suction will be reduced from the ocular surface. Fenestration is great. Again, we need to understand when for which patient to include it. And also fenestrated lenses, as you can know, Chandra has different fitting approach. They are not fitted as scleral lenses. They need to be closer to the cornea with limited central clearance, about 100, and limited limbal clearance as well, to reduce the bubble dimension, the bubble size into the reservoir.
Thank you, Dadi. I just took the liberty of asking all my questions to you. But this was really nice. Thank you very much. Anybody has any other questions?
Yeah, just to answer Dr. Regarding Excel is a wonderful lens provided you can get the shape right. And unfortunately, all of us are so well trained in fitting scleral lenses that everybody, including the low-scale educators, they try to fit that lens like a scleral lens, which is completely wrong. So once I do a routine on all the educators, I said, what is the watt that you prefer to keep? And somebody said 200 microns, somebody said 250 microns, somebody said I get 300. Whereas there should not be any more.
It's a corneoscleral lens.
It's a good lens, it can fit it properly, but most of these senior practitioners prefer to fit with a scale or a scale. But it feels amazingly comfortable. There is no issue with the body.
See, it's basically came out from Paul Rose, who's a master in keratoconus design. Only thing what he did is he extended that diameter. So, and it's just called Excel, and then it got confused with the mini scleral and scleral lens and other stuff. But anyway, thank you, Dadi. It was really wonderful speaking with you, and thanks for your time. Hopefully next year we will have you in person here.
Thank you again. It's such an honor for me to be part of this meeting again. Thank you.
Thank you, Dadi.
And greetings to everyone. Bye-bye.
So before I, okay. So it's my talk now on prosthetic scleral lenses. Okay, so as you know, I am an ocularist also, and of course, scleral lens. So I try to combine my both technologies, and today that is what has made me, quite popular all over. And this is really helping so many patients who otherwise will not benefit with other kind of technology. Because I think I'm the only one in the world right now with this technology who can paint on a RGP material. PMMA material, of course, there are people who can do it, but maintaining the oxygen to the cornea is important when we are talking about the, when the cornea is present. So the indications are fixed dilated pupil, traumatic pupil, iris coloboma, aniridia, post PKP, corneal opacity, total corneal opacity, thysical eyeballs, and pure cosmetic purposes. So during some injuries or surgical or any other conditions, sometimes people get a fixed dilated pupil, and the moment the pupil gets dilated, the vision, even if they have a good cornea, everything, they have photophobia and the depth of focus is gone. So what we do is we can create an artificial pupil like a scleral lens with a clear pupil, and we match the cornea like an iris on the scleral lens. Similar thing for the traumatic pupil, where because of the injury, the pupil shape has changed, and again you need a central about 3 millimeter to 5 millimeter of artificial pupil to be designed. Iatrogenic injuries, again sometimes you have to do buttonhole iridectomy, and that can cause vision issues. Iris coloboma, again, if you treat these children from the younger age, the nystagmus will reduce. Otherwise, most of the time they will have a little nystagmus as they grow. But this 4-year-old child I fitted with the iris painted scleral lens with a clear pupil, and she's doing amazing. Incidentally, her sister, which was 1-year-old, also had issues, so we fixed her with the scleral lens, painted scleral lens. So of course, in this picture, you may not appreciate the color difference, but in reality, it looks quite okay. Of course, you can't match 100% because the real iris is behind 3 millimeter of the cornea, and the painting of the scleral lens is directly, behind the 300 microns of the scleral lens. But this helps, his vision improves. This is aniridia. Patient is lost. There is no, iris there. Penetrating keratoplasty is the major patients that we get. This is the pitch image on the right is very nice, but she doesn't like that, the opacity, and that we created a painting on the periphery only. And this other image that you see is actually fresh corneal transplant, but the pupil is so big that patient don't enjoy the good vision. But with the clear pupil scleral lens, patient can see much better. Corneal opacity is mild to moderate, depends. We can have a tinted lenses or painted. The difference between tinted and painted is tinted lens will have still good amount of oxygen transmissibility, whereas painted lenses, wherever there is a paint, the oxygen transmissibility will be lost. But what happens is central pupil, if we keep open, so that much area allows oxygen to pass through. So we use 120 dk, 200 dk material, and usually it is 12 millimeter iris. The landing zone is usually 13.5. So that 12 mm to 13.5 mm ring allows sufficient oxygen for the cornea to breathe and survive. Because my justification is, if you put a soft contact lens, which is only 20 dk, 15 dk, and still cornea is okay. So with the 120 dk lenses, even if I do iris painting, it's suppose because of the painting, 70% of the cornea, the oxygen is compromised. Still there is 30% oxygen allowed. The area is available for oxygen to pass through. So far there are no complications. It's working well. So this is what I was talking about. The opacity, we can have a black pupil also. tricycle eyeball, we can have the same scleral lens fitting, but we can keep a little extra thick scleral lens. And of course, the fitting philosophy is same 250 to 300 microns, and it works very nice. Pure cosmetic scleral lens, as I said, it's you can prescribe a regular scleral lens. Patient once starts using and enjoying the vision, then you can give them an option to make her eye look blue, green, gray, whatever, for party or function or whatever. So this is something new. Right now, I'm filing the FDA approval procedures and everything. It is still not US FDA approved, so I can't openly sell it. So whatever right now I'm doing is through the optometrist. If they order, so it is there, so it's off-label and it is under their care, so they can fit this. So I offer this from my laboratory. I don't fit this directly. So this is what the tinted lenses looks like. It will not block light 100%. If you want to block the light, you need a painted scleral lens. This is how it looks like. So clear pupil painted lens and opaque pupil. That is, we have few cases where the patient had a retinal surgery. She looks normal, but she has a diplopia because the retinal surgery has, it's a successful from the surgeon point of view, but patient can't see through that, but she gets a distortion because that was a dominant eye. So she wants to block the total vision, and that works fantastic. So she looks normal. There is no opacity, no nothing, but you need a something to block. So it's an occluder lens. I got a lot of orders for this kind of requirement, and it works fantastic. So we want a picture like this. So I want to see the 360-degree flash photography, and because we use this image as a digital, I don't do hand painting. It's a digital technology, and the colors, there is a stencil. Of course, I can't explain everything, but it's I vaporize the colors and tints and pigments and make it penetrate through the material. All these oxygen permeable materials are reacting to alcohol. If you put your lens also in alcohol, you said clean with alcohol, that will damage in long term. But if you put alcohol, the lens in alcohol, the lens will expand. Nobody knows that because nobody wants to put that 1,20,000 rupees lens into the alcohol, but I experiment. So that's how I found out. So if I can get the lens, because that is the technology we use for soft lenses. Soft lens painting, prosthetic lenses, you put it in alcohol, it will expand. Then you put your colors, let it dry. So it will hold, the color gets trapped into that small pockets. That is what we do for a soft lenses. So similar technology we tried for scleral lenses, and it works. So it gets entrapped, whatever is there on the surface and everything, when you clean, it goes off. But whatever is in the matrix, it remains. Okay. But of course, some superficial and color will leach out, but this is permanent. Till you break the lens, it will never come out. So sometimes I use tint and sometimes I use pigments. If I use pigments, then it won't allow oxygen to pass. But if I use tint is a dye. It's a chemical again, but it's not reactive. So but it will allow light to pass through. So it's a transparent thing. But it works. So far, it is nice. So I ask people to send a picture with a flash photography. Of course, people don't understand what to send. They think, oh, I'm a good photographer, so they will take the patient in direct light or something. And then I call them and say, hey, you have 4 lights in your background. There is tube light, because that everything is reflected off the cornea. I'm looking for an iris, whereas what I get is a corneal reflection. But anyway, so it's a time-consuming process. To finish one patient, I needs almost 1 month to 3 months, or sometimes 6 months also, because there is a lot of back and forth. If I don't see the patient, I don't know exact colors, and I have to depend. Now, same image here, the color here and on my monitor is different. On your mobile phone, it will be different. So it depends on what gadget you are using. So there is a lot of mismatch in the color. So I send them the order form and everything, and then they have to send me the details, and we do this. So tinting and painting, I explained this difference. So prosthetic, we also have a my own technology of impression scleral lenses. That is, you take an impression, today we'll do it, and I paint it to match the iris and everything. If you need vision correction, that is also possible, but I don't enter into that thing because iPrint Pro and other technology has a better techniques. So custom painting on any type of scleral lens we do. We give you an impression kit and we'll teach you how to do it. It's very easy, simple. There are videos I have posted on the, I think there is video here also. So, anybody can take an impression, send it to our lab and we can make it. We added the Hydra pig. How many of you know about Hydra pig? Good. So basically any scleral lens or even corneal lens can be Hydra pig. What is Hydra pig? It's a special treatment, surface treatment, where they create a very thin layer of a hydrogel material, like a soft contact lens material. So that makes the surface very smooth. It holds the moisture. It is very good for dry eye patients. So now what I'm doing is I'm applying the same technology to my artificial eyes also, because a lot of artificial eye patients are also dry eye patients that usually get neglected because once there is no vision, ophthalmologist has no interest in the patient, but then I have to manage, and then there is a lot of discharge and issues. So instead of putting lubrication every 2 hours or half an hour, mostly patients, sir sends are dry eye patients. So you need the Hydra pig treatment. That's additional. It is not available in India so far. It has to, which lab is offering you? Okay. So good. So it is the transportation cost is saved. And of course, injection. This is the video of the technique. So this is Matt. I think you saw him in the presentation. That's Matt's wife. It's so easy, no anesthesia, and he's doing it for the first time on his wife. So imagine, so it's very easy. So why am I telling you this is I want a volunteer next time, so don't be afraid, and we are not going to put any anesthesia. We are asking, do you feel any pain or anything? Nothing. It's an edited video, fast forward. So within a minute it will settle. Ask patient to look up, down. So that will break a little suction. Make sure it is, hard. Ask patient to look up. Release the suction from the down. Remove all the eyelashes and everything that is trapped in the silicone. So this is special silicone, non-toxic. Don't use any silicone, otherwise it will burn. Very good impression. Now this impression, we spray to make it opaque, and then this, once it is opaque, we put it in scanner. Once we get this soft file, we use it for further processing. So it takes more time to manufacture these lenses than a regular lens because there are a lot of ups and downs, and the manufacturing time is almost 4 or 5 times the regular lenses. So that's why the cost is also. You can see that image which is irregular. That is because of the lens shape. So, we can use a prosthetic scleral lenses now for the opaque or corneal complications, pupil complications. Thank you very much.
Again, then post. So Dr. Gulani is on the airport right now, but he said he can be available for a quick interaction. So we are taking him online. Dr. Arun, can you hear me? Dr. Gulani, can you hear me?
Hi, Dr. Shekhar. That's an excellent talk.
Thank you. Thank you. It is so nice of you to be joining us at this hour. Oh, you're still at home or you came just now from the airport? Okay.
Just leaving for the airport. Any questions from anybody at all?
Anybody wants to have any questions? Sir, come here because then he can see you.
Hi, Arun. Quresh here. Just to say hi, no questions.
Good evening. How are
Good
you?
evening. How are you? Well, all good. Where are you flying off to?
Well, I'll be teaching in Singapore and then actually I'll be in India for 2 days.
Okay.
Still planning the days out there, but great to see you all.
Okay, let's hope we can get together when you're here for 2 days. Yeah?
I will certainly try.
Okay. Okay. So everyone here enjoyed your talk and your sound effects and visual effects and color schemes were all great. Yeah.
Thank you. As long as we taught everybody that they must look at the mindset of how to approach a keratoconus patient. My biggest point being, cannot paralyze yourself and the patient by making this diagnosis. And I loved what Shekhar just showed too, is how people give up on patients when they just assume there is no potential. There is so much work to be done, and these patients are so gratified. That's why that Quresh, as I keep showing, there's no higher accountability than a patient on camera. In fact, I tell surgeons, get addicted to this appearance and their happiness, because there's no way you should go home without doing anything for them.
Thanks, Arun. Yeah, there's a question. 1 minute. Yeah, go ahead.
Hello, Dr. Durante. This is Verkicharla here.
I can't hear you.
Come here.
Go ahead.
Come.
Hello, sir.
Hi.
So just had one question for keratoconus patient. Of course, you do multiple surgeries to make patient 20 by 20, but this is just from our clinical optometry point of view. If you are taking patient for a cataract in keratoconus eyes, are you taking any consideration when you are taking a lens measurements or selecting a IOL power of a lens?
Certainly.
I would like to interrupt. The patient that we did, so Madhvi was the one who helped us with everything. Anand Pete, the keratoconus patient that we operated at Dr. Sahu's clinic with success. So she was the instrumental person. So she has a lot of interest, and so that's why her question will be more to the point.
Thank you, sir.
Well, first of all, congratulations, doctor. And I remember Dr. Shekhar asking me about that patient. So how do you feel that your patient now is seeing perfect?
Amazing, sir. It was wonderful. That's what when you are giving a talk. Yeah.
Exactly. Stop. I don't want to know anything more. All I wanted to hear was amazing. So all I'm trying to say to you all is, it is not just keratoconus. To me, even an ordinary myope, and Dr. Shekhar has been to our institute, it's been a pleasure having him here, is every patient to me is unique. Every patient, our brain must go through the 48 techniques that I teach. Cannot do a cookie cutter surgery for anyone, right? If you keep that mindset, it doesn't matter if it's keratoconus, my intensity is the same. And now that you have finally done this patient, I don't want you to forget the exhilaration, not only of the patient, but your own excitement. And the fact that you will not tolerate anybody saying no to any patient. Am I right or wrong?
Right, sir.
Now, next question, which is the least important. What lens and what every doctor, after I finish speaking, they have the same mundane question, what lens? You know how I answer that question? You don't ask a master chef what ingredient they used. It's the recipe, it's the artistry. You saw Shekhar just now repeating art 3 or 4 times that I was here. It's very important to understand. It's not the lens. The magic is how you approach the patient, how you plan it, how you design the surgery. And then the lens, yes, is very important. And yes, you do take consideration. There are formula changes that I do that I've talked about before. But in keratoconus, more important than that is stability, measurability. It's just 2 lines, stability, measurability. Otherwise, no surgeon should be allowed to enter the eye because that's a very sacred area, correct? You can't go in changing lenses. You can't have concepts I'm bringing out in stitching, all that. I want the patient at 20/20 and dancing in front of you. So the lens is important. The measurement is important. There are various formulas, especially my fudge factors that I've used for 3 decades. But more important, we want to talk about in this amazing meeting is how we got to approach these patients, and they all have potential to see. And scleral contact lenses are very important advancement for ophthalmology. Because after the surgeon has operated, there are many cases where I cannot reach 20/20 because the patients are coming to me with 100 micron corneas, extremely scarred. Now those cases, I still take them surgically to at least 20/40, 20/50. Then you put on the scleral contact and magic 20/20, 20/25, right? But most of these patients, I want to say this, do reach 20/20 if the surgeon is diligent. And it's not extra work, it's just more planning. Surgery still takes 6 minutes, 7 minutes, but you change their lives. You will not, if you had your only son or only whatever loved one in your family, you wouldn't cross-link them and tell them live with this, right? I have patients who call me every day in tears. They're crying on the telephone. That surgeons have told them, we've cross-linked you, now go live with this. Or, you know, let's put you on a contact lens. Contact lens, great, but cannot be first option. Surgically, please encourage your surgeons to say, hey, this patient has 20/20, doctor, unless proven otherwise. That's the attitude. It shouldn't be the other way around. The patient's blown. So now that you've done that patient after we discussed, I want you never to forget that feeling and be infectious. Anybody sitting next to you should be equally excited.
Sure. Thank you so much, sir. Thank you for your guidance. Thanks.
Thank you, Dr. Gulani. It was really nice of you to be joining us at this moment. Wonderful. So hope to see you in Mumbai. If you have some time, definitely we'll catch up. Any last message?
Again, congratulations for a wonderful meeting, both you and Dr. Quresh, and keep it up. That's amazing training, and I love the enthusiasm to excite the doctors. Want to make sure they do this. So again, congratulations on a fantastic meeting. I'll be leaving now.
Thank
All the
you.
best.
Thank you, Doc. Thank you. See you soon. Bye. Bye, Vinay. Huh? That's all. Sir, don't go. No, I had to just finish this thing. इसका आवाज कम करो. So it's time for announcing our free paper winners. So since we don't know who was first, second, third, so we haven't prepared the certificates. Certificates will be sent to you. So I request Dr. Maskati to be here, and now so there was a really tough decision to make. So 4 people, there were tie. So we had to take one more guy to, pitch in. So thank you. Congratulations for a wonderful presentation. Everybody did really good job. That's what actually I wanted. I wanted more people to participate, but at least 3 what we got was, really classic. And another thing is Jalak Shah was the last year's winner, like last meeting's winner, right? Oh, okay. But you have presented in the meeting. That's all. So. So the first prize goes to Shivanand Madhin. Congratulations, Shivanand. You'll also get a certificate. Second prize goes to Anjali. So you get an opportunity to shake hands with Dr. Maskati and a photograph. You'll get a certificate. Third prize is, of course, Jalaksha. So actually, all 3 did wonderful. So round of applause for all of 3. So now I request Dr. Jethani to felicitate Dr. Quresh Maskati. Sir. तो बाद में सर के हाथ से आपको No, but the name will change. Jethani sir का Dr. Jethani. हाँ. No. Name. दिखेगा. Thank you, Dr. Jethani, for coming all the way from Ahmedabad. He was reluctant to travel in this COVID situation because, he used to sitting at home on giving presentation on the Zoom. So it was a difficult decision, but I forced him, no, sir, please, you have to be here person. The whole idea was to break that COVID mentality and be there in person. So thank you very much, sir. I appreciate that. So I request again Dr. Maskati to do the honors. I invite Yashwant Savji. Again, Yashwant also immediately said yes. If there is no problem, I will definitely come. So he's been coming to my meetings since 2015, and thank you, Yashwant, for all the support. Ajit Limaye. Yes. Ajit also has been real support for so many years. He traveled from Sangli to Mumbai yesterday night. Day before yesterday. Early morning he came. Thank you, Ajit. They're not here, so. Madhvi, please come. Madhvi also has been attending my meetings regularly, and she helps me with my patients. Just now, we were discussing with Dr. Gulani. So all our complicated cases and everything, since it's a new technology, we need a lot of guidance from Arun, and we successfully did keratoconus patients. He was terrible. He could not see without the lenses, and his issue was the moment he takes off the lenses, he can't even go to the toilet. So he wanted to give me some vision which I can manage, and then I don't mind putting scleral lens. So we operated only one eye, and now he's 612 without any correction. There is still a lot of irregularities and opacities and all, but he's amazing. So other eye, of course, we are waiting. We don't want to, we are still not confident. We are not Arun Gulani. Huh? No. So keratoconus patients, so we did a ICL and then topo-guided PRP. Thank you. CT. I think everybody got the certificate, right? Yeah. So I invite Chandrashekhar Chawan to come forward. So I think we covered almost everything. My one talk is left, but I think there is no time for that. I will put it on YouTube and send you the link. All these talks, I'm going to put it on YouTube break-wise so that you can select which one you want to again listen and everything, and I'll share the links with you. So most important, now we'll go with the hands-on training. So what we are going to do is we are going to divide two groups. One table will be scleral lenses, one table will be orthoke lenses, and feel it and everything. And we'll of course do the demonstration. That is, we are going to put the lens in the eye and put a fluorescein and see how it looks and everything. And scleral lens will actually start with the impression, and then we'll put a scleral lens also. So just get yourself divided into two, and we'll start. to do it.
The multifocal presbyopic patient, and you are using this as a fitting set. Same thing, follow the same footstep, get the fitting, the microns, everything. Then you see on the slit lamp with real visual, you are seeing with your own eyes, and you know it is decentered. Find the center of the pupil and find which line it is intersecting. So that line you have to tell. This is the line, third line, fourth line, fifth line. That's okay. Let us not discuss what is available. Right now, I'm telling you about this, okay? Because not everybody knows what company. So right now, this is available. You can talk to them directly, and they will supply you these lenses. Of course, you will have to buy a fitting set first, but they can do it because they have a agency here. Because she's getting it from them, that means there is agency, so they can coordinate and get you this fitting set. This is relatively new fitting set. In last GSLS, I saw this, but because of the COVID, they could not do promotions and everything. But I think they'll be concentrating more on this. So this is the hot take, latest thing. There is a Zen lens also, which offers you multifocal lenses, but there you have to tell them. They default displays to 2.5 millimeters from a real central zone, but that doesn't work. I made my own lenses. I had to make almost 3 different lenses till I get that, because we were gazy, right? We don't know how much is this. Here you actually know how much decentration you have to do and which direction decentration. So this one, then Boston lenses, she explained you everything. I'm going to put the same video so you can again go through. The main thing is hands-on. Get the fitting set, get the patient, put it in the eye and start. And then you know what complications you get and try to solve the things. Then Hydrapic, you said it's available in India. So any lens can be Hydrapic. Hydrapic is suggested for dry eyes patients. So it is wonderful. Only disadvantage with that is then you have to use their solution only, because if you use Boston Simplus or any other, the coating will go off. So they have their tangible Hydrapic solutions that you are supposed to use, and they have come up with tangible boost. This is recent thing that they added, because every time it is a soft material which is definitely going to go off over a period of time. So with this, if you do every 3 months, it again builds up. Otherwise, you have to send it back to the lab. They will do it, send it back. So it's a time consuming. It's not available in India, because it's not easily available in the US also. But this is the thing. I use the similar technology for the artificial eyes. You can take it out and feel it. It's really like a slippery thing. So this is suction cup, and this is plunger. People mix up both of this. Plunger is like you use the plunger for your bathroom. Right? It's the same thing. So it has a vacuum. I don't like to cut this back off and whatever artichoke, all those things. So that is for people with arthritis, where they can't use it. So for those people, so why they are doing it, right? It's difficult if you poke in the eye. That is for people who have motility. Right? So because see, dry eye patient, why rheumatoid arthritis? Severe rheumatoid, they can't have a good finger movements and all. Then they have to move their heads. So now let us go into impression scleral. So this is an impression tray. You can use any tray. If you have any ocularist, you can use that tray also. So I'm going to show you from the beginning how to make this, how to prepare this. So this is basically, you can get this gun from dental supplier also. So it comes like this. This you press the back, press it till the end. This is the special silicone. This you won't get in the dental supply. If you use that, then you will have to find a corneal surgeon. Send for a okay. So this is part A. Part B is the silicone. This is the tip that you use. So open this. Who's going to be my volunteer? Thank you.
Thank you very much for having me here.
No, sir.
So she will arrange the drive. She's a big. So
we'll hold it for you. We are waiting for you.
And another thing is, I'll just take an extra liberty. Whenever you are in Nagpur, do visit his clinic. You must see the way he has presented, and that's what I want all of you to have your own clinic. Okay, that's the way to go. So whenever you get a chance, do go and visit. Of course, you can visit my clinic also.
You have a data.
Yeah. So who wants to be my so let us get a chair for you so that you won't fall off.
Excuse me.
कितना अच्छा पेशेंट है वो पहले से लिख के दे रहा है कि डोंट वरी मैं कुछ नहीं कर रहा तुमचा होता है का इथे याच्यावर
given by the patient, taken by the patient.
That is informed.
And I have so many witnesses.
Live camera is on.
ये दिला होता ना tissue paper. I had to wash my hands and completely. Yes.
Is there any chances of putting silicone?
एक आंख है ना
एकदम खड़े हैं पास में ही कुछ हुआ तो
Madam, trial was done as much as the observation
अगर कुछ हुआ तो पहले बोलेंगे कि स्वाइप करो कार्ड ये करो
भाई डॉक्टर कभी नहीं बोलते स्वाइप करो डॉक्टर मस्त होते हैं आजा आजा देख लेते हैं देख लिया ना सब तीन और भी है उनको भी देख लिया ना अभी इनको भी देख
डॉक्टर कंसेशन देंगे क्या
कंसेंट का बोला ना इसलिए वो हाथ बनाएंगे उनको भी लगा यार मुझे तो आता हूँ मैं यहाँ पे
हाँ
कैमरा ना
नहीं he is asking to take everything on the stage. That's okay.
उन्होंने कंसेंट का बोला तो आपके कॉन्शियस हो गया हाथ चुके आता हूँ कंसेंट का बोल रहा है
This is habit, no? Before you touch the patient, you have to so
रिकॉर्ड इथे असताना काय पाहिजे
पण एंट्रोल
के बाद एट्रोपिन है
वो एंट्रोपिन Already तेरा है. This is just for a comfort sake. Which eye is your dominant eye? Right eye dominant. Oh, we'll do it in non-dominant eye, so you're comfortable. See, these are small things, but that makes a difference. When you want to start with fitting a scleral lens, start with the dominant eye. Because, you know, he starts seeing clearly and everything, then if you did not know, farak nahi padta, theek hai yaar. So that helps. Usually we don't ask about dominant eye, right? Do you know how to check dominant eye? Huh?
Yes.
हाँ? कैसा करते हैं?
वही आपसे वो दोनों आंखों से कंपेयर करो.
अगर वैसा नहीं है तो दूसरा क्या चीज कर सकते हैं?
तो विंकिंग के लिए भी पूछ सकते हैं ना, विंक करने के लिए भी पूछ सकते हैं ना, which eye remains open is dominant eye.
One more.
Camera. Ask to him, yes. Even older style camera also people focus with the dominant eye. And you can do WFDT also for the
I am asking you how you will ask patients.
righty or lefty.
Righty
or lefty.
Using right hand or left. See, I have to come up with something different. That's why I'm asking.
But for that,
okay, there is one more trick. Last patient we have corners, right? A straight line.
Close one on the right.
Let's finish, So it's okay. So ask patient to, you know, make a finger parallel to that. Okay, now this finger is parallel to that straight line. Now close one eye and then close other eye. In one eye, it will still remain parallel. With other eye, it will shift. Shift. That means right eye is dominant. Okay, so we'll use his left eye. At least I could teach you one more trick.
ये क्वेश्चन उसको थोड़ा कंफ्यूज कर देगा, लेकिन मारता हूँ यार, ये तो देखने लगे, ये तो ठीक रहेगा.
हाँ.
वो थोड़ी नॉन डोमिनेंट है तो उसको.
Now we have example. She said
she had a doubt.
Dominant eye is different, but still she is using the other eye because it's a सब लोग देखते हैं ना ऐसा ऐसा मारते हैं तो वो भी ऐसा ही कर रही है. She is understand Hindi, so पता चलता है. Okay. So usually this is a iPrint Pro tray. It has a flat edge, so that goes up. There is a one notch also. So this is indication. Many times the whole impression comes round, so you don't know which is up, which is down, what is what. So this is up. So what I'm going to do is I'm going to fill up this with the silicone. Ask patient to look a little down. And then I'm going to hold the upper lid, insert this, then ask patient to look straight, and then release the lower lid and hold it there for a minute. Then touch, feel it. If it is solid, then I'll remove. Okay? Okay?
Yes. And what marking there exactly is?
This is flat, है ना? आत्मदेख marking. This is just to hold the thing, but this also helps you to.
So you're holding the
locate.
flatter.
This is 12 o'clock. Okay? This is good. Yeah. So you know how we did this. Again, if just for the sake of the camera, we'll know how to load the thing. तुम्हें हाथ नहीं दुखला but आता तो इसने तो consent
दे दिया अपने को रिटर्न.
तो consent दिया करके तुम्हारे responsibility खत्म नहीं होता. So you take this up. Tension आ रहा है. We have world's best ophthalmologist here. कुछ भी हुआ तेरे को Here. We are all here. Okay, so there we go. If you want, you can try. Right? If he allows you, or you find another bakra. I'm not saying you bakra. Okay. So now you don't have to wait. Okay, so you start with the down, so there is no air bubble. Just keep on pressing, fill it up, right? Then, so look down. Look straight. Keep looking straight. Look here. That's it. कोणाचा हात कव्हर तो माझा हा ठीक आहे तू जिथे बघतोस तिथे बघ माझ्या बोटाकडे तो असा पण बघत नव्हता त्याला काहीतरी इंटरेस्टिंग मिळालंय तू हसू शकतो अभी इसमें क्या इम्प्रेशन हिलने का सवाल नहीं बिकॉज वी आर टेकिंग इम्प्रेशन ऑफ द तो वो फर्क नहीं पड़ेगा
सर he can blink normally, he can be normal.
How can he blink?
No, right, that
like that he can blink. Are you comfortable?
Yeah,
no pain, no nothing, right? You may feel little pressure, you may feel of course foreign body sensation because we are you feel like dancing.
Is there any
foreign
need
body
for
that I am
paracan?
feeling? I am not able to blink fully, so that's little blurry, but that's okay.
See, simple thing, how you will know whether patient is in pain or not? He will start crying. It's a natural reaction, right? The water has to come out. There is no watering. No watering. And when we remove it, there will be a little redness, but not like a real congestion. Okay. Of course, when you're doing it on a diseased eye, there may be a little different reaction, but believe me, there is no pain.
No pain.
So can we insert paraffin and do this or not? Why?
Does it make a difference?
No difference. You can use paraffin. I don't like to use paraffin because the moment you put a paraffin, the epithelium is going to get little distorted. So this is the best thing. Of course, anyway, even if epithelium gets distorted, nothing happens because we are anyway going to vault it over. So no issues. So let us check whether this is solid. It's still.
I can feel a little.
Yes, you'll feel a little difference.
Yeah.
You'll feel. Good enough. Thank you.
I'm wearing contact lenses.
Yeah, so we can remove the lens.
Okay, this is another trick that I do for my, the prosthetic lenses. I put a bandage lens because many times irregular corneas are there. And anyway, I don't need that. And I want to maintain 300 microns of space. So best is of course, not a regular, you can use a regular lens also, but I have special, little thicker soft contact lenses. So that I put, and then I take the impression. So then just use the same impression and don't do any modification. I don't have to even scan also. Of course, I have to scan for a thing, but then I don't have to edit. Now in his case, if I use this impression, I'll convert it, then I have to edit and change the central thing to 200 microns. But if you use a soft contact lens, it's already there.
So it should be mentioned whether it has taken over a contact lens or not. That should be mentioned. Yes.
Okay, so this is ready to come out. Now listen to the sound. Okay, when it breaks, there will be a click sound. थोडंसं पाठीवर कारण तुलाच ते नंतर बघता येईल त्याच्यावर. Sorry.
You can see the.
Can you look down? Thank you. आपण आर्टिफिशियलाइज करून टाकू त्याला. Fantastic, very nice.
Let me put a torch here so that you can see nicely. Yeah, okay.
Yeah. I'm okay.
वीडियो में लाइट कर दो तो आप टॉर्च आ जाए
वीडियो में ही लाइट ऑन कर दे, ये जैसा है ना.
ज्यादा लाइट
हाँ,
See, he has a very nice this thing. Huh?
beard is there but it does not come in the impression.
So now if you see this area, can you see a little irregularity here?
Yes. This one.
Right? So even that blood vessels which are there, that is picked out.
Can you pass on that so that?
I'll pass. Right? Okay. I'll give a chance to him first because तेरा खुद का आँख है देख ली.
कभी ऐसे देखी नहीं.
ठीक है ना, आँख बाहर नहीं निकाला मैंने. I can see. Just pass it on.
कोशिश किया है पर नहीं आया.
Don't touch.
Dry हुआ रहेगा. Thank you.
Thank you. Thank you.
See, patient will cooperate with you because there is no choice, right? You are normal, you don't need it, so
सर एकदा कॅमेरा दाखवा इकडे.
Actually, light from the
we are a little bit scared because you are doing something new, different. We are not sure what is going to happen with that, but you don't need anesthesia. You don't
This
need
is
anything.
flattened.
Patient has to be cooperative.
Which is at 12 o'clock.
Many times, what happens practically, now since he
The
knows
impression
what he's doing,
has
he
a
is
central
cooperative.
corneal
Patient,
mark,
you may have to do second impression, third impression.
and you can also,
Patient will
if you
be this thing, and then if you are not quick enough,
focus it
what
properly,
happens is
you can actually see impressions of blood vessels and conjunctiva.
soft thing is there, and then you are trying to reduce it. The finger gets slipped out, and then it is difficult to get the lead out. You want that lead out, and then the spray should go. So that's a little trick. So you have to be little quick. Otherwise, you put a tape here and keep that thing ready, and then put it. But if you put tape, is that the patient goes more and more into tension. Idea is,
How are you feeling now? Natural?
no, bubble will come. So that's what I did is I press it inside and then fill it.
Congestion है क्या?
ऊपर से करूँगा तो
Conjunctival congestion है.
हाँ?
Conjunctival congestion. Irritation नहीं है.
See, it's a foreign body anyway. Only thing is, it is not this silicone. Do not. If you take any other silicone, usually it releases chemical oil, and that is toxic to use. So that's why I said don't just use any silicone. This is a special silicone buy from. You can buy from their silicone is different than my silicone, but I have a manufacturer in the UK, which Ken Fulham uses. I learned from him actually when I was in Multifocal hospital. I was learning the prosthetics, but he was next door, so I had an opportunity to see him. So he is using this since downhill. So it's amazing. Time to impression scleral lens for a fair. No, I will tell you your cost. You
Yes,
charge
our cost.
whatever. What you charge is your. So 5,40,000 rupees pair. Okay. Usually you will need both. If it is only one, then half plus the $120 for custom and everything is your job. Because it will come in your name and you have to pay the custom. If it gets. So impression scleral lens, if you do, you have to try any scleral lens like you try, so that you have to tell me the base curve, or if it is a Boston scleral or anything, you just tell me the name and the overcorrection, because that will decide your final power. If your power is perfect, the first lens only will fit perfectly, no need to do anything. Once you get the again, you can do little overcorrection, and if there is a power difference, then you tell us. So that we make another 5 grams. See, within a few hours.
Second exchanges.
Huh?
second action, there is no cost. See, usually in USA, it is a understood. It's a warranty system because.
But roughly कितना custom का हो जाता है 540 plus how much custom?
Custom duty? I don't know. See, usually it is only one lens. They will not bother, and I will send you as a gift or something. You know, as a project or something like that. If you keep on getting, then the custom becomes aware of इसको जाना है. And if I usually what I'll do is I'm sending to Preeti. I'll send Preeti. Okay, if I put her business name, then they know it's a custom. So they will charge anything. Usually, Indian custom charge 36%, which is very exorbitant, and then it will delay also. But if it is like 1 piece, 2 piece, or something, they don't bother. Okay, let us go in the next thing. So I can't ask him to be my.
So this is
Okay, so since he agreed happily, without he changes his mind, let me start with the scleral lens. So this is right eye and this is left eye. Okay. So all other companies will never give you right eye, left eye because it's a universal design. Here there is a little difference in the design. When Ken Pulam came for first time, we saw his lenses very thick, but he has right and left eye profile because if you see when you do the iris profilometry, you will understand the nasal part of the sclera is little flatter than the temporal, right? But this is a spherical thing, so it is going to cause little, that's why it gets shifted also. And once you know these things, you will learn slowly. Even I took 10 years to understand, and then of course that time there were not many toric. Now everybody offers toric, so suddenly you start fitting toric and it works fantastic. But it is again a guesswork because you're putting the lens and looking in the slit lamp, and what you're looking is the blanching, right? The blood vessels, whether they're getting press on this and that. So that's a guesswork again. It works, but if patient is sensitive, patient has allergic conditions, then patient will have a midday fog because eye is going to react. It will start creating a suction, discharge and other things. So which eye shall I put?
Now right.
Preeti said ke, so
एक ही पे करना भैया.
What do you mean?
Match your eyes.
मुझसे ज्यादा मेरा ड्राइवर फेमस हो गया
प्रीति तेरा ड्राइवर है वो
फेमस तो
होना ही
put it in left eye. Ajit also says put it in left eye.
देखना ट्विटर में हैंडल अच्छा हो जाए प्रीति का ड्राइवर प्रीति का हैशटैग
I thought of putting in left eye for the reason that suppose our impression has distorted his epithelium. You put this and it works as a bandage. By the time we finish and remove, it will, become normal. So, okay, which one you want to try first? He's myopes. We don't know his keratometry readings, but he is normal, not keratoconic. So, which sag height you want to start?
Generally 44
Standard one. So, you have standard 2.6, 2.8, and 3. These are the sag.
2.6. Why you want to go for high?
16.
16 कौन सा?
16 mm
You
diameter.
want to do this? Okay. तो फिर वो DL 60 भी बोल सकता था. So this one, okay. Give me help. Anybody else with a different idea which you want to try?
Generally, it's
No, you gave me your thing. Now anybody else want? Any other? You want to try this one? Why? Okay, I'll not ask you why. Anybody else? See, the sag height is what? Ectasia of the cornea, right? So 2.5 is the base, means simple, non much ectatic, or mild, whatever. 2.8 or 3. Not necessary that you don't see ectasia. That doesn't mean that cornea may not, like, it depends on the whole eyeball, right? So she selected 2.6, which is the correct thing because
is a normal, we don't expect anything. But if we select the exact wall and you're not sure because we don't have a slit lamp, and if the lens touches the eye, the experience will be bad. See, the first impression is everything, right? So
2.6.
better to hold not steeper. See, we talk about what? Higher side. Okay, so you put a higher side first. Okay, you may have to put extra lens, but it's like this. So you want to finish it fast, or you want to spend more time with the patient? What do you want to do?
Finish
it fast.
I want patient
Spend
impression to be happiest.
Yeah.
I'll tell you. See, and this is a practice management tip. Doctor is busy. He's not, he don't have to create any impression or nothing. He's charging routine, so he don't want to spend time. No patient will say, "कि हाँ वो doctor ने बहुत मेरे साथ गप्पा मारा." No patient wants to talk with doctor, but doctor has no time. Whereas if you spend more time with the patient, see, you are charging 3,50,000 rupees or 1 lakh something, right? So you want to make him feel that you are doing so many things. Otherwise, usually you just like तभी तो स्लिट लैम्प पे भी नहीं बिठाते थे. टॉर्च मार के उसको एक lubricating drop दे दिया, चश्मे का नंबर दे दिया, इतना सा टॉर्च मारा और 500 रुपीज चार्ज, right? But if you spend time, do duochrome test, थोड़ा color test, ये वो, yeah. Plus you have to write eye drops, plus दूसरा एक eye drop, some multivitamin tablet, these that, उसका बिल ऐसा 500-600 रुपए का 1000 रुपए का होना चाहिए केमिस्ट के पास जाके. So he's paying you money for consultation and paying same money outside. ना बड़ा डॉक्टर है ना चार्ज because it again it depends. Yeah. वो भी मैं वो अमेरिकन इधर मिलता नहीं, एलर्जन का दिया मेरे को. It's a practice management tip. So it depends on what you're doing. See, obviously you're not doing this for a charity. It's not a camp, right? So give your best.
I was telling time for we want to learn.
This is in fact learning more, no? So you will know.
Generally, we go start with this.
And now she's saying this.
No,
I
sir,
said,
generally, I was like
3 times 2.6. Madam.
But generally we start with this. That generally I started and then like no, like you don't know.
Okay, so
Central lens is the first lens to be right.
So we'll try this. Okay. Central lens of this. So then you go flatter or thicker. This is for extra, precaution. Okay, so let us do this. Now I need a Boston Simplex. कितना बचा?
524.
जरा पटकन आटो तो अभी वो एक आंख में वो लगा देता हूँ. बकरा मिला है.
Give me a look.
So keep the fluorescent strip ready with you. If you have an assistant. बस इसको ये चाहिए अपना चाबी वाबी डाल.
पेन होगा ना, पेन का वो टिप.
So what do you think? Should I use this water to wash lens?
No.
Never use water. Never use water. Except washing your hands. And even after washing your hands, use this solution to clean your fingers. Or use the saline. So I'm using only fingers. You can ask patient to put it on the palm and clean from the inside. The chance of breakage is more with that technique. Less unless you have a bigger So keep your nails short. How many of you keep nail cutter in the clinic? Good. So, plunger also needs to be clean. And I usually keep little extra the solution inside, so that keeps the surface more clean, more moist. You can always check if there is any residue, because this is a trial set, right? You don't know whether you have cleaned it properly and all. You are supposed to clean the whole thing at the end of the day or after every patient. If you have an assistant, madam, clean it. So I'm going to rinse this off.
No, it's not rinsing. It's going here.
Typical service number, there is a side number.
Now fill it up. See, when you clean, you understand whether the surface is smooth or not. But right now I'm just going to go ahead.
Because yes.
Right? Somebody can hold this. So there is a black dot goes on 12 o'clock. So this is
Best of luck.
Okay. Very light card. Okay. So ask patient to look down. Okay, chin in. Look at itna much. So look at your finger here with this, with the right eye. Okay, with the right eye. I'm going to put the lens in left eye. Don't squeeze. Nothing is going to happen. No pain. No nothing. Take a deep breath.
Rocky मध्ये no pain, no pain, no pain, no.
ये cooperative
Looks great.
मैंने कभी किया
Are you okay?
कॉलेज में टेस्ट किया कॉलेज में किया
Go like. Direct one karo. See?
No bubbles. No bubbles. Just that.
I'll go back.
हाँ मी चालू ठेवते
Oh, it's heavy, no, it will
Also kill the part down. Saline also.
Because saline.
What's your name? It has to go like this.
Okay, thank you so much.
Lens will follow.
Yeah, I'm just seeing that. I always ask the patient to
Change.
If I'm like this.
It's your technique, your trick. If you be quick enough, I can put like this also. You have to be quick.
No, but now
Before the solution falls. I'm going to give you this. Take this. And do okay. You can hold this. Press it and put it on your nail and see it. Okay? So it creates a suction. Okay, so lens will not fall. Or जैसा तुम lens लगाया, you just press this and release the eye, so it holds. Okay.
Original को ना अपन ने जब PM में start किया तो ये से हाँ पर अपन ने
मैं बना. I started this and I got it this. There was nobody here. So I started manufacturing.
Okay.
So if you want, we can do it.
Oh, you can buy it now. There are so many people who make this, but it has to come from US. But if you want from here, it is. सबके साथ आता है कौन देता है कौन देता है
Because I never got any.
पुरानी बात है
हाँ वो आप पुरानी बात
I have lot of them.
पुराना नहीं है
Okay, you can donate it to us.
because I started अभी कोई which company के
The moment I get to know what I say,
because you don't want to spend money because I was the only one.
Do you order and that company will send you that every time?
Which company? Company number के साथ
Okay, so are you okay?
Sir, is this a bubble?
See, tell me.
No, sir.
Who said?
नाही एक आपण जाऊन काय सांगायचं मला
नाही कुठे दिसतो मला तर नाही दिसत आहे
12 o'clock.
12 o'clock पे बबल है नहीं I don't see
Even I cannot see.
that's the reflection you are seeing so now what is your observation
Vaulting is much more actually. Sag is more.
तुम्हाला ते कॉर्नियल आरजीपीचं स्टीप आणि फ्लॅट see what is happening here is there is definitely a little extra wall we show it but you can see the touch here
Touch at nasal and temporal.
here there is almost no fluorescence so that is touching at the limbus right so what you have to do you have to focus नहीं हुआ बेटा तेरा थोड़ा पीछे से ना फोकस में कर रहा टेक वाह वंडरफुल
Sir, तो क्या करना है? Central touch, nasally touch हो रहा है तो?
so you have to tell your lab this is what it is you can send a picture or ask them to increase the landing zone
Only nasally.
no temporarily so that's what I'm saying ना उसका वो बढ़ाना पड़ेगा ना ठीक है मैडम डॉट है तो अपन निकालेंगे फिर से वाटर डालेंगे फिर से डालेंगे ठीक है इसके ऊपर you see the slit lamp so you will see now this is rotated here right so if this is at 12 o'clock you will see 1 2 3 and 4 laser marking okay you have to see photograph ketla ka koni ketla photo just enlarge take the image one more from the front quick front
ऐसा नहीं रे बड़ा करके ले हल्लू
आ गया इमेज आ गया नहीं ते मोठं केलं ना तुमचं रिझोल्यूशन जाणार and then increase if you पहले से zoom करोगे तो it's a digital zoom ना that's your relay का sharpness focus sharp आना चाहिए अभी इलाज करके देखो उसके ऊपर मार्किंग है क्या no 1 2 3 4 ऐसा लिखा होता है anyway that's some meridian 1 2 3 4 so when you talk to the lab you know which meridian to change touch है
Two dots.
dots okay so I'm going to put पैराकेन
तेरा फोन ही गड़बड़ है पैराकेन नहीं है तेरे फोन में पैराकेन कहां है पैराकेन नहीं है
ना पैराकेन
एकदम में दिखेगी छोटा पैराकेन सारा क्या नोटबुक कहां से
हीरा वीरा रे एलवी प्रसाद मी काहीच नाही विकत
पैराफिन
झालं का मी इतकी वर्ष मीन्स
If somebody, I'm sorry. If they want your design, then only you will.
This is available here. It's cheaper also. If you buy from me, I am going to add my margin. 20,000.
20,000 for?
You, one lens.
One the set.
Just call LVP. I'll send an email. We want to become a Boston scleral lens practitioner. So they will ask you whether you have experience with that. They also want money. They will send the money. They will send you a fitting set and start. It's easy, simple. If you say I want to learn, they will send some videos. That. All future conferences are going to be like this only.
What is this gun called? Dental gun, but this is different.
Dental supplier, you can buy from me also, but see, I don't want to say I want to sell. I don't want to sell anything.
Sir, please
okay,
be.
If you
tell us why we have to go to 10 places. You tell us a proper way.
सस्ते में मिलेगा.
मगर आप बोल रहे हैं ना वो गड़बड़ है, उससे कान में तकलीफ होएगा. Why we? सिलिकॉन का बोल रहे हो. अभी तो सिलिकॉन उधर लेंगे, गन किधर से लेंगे? क्या सर आप घुमा रहे हैं हमको?
So then you will select what you require is good quality silicon.
This too comes with like that or?
This is disposable. Once it is finished, you throw it up. You can't fill it up. वो शॉर्टकट मार रहा है उसमें फील कर
अरे घर में प्रेशर कुकर बना के वो सिलिकॉन बॉईल करके नहीं मिला
बड़े प्लेंजर से निकाला तो
He's a younger.
क्योंकि उससे मेरा बात हुआ था because I have one patient in Malaysia that I wanted to refer. So
there on that optometry group.
ऑर्थो के ट्रायल से सर एक मिनट एक लेंस कोई भी एक लेंस निकाल के दो फ्लोरेसेंट रेडी रखो.
What is your lens?
So right now we don't know his K readings and everything. I just want to show you the pattern how it looks. Okay, so that's why we are putting this. This is RGP lens, but it's a reverse geometry lens, right? RGP
क्या diameter है?
That's a 10.2.
8.6. Diameter 10.6.
Yeah, let him show that lens.
So how to select the diameter for the ortho is 90% of your HVID. So HVID is say 12, then 11, like that. Okay, because you don't want lens to move too much, but you want little movement for a TRX. This is gone, huh? That is solid. Solid, do it.
Actually, you have to have so many patients a day. It's like some vial. Corona, you have to have 10 patients.
So putting orthopedic lens always goes in with a eye drop, lubricating drop. If you don't put it, then there will be air bubble in that reverse geometry thing. Nothing happens, it will fill up automatically. But if you put a drop, it is comfortable for the patient also. There are fluorescent rating.
Blue light.
I'm holding that.
Okay, thank you, sir.
Sustain Ultra gel, I mean viscous type.
Look down.
Look down, Chandrashekhar.
Yes.
tissues.
Light is amazing. Na?
I know.
Effect मस्त आता है.
Next time sir stock में लाना है आपको.
हाँ निकाल थोड़ा सा और. Because let it come down and then you will see the pattern. Damage होगा. Can you see the pattern? What is happening? There is a central touch.
But there is a slight loose.
हाँ.
So the flow is inside.
See? So it takes time to settle. थोड़ा सा dry करो और tissue paper से.
पूरा proper ring है.
You want sufficient tears only inside. See, beautiful. Now you can take a picture.
Oh, nice. एक मिनट इसको और थोड़ा लेते हैं then. हाँ.
She has the previous picture.
Only one or two people take a picture. Then we
So post it on that.
super picture. One is clear.
That
One is
is a myopia control orthopedic group. No, you are scleral. So I'll add you.
Please add us also.
Yes.
नीलम को भी add कर.
Yes.
एकदम poster picture है.
Very nice.
Super pattern. कोई वाला निकाल.
Scleral निकालते हैं. चलो. Okay.
This is related to you.
Okay, so now I'm removing the scleral lens first. Okay, so patient, when you teach patient, ask him to put it at 6 o'clock. I'm going to remove it from the 12 o'clock. I'll tell you the reason why. Look down.
Okay.
नहीं नहीं सिर्फ
दूसरा आप खोलो ना तो बिठा
So what?
No, nothing. You just touch it. Okay. Put it on your finger and see how it happens. Put it on your finger and see what happens. Automatic step. Same thing नहीं, उसमें प्रेस करना पड़ता है. You have to create a system. हाँ वो. उसका भी फोटो ले लो. फोटो फोटो.
आपका फोटो. टिश्यू है.
हाँ वो सेट दे.
ठीक है.
So while keeping the lens, it is better to keep it dry. Okay. Bombay Hospital likes to see 120 patients ना refraction करना था. तो एक तो अंधेरा रूम में दिखता ही नहीं ना. You do one glow like this. हाथ डालो जो लेंस आया वो न्यूट्रलाइज हो जाए. Of course वो कैसे ही इतना ना फोटो के निकाला है इसका. Okay, everybody saw. Shall I remove this?
Yeah, जी. इसको भी
Thank you so much. Ajit, थोड़ा सा मला लाइट दाखव. टॉर्च.
इसमें डायमीटर सबका सेम है.
It won't get.
Yeah, right. But otherwise, so you said the first diagnostic approach is when you said HUID का 90%. At present in this EX, all our centers are 10.6 only. But routine when you are selecting with the trials.
I don't do trials.
That's
Feel it. Pass it off. Feel it. Pass it on. Don't break it. Very nice. Amma is a great.
ऐड करने को बोलिए. हाँ मैं उसको मैसेज करूँगी.
आप मेरे को मेरा नंबर डालो भेजो. हाँ तो पास इट. हैंडल किया है लेंस. फिर भी एक बार देख ले. ये डाला था तेरे आपने. उसको कितना सॉफ्ट है करके दबा के नहीं देखने का.
Yes.
Do that. Semi soft है?
Yeah.
Soft है.
Then they have two half lengths.
Yes. हाँ.
सर ये हैदराबाद वाला नहीं है ना?
हाँ?
ये हैदराबाद वाला
हाइड्रापेक नहीं है।
Everyone, who wants to say?
This is which one?
Right? It's very thin layer, but you can.
I had done one shell in my
They're happy with that.
I just forgot.
This orthopedic technology is time tested, but RGT material is always better than soft. Yeah. Johari has a soft orthopedics. This is XM. XMG. See, if you tell me, looking at one picture, I don't know what it is. So you have to give me full information, then I can comment. And they also have XMG. How do I know what is XMG? If you know the diameter, then we can. We call it brand diameter, brand Johari is a totally new concept. Which one have on yes.